A very good morning, students, and all those who are viewing us today on our YouTube channel, and welcome you all to our final dash for the subject of ophthalmology before we head towards NEET PG 2024. So I'm indeed glad to meet you all today on this session. And before we jump right to the session, I would like to introduce myself. I am Dr. Niranjan Karthik, your ophthalmology mentor for Medico. So before we go ahead, I just wanted to give you a brief outline of what we are going to see today in this session, and also a little bit of idea of how to approach the subject of ophthalmology for NEET PG and INI-CET. So ophthalmology, being a short subject that we see in our third year MBBS, is often given adequate but not underweighted weightage for NEET PG and INI-CET. So roughly around 5 to 6 questions minimum is asked in and around the subject of ophthalmology, and often you must know that it is related to basic sciences, like to some extent anatomy and physiology, and in combination with other subjects like medicine for cases of neurology, etc. So there is always a mixture of subjects as far as the questions go, but let's not bother about all of that. We have to make ourselves very strong in a few concepts which are core to the subject of ophthalmology. So what did I do? I analyzed the previous year question papers, and I came to understanding of a particular trend where they are focusing pretty much on the basics and the core of ophthalmology topics. Like if you ask me, cataract, glaucoma, neuro-ophthalmology. Like I mentioned, neuro-ophthalmology is one subject which has a very good connection with anatomy, physio, and also with neurology in general medicine. So that is another area which is focused upon. And optics and refraction. They always say optics and refraction is the bread and butter of every ophthalmologist. So prescribing glasses is a very crucial part. So what have I done here is I've tried to compile the questions which pretty much match with the trend of what is usually asked in such topics, right? So more emphasis on more important high yield topics, and the less important ones are also touched upon here. So as we discuss forward, it is going to be in a question answer format, questions that have been taken out from the previous year papers. But what I will do is also touch a little bit upon the other topics which are related to that question, so that we get an overall gist of all the high yield information that is required to face NEET and INI-CET, NEET PG, right? So with that introduction, let us move on to the first question. Right. I hope you're all with me. So feel free to post your doubts and questions in the chat box, which I'll be taking it up in the meanwhile while between questions. Okay. So in case you have any doubts or clarifications, I'll be happy to take them up. So let us look at the first question for today. A patient comes with a history of penetrating trauma and diagnosis of sympathetic ophthalmitis is made. Which of the following will be seen? Now you see, the pattern of questions is not always about a clinical scenario and they ask you to diagnose. So as we discussed in undergraduation in our MBBS time, it is not always about the diagnosis. It's about your approach to a diagnosis. So to exemplify that, here we have a question which gives us the diagnosis already. What they want you to know is a little bit more about the diagnosis. So they're saying which of the following will be seen? Acute anterior uveitis, chronic anterior uveitis, pars planitis, and panuveitis. So you got to know a little bit about this sympathetic ophthalmia in order to be able to answer this question. So the right answer is panuveitis. Let us see why. Sympathetic ophthalmitis is a rare and a serious condition which often occurs as a complication of penetrating eye injury. It is characterized by inflammation in both the injured eye and the fellow uninjured eye. Okay, so what I want you to understand is the injured eye is often the affected eye, which is going to release sequestered antigens. So all the important elements inside the eye, like the intraocular lens antigens, they are all embryologically sequestered antigens, which means they are not exposed to our immune system at the time of development. So the moment they get exposed to our immune system following trauma, let us say there is a breach in the lens capsule during trauma. So what happens? This breach will lead to exposure of this sequestered antigens, and the immune system thinks it's a foreign antigen against which it will start eliciting an immune response, because of which the antigens which are present in the normal eye, which is the sympathizing eye. So sympathizing meaning it is actually sympathizing with the eye that is injured, so it's called as a sympathizing eye, right? So that eye starts eliciting response and it develops pan uveitis. So always remember, what is pan uveitis is when all the coats of the eye, that is the inner coat, middle coat and the outer coat, that is retina, choroid and the sclera, all three get involved in the immune response. That is when it is called as pan uveitis, right? So sympathetic ophthalmia, to come to a diagnosis of that sort, it is important that both eyes are involved. Until that happens, you can't diagnose a case of, you can't label it as sympathetic ophthalmitis. Now, when can this happen? Sympathetic ophthalmitis has been known to occur even like 2 years or 3 years post the episode of injury. Now this is important. Why? Because as ophthalmologists, it is important for you to keep them in follow-up and not to forget to examine the contralateral eye, because often, when a person comes to you with injury, you always focus on that eye, try to recover vision in that eye. But it's more important to not miss out on the other eye, because in many situations what happens is that will be the only seeing eye for the patient. So this is the core concept that I want you to understand about sympathetic ophthalmia, right? So the link between the pan uveitis and sympathetic ophthalmitis lies in the fact that an initial insult to one eye, okay, can trigger an immune response that affects both eyes. If an eye with the pan uveitis experiences significant inflammation and tissue damage, it releases antigens. I told you they are called as sequestered. Sequestered meaning they are not exposed to the immune system at the time of development, embryological development. Okay, so this can lead to sympathetic ophthalmitis, right? Yes. So this can result in inflammation in both eyes, leading to vision problems and even blindness if not properly managed. So I hope it is clear to you now, right? So one more condition exists that is called as VKH syndrome, Vogt-Koyanagi-Harada syndrome. I'll just write it out here for you. Now, why am I mentioning this here is because this is a very close mimicker of sympathetic ophthalmitis. Okay, Harada, right? So this Vogt-Koyanagi Harada, what happens is it is also a type of pan uveitis. It has anterior, intermediate, and posterior, all three involved. And important is this is not because following trauma. This is autoimmune. Okay, so some patients have a genetic predilection in whom you see this VKH syndrome. The manifestations are almost very similar. So here again you have panuveitis, and that again has involvement of retina, choroid and sclera. But most important, what you need to know is this is not following trauma. So when there is no history of trauma, labeling it as sympathetic ophthalmitis is wrong. Okay, so let's briefly look at the difference between the two, because sometimes a very similar scenario with all this panuveitis without the history of trauma will be given. So you shouldn't jump to sympathetic ophthalmitis. So remember, Vogt-Koyanagi-Harada happens in 20 to 50 years of age, often in the Asian and black races. See, the penetrating trauma is absent. That is the most important point I want you to remember here. Here it is almost always present. Skin changes, CNS findings and hearing dysfunction. This is a very classical feature of VKH syndrome. Understood? So what are the skin changes? Skin changes, you will see vitiligo. Make note of this because these are all the kind of questions you will get as a clinical scenario, right? CNS findings, you get meningismus. Meningismus. Okay, hearing dysfunction, you can get sensory neural hearing loss or tinnitus. So when a patient presents to you with these, along with the complaint of diminution of vision, you should always keep VKH syndrome in the back of your mind, right? Serious RD. See, I told you the visual disturbances in VKH is much more because of the involvement of retina in the form of retinal detachment, right? And pathologically, now clinically they may look very similar to each other. So what they have identified after detailed pathological examination in patients who had VKH over after the post-mortem examination is that the choriocapillaris involvement is not seen in case of sympathetic ophthalmia, whereas it's frequently seen in VKH. So I hope it is clear how you should differentiate the two syndromes which look very similar in presentation. One more point I want you to know here is this name. So this is a very common name that is, asked in many of the one-liners, and this is a very characteristic finding that you can see, which is actually clusters of epithelioid cells containing pigment lying in between the RPE and Bruch's membrane. Okay, so this feature is called as Dahlen-Fuchs nodules, and remember Dahlen-Fuchs can be identified or seen in both VKH and sympathetic ophthalmia. So it is not specific to one, but remember this name for one-liners in case they ask in NEET PG. Right. So I hope now we have an idea of this. I'll also touch a little bit upon what are the different types of uveitis that you need to know. So uveitis, okay, based on the location, it is anterior. So like I said, it's important to understand the basics before we go ahead too much in detail about all those syndromes and all that. Okay, intermediate and posterior. When all of them are involved, it is called as panuveitis. Okay, now anterior is iritis, where there is involvement of the iris, or iridocyclitis. Intermediate is when it is called as pars planitis. Now, to get technical about it, pars planitis is often something that is told about when you don't have a cause, that is idiopathic. But when it is having a basic pathology related, like conditions like multiple sclerosis, tuberculosis, all of them can cause intermediate uveitis, and multiple sclerosis is a non-infectious cause. Okay, so that is why I mentioned it here. When it is idiopathic, it is called as pars planitis. Otherwise, it is simply called as intermediate uveitis. Now, what is posterior uveitis? When there is involvement of retina and choroid and sometimes sclera. Okay, now here another important point I want you to know is posterior scleritis on B scan. B scan is the ultrasonic examination of the eye and the codes of the eye. To some extent, we can also see the intraorbital structures, okay, like the extraocular muscles. So that you see the classic T sign. Now this again is a very important point that I want you to remember. So T sign on B scan or ultrasonic examination of the eye is seen in posterior scleritis. What is this T sign? Basically a collection of fluid under the sclera and along the optic nerve, which sees like a T. So this is the posterior coat, right? This is the optic nerve. So there is fluid collection around this area. Okay. So that is called as T sign. Okay. So this is another important point I want you to understand. And one more thing is, one important point is T sign that I mentioned. Second is you should know what is the classification. Okay, classification for severity of anterior uveitis. Okay, anterior uveitis. So let me just get rid of this. Okay, so in anterior uveitis, it's called a Sun classification. Standard uveitis nomenclature. Okay, this is another important point that I want you to remember. Two more things. One is this one, the other is, let us say this is the iris, right? In uveitis, there are two types of uveitis. What are they? Granulomatous and non-granulomatous depending on the etiology. Conditions like tuberculosis, leprosy, etc., they cause granulomatous inflammation, whereas non-granulomatous are things like cat-scratch disease, etc. So they are all non-granulomatous, even anterior uveitis like HLA-B27 associated uveitis, right? So what are the features of granulomatous? Are two important iris nodules. One is Koppi and other is Busaka. These two names are important. Kopis is around the pupillary margin, Busakas is in the stroma of the iris. Okay. Now, important thing is these are features of granulomatous. Right. And apart from that, one more important point is Berlin's nodules. These are not seen on the iris, but seen in the anterior chamber angle. So, anterior chamber angle, and seen in which condition? In leprosy. So I hope it is clear to you now what are all the different manifestations of anterior uveitis. Okay. Now just to touch upon the intermediate uveitis. Okay. So intermediate uveitis is when the pars plana that gets inflamed. Okay. So in that, one important point or a couple of important points I must say. Intermediate uveitis. I told you the most important non-infectious causes multiple sclerosis. What all does it cause? Snow banking or snowball opacities. All these are very potential questions that can be asked. Okay, these are all important one-liners, or they can be a small part of a big clinical scenario. So these are all clues you need to pick it up from a clinical scenario, which is often the trend these days in the pattern of questions that's asked in NEET or INACT. Okay, so snowball or snowball opacities or snow banking, they are all vitreous exudates which are seen in the inferior aspect. So what happens? Intermediate uveitis exudates. The cells in the vitreous, which are actually inflammatory cells, they collect together and settle to the bottom of the vitreous, and there they look like snow banks, like deposits of snow, and that is called as snow banking or snowball opacities. One important point here is that you should know the cause of diminution of vision. Patient can tell you nothing of this, but can come to you with simple diminution of vision. Cause of decreased vision is not vitreous cells, but it is the cystoid macular edema. Okay, so whenever there is intermediate uveitis, you should always look for cystoid macular edema, which is often associated with this intermediate uveitis. Understood? So cystoid macular edema is the cause of decrease in vision in case of intermediate uveitis. So you treat this, the diminution of vision will definitely improve. So I hope we've touched upon in detail about the different types of uveitis, right? So these are some of the important high yield points in the topic of uveitis that you must know. Okay. And lastly, one important point is HLA B27 uveitis. So this HLA B27 is a type of subgroup of uveitis where you have anterior uveitis in often young males. Often, not always. Usually in the middle-aged or young people you get this. So what are the causes? Ankylosing spondylitis. What do the patient complain? Back pain. Okay. Second is reiters. Okay. Third is psoriatic arthritis. So they have nail pitting, etc., which will be knowing in derm, right? So psoriatic arthritis. So also remember, those who have nail pitting have an increased predisposition, they say, of getting uveitis. and lastly IBD. Okay, so these are some of the causes of inflammatory bowel disease. So these are some of the causes and often Crohn's. Causes of HLA-B27 associated uveitis, which is a very common cause of anterior uveitis in young to middle-aged people. I hope this is clear. Okay, so I think that's enough about anterior and the different types of uveitis. Okay, let us move on to the next question for today. Yes, this is another question we have. Extra set of eyelashes emerging from the posterior margin of eyelid is known as A. Distichiasis, B. Trichiasis, C. Tylosis, and D. Madarosis. So the answer here is pretty much straightforward. There's nothing you need to rule out options or anything. It's a straightforward question and a straightforward answer. So the answer is distichiasis. Okay, now let me explain every condition in detail because any one of them can be a question, right? So this condition referring to where there is an extra row of eyelashes behind the gray line. I'll tell you what this gray line is and its significance. It's called as distichiasis. It is a condition in which the eyelashes grow due to improper differentiation of pilosebaceous units. Okay, I'll explain that. So they abnormally differentiate and emerge from the meibomian gland openings behind the normal lash line. These extra lashes cause irritation and damage to the cornea conjunctiva, leading to eye discomfort, redness, tearing, and sensitivity to light. What are the treatment options? You manually pluck it out, which is called as epilation. Okay, this procedure is called as epilation. One more option is cryotherapy and various surgical procedures. So basically you try to remove only the hair, it is epilation. When you try to excise that portion because it is happening recurrently. Okay, so in recurrent cases what they do, that particular area is excised and sutured up so that it cannot recur. That whole pilosebaceous unit is removed out. Okay, so that is surgical excision. I'll show you this picture which will make you understand better. See here, okay, here this is the actually you're looking at it in the sagittal section. You're cutting vertically in the eye and you're seeing from the side, correct? So this is your iris and this is the lid. So here is the anterior lid margin. Okay, so in the anterior lid margin is where you have the lash line. So remember students, anatomy of the lid and its clinical applications can very much be a potential question. So here we are trying to address that topic. Okay, so anterior margin, what you see here is where the lashes grow and that is the lash line you are seeing here. Understood? Now just behind that is this. Can you see this structure here? So this is the meibomian gland. And if you notice here, I'll just erase this so that it becomes a little clear for you. Yeah. So here, can you see that this meibomian gland is a part of this? This is called as tarsal plate. Okay. So remember that the meibomian gland is actually a part of the lower part of the tarsal plate of the upper lid. Okay. So that is where the meibum or the sebum along with the gland tears that get secreted. Okay. So that is important. And I'll just touch upon a few conditions here. Okay. Chronic granulomatous inflammation of this chronic granulomatous inflammation is chalazion. Okay. Whereas if that gets infected, it is stye. Not stye, it is hordeolum, I would say. I'll tell you the difference in a later question. But just know that this is, if it gets infected, it is hordeolum. Okay, so I hope now you know a little bit about the lid anatomy, right? Now let us look at the abnormal parts. See this picture. Instead of turning outwards, this lid is turning in, this lash is turning inwards, right? So this is called as misdirected lashes or trichiasis. I hope it is clear. But here the meibomian gland is still normal. It is not having any abnormality in its structure. It is only the normal lash line, one of the lashes or a few of the lashes are turning inward and they are going and touching the cornea. So chronically, if something like that, every time you blink or you look around, if there's a hair that is going to keep scratching the cornea, that will lead to damage to the epithelium and photophobia. Why photophobia? Because just under the corneal epithelium, right, there is a subepithelial plexus of nerves, and that is what is responsible for corneal sensation. To keep it in a resting state, the corneal epithelium above it should be intact. That is why any abrasion or anything, the patient finds it difficult to even open the eye, because for a normal amount of light that is entering the eye, this nerves gets stimulated and that results in photophobia. Understood? So now here you see it is normal. There is no change in that, but these lashes are turning inward. This is called as trichiasis. Clear? Now, let us look at another condition or the answer to our question. Can you see that this hair follicle itself is arising from here? It is not this which is turning inward. No, it is a new lash that is arising from the meibomian gland. That's because it is differentiated into a lash rather than just a meibomian gland. So I hope it's clear. And also remember, this whole pilosebaceous unit is actually from a common neural crest cell derivative. So instead of just differentiating into a pure meibomian gland, it is also developed into a lash. Clear? So that is called an extra row. Now I'll tell you what this gray line. This gray line is actually the line which is between these two. This is not clearly seen in this section, but it comes somewhere here. Okay, it will be throughout the entire length of the lid, and that is actually a part of the, or I should say palpebral part of the orbicularis oculi muscle. This is the voluntary muscle which is controlled by seventh nerve, right? Which is responsible for closure of the lid. So this muscle, okay, is actually called as muscle of Riolan. A named thing, it's an eponym, so possible that they may ask. But beyond this, why should you know about it? This muscle, every time you blink, that is why they say decreased blinking leads to dry eye. Of course, because of evaporation is one major reason. This is another thing. Every time you blink, this muscle of Riolan, it presses on the lacrimal pump and also on these meibomian glands. Lacrimal sac is there, right? So these meibomian glands are going to get squeezed every time you blink. So that ejects out a little bit of water, which every time happens when you blink, right? So this is important for that, and also to keep the lid opposed to the globe. So when you have a seventh nerve palsy, okay, this muscle becomes weak in case of a facial palsy, right? So what does that lead to? The lid, especially the lower lid, okay, which is not shown here, there is here muscle of Riolan, it tends to go in or sorry, come out or go in. That leads to two important conditions. What are they? Entropion and ectropion. So I hope now you've understood the point what I'm trying to convey, right? So ectropion or entropion. See, there are multiple reasons why entropion and ectropion can happen. Okay, one of the most important causes is senile, or it is called as involutional. So this is important because this is one of the most common causes of entropion, ectropion. What happens? There is lid laxity because of loosening of all the tissues around the eye with age. But this is just to touch upon this lid conditions so that you have an idea as to why these things happen. So now I want you to understand that entropion and ectropion also can happen because of weakness of this muscle. Okay. So I hope we've touched in detail about the lid conditions. Okay. So distichiasis is different from trichiasis. I'll also touch upon tylosis. Now, what is tylosis? Tylosis is basically thickening thickening of lid margin. Okay, that happens due to conditions of allergy, chronic allergy conditions, right? Eczema. Okay, so these are some skin conditions often that results in this. Madarosis is important. Okay, madarosis, students, is important in one way because madarosis refers to loss of eyelashes and also eyebrows too. Okay, so this can happen following conditions like chemotherapy. Okay, okay, but what is more important is there is something called as Queen Anne's sign, which is, this is the eye. So loss of lateral 1/3 of the brow, often seen in leprosy. Okay, so I hope we've touched upon the various points in association with the lid anomalies or lid pathologies. I hope it's clear. Right. Let's move on to the next question. The following eye movement will be lost due to injury to A, third nerve, B, fourth nerve, C, sixth nerve, D, seventh nerve. So we're talking about a cranial nerve palsy here, and they want you to know which is the uh, palsy or the problem which will lead to the loss of this movement. So whenever they give any such scenarios, this is at least relatively simple. Sometimes what do? They give a 9-gaze image. Okay, what is this 9-gaze image? The center will be looking straight, then this will be looking like this, then this will be looking like, 9 images of different extraocular movements they will give. Okay, so why am I saying this is because I want you to understand the approach of how to do it. That is most important. See, answering one question is not a big issue, but being able to approach it in the right way is most important. Okay. Right. So let's deal with this question. I'll take you through the approach. So in this image, what are you seeing? You're seeing that the eye is looking inward and upward, correct? Inward and upward, right? So it is looking supero-nasally, right? So supero-nasally is the right way to describe it. So, or in another way, in this condition, okay, it is levo elevation. The right eye is looking to its levo elevated position. Remember, there are three things. One is a primary action, okay, secondary action, and tertiary action. Don't bother too much about tertiary, but at least know primary and secondary. Primary action, what does it mean? It means that that particular movement is predominantly or mostly done by that particular muscle only. For example, elevation, it is superior rectus, primary function is elevation. Okay, abduction, lateral rectus is primary function is abduction. So do you understand what I'm saying? So primary function is that which is important for that particular muscle, right? So here we need to know which are the muscles which facilitate adduction and elevation. Am I right? So let me go erase this. Always I'm going to tell you some important thumb rules which I want you to remember in order to decode, I would say, these extraocular movements. Remember few lines, okay? Superiors are intortus. So these are, I would say, some strategies or fundas to know in order to understand the movements and quickly apply them. See, knowing is one thing, being able to apply in a short period during NEET exam is another, right? So superiors are intortus, meaning superior rectus and superior oblique are intortus. Remember, second rule, in adduction, Okay. Obliques work. In abduction, recti work. I'm also touching a little bit upon squint while we're dealing with neurophthal because they are all interconnected. Okay, right. Next point which I want you to know is in lateral and medial rectors are isolated. Okay, they are not going to do anything with elevation depression, whereas recti do, right? They are all vertical muscles. So here, in case of adduction, I told you only obliques work, and obliques, remember, are opposite, O for O. So superior oblique causes depression, whereas inferior oblique causes elevation. So remember it like this. This is another thumb rule. Obliques are opposite. What do I mean by this? I mean to say superior means it doesn't cause elevation. Superior oblique causes depression, whereas inferior oblique causes elevation, right? So these three rules will help you understand and apply the points very quickly in cases of asking you for a which pathology, right? So here, here the eye is adducted, right? So in adduction, which are the muscles? Obliques, correct? So the eye is elevated, that means the muscle that is working is inferior oblique. And to able to cause adduction, which is the muscle? Medial rectus, right? So these two muscles are supplied by, and yeah, we must all be knowing this LR6SO4, this some chemical compound sort of a formula, right, which for us to easily remember. So lateral rectus is supplied by 6th nerve, superior oblique is supplied by 4th nerve, correct? Rest are all supplied by 3rd nerve. Understand that. So here what I'm trying to say is this medial rectus and inferior oblique are supplied by 3rd nerve, and the question is the following eye movement will be lost. So they're asking in which nerve palsy it's lost. So answer here is 3rd nerve. So with all these basic principles, you will be able to answer any nerve palsy question that is asked to you without having any second thoughts or doubts, right? So the image depicts the extraocular muscles which are responsible for eye movements. Each cranial nerve plays a specific role in controlling, we know that. Okay. Option A, that is 3rd cranial nerve palsy, is responsible for innervating several extraocular muscles. We know this formula now, right? So we don't have to mug up anything else. Okay. If there is a palsy or dysfunction of the 3rd cranial nerve, it can lead to weakness or paralysis of these muscles, resulting in limited or lost eye movements as depicted in the image. So I hope this part is clear. Now this is a very common question that is asked in our neurology related points. I was telling you, right, neurology and neurophthal are not exclusive because eye itself is said to be a derivative of the brain, right, extension of the midbrain. So what I want you to know here is that these syndromes, Weber syndrome, Claude syndrome and Benedict syndrome. Okay, so there is one more Northnagle also, which is not mentioned here, which is about the posterior part. So the reason I put this here is because many of these can just come to you as clinical scenarios and all of them may involve 3rd nerve. Okay, so the reason is neurophthal is often a very easy way of identifying the exact location, and nowadays we have MRI, CT and everything. In those days when these were not easily available, clinicians were so good that they could identify where the problem was just based on clinical signs, and they knew these things in depth to be able to do that, right? So here oculomotor nerve, and yeah, one important point I want you to know in all these pictures is that all of them are at the level of midbrain, correct? So in Weber syndrome, along with the 3rd nerve involvement, okay, there is corticospinal and corticonuclear, because of which there is contralateral hemiparesis. So if they say that the patient is having a right-sided 3rd nerve palsy and a left-sided hemiparesis, blindly you can go for Weber syndrome. Now, apart from the 3rd nerve palsy, like now we know how to identify 3rd nerve palsy. They have ptosis. Yeah, I forgot to mention, sometimes the only clue they give you is ptosis. And this can also mean a 3rd nerve palsy. How? because third nerve supplies an important extraocular muscle which is not often, often missed when you ask maybe an ophthalmology undergraduate attending clinics, what are the extraocular muscles? They often miss this muscle of LPS, right? So this LPS is levator palpebrae superioris, which is responsible for keeping the lid up and not allowing it to droop down in cases of ptosis like we see, right? So oculomotor palsy can actually mean that the patient has ptosis. Okay, that is important. Along with that, the red nucleus and the cerebellothalamic fibers that results in contralateral tremor. Okay, you know that the decussation happens at the level of medulla and hence the contralateral nature persists because all of this is happening above the decussation. Correct? And next is Weber plus Claude is seen in Benedict. Okay, so in Benedict syndrome, combination of Weber plus Claude. Okay, so this is a compilation of all the midbrain syndromes which are known to happen along with the third nerve palsy. Correct. So that is why I have included them here. Now I'll move on to another very important point that I want all of you to know. Okay, this is crucial because this again can be a part of the clinical scenario with a twist. So here, what are they saying? What am I saying? Here, sometimes they'll give you a question like this: a middle-aged or an elderly male presenting to you with ptosis and diplopia, etc., etc. But when you shine a torch on the patient's eye, which is involved, the pupil will still be reacting. So, whenever you see a third nerve palsy question, your mind should immediately ring a bell. See whether they have made any mention about the involvement of pupil or not. This is a core concept in third nerve palsy. Okay, I'll explain it to you. Now, anatomy of the third nerve is like this. It has two blood supplies. One is in the core, one is in the periphery. This core, okay, is vasa nervorum, which supplies the major part of the third nerve, which is in yellow. Can you see here? On the other hand, this small strip of green color, which they mentioned here, is the pupillary fibers, okay, which is also traversing there, but it is peripheral in position. That is more towards the outer aspect of the third nerve. So why is this important? Because the vasa nervorum, which supplies the entirety of the third nerve, is not going to affect this pupillary portion of the nerve, because that is also supplied by this blood vessels on the pia mater. Okay, so what does this have to do with any of what we are saying? If there is an external compressive problem, okay, so like a tumor or a raised intracranial pressure, things like that, like in case of midbrain syndrome, there is stroke. Okay, so there is accumulation of blood or anything that is compressing onto this outer aspect, pia mater aspect of the third nerve. Okay, in that case, you will have involvement of pupil. That is, if you see in these images, all of the places they mention mydriasis. They mention mydriasis, right? Any compressive lesion will have mydriasis, whereas any uh, microvascular condition like diabetes. What is diabetes going to cause? It is going to cause microvascular complications, correct? So this microvascular complications will not go affect the pupillary fibers, and hence the pupil is spared. Remember, spared, or it's called as pupil sparing third nerve palsy. Can you imagine? Just by knowing whether the pupil is involved or not, you can come to a very clear conclusion whether it is a medical cause or a surgical cause. That is diabetic control or neurosurgery to remove, or an MRI to be done in order to find out what is compressing it and further go ahead with neurosurgery. It is that effective a clinical sign. That is why I have mentioned it here with the picture. I hope the concept is clear now. To differentiate a compressive third nerve palsy to an ischemic third nerve palsy, this is what I wanted to make it very clear to you, because this is a very, very important concept that I want you to know. Right, so coming back to the basics of our third nerve, this is the course of third nerve, starting from the oculomotor nucleus, We've just discussed about the various syndromes, right, which can happen in this midbrain part. And remember, these are the several lesions or sites of the lesions that can happen with the third nerve. And remember, as you go from the midbrain to the eye, the nature of incompleteness increases. For example, let me say that there is a intra-orbital tumor compressing onto the third nerve like this, right? So the number of muscles that is involved will be much lesser because the nerves that's supplying the LPS and everything will leave before that. So they may not have ptosis, but they may have difficulty in elevation because it supplies the inferior rectus, correct? So based on the clinical symptoms itself, you can identify the site of lesion. That is what I wanted you to know about this. I hope it is clear. So now one small change in the question let me make in order to explain another condition. Let us say instead of this eye not being able to look up, it is not being able to look down like this. In fact, that is more likely of a question because that is a very classical picture you see in case of a fourth nerve palsy. Is it clear? Excuse me. Yeah. So what do you see in a fourth nerve palsy is the superior oblique muscle. I told you, right? Obliques work in adduction and obliques are opposites. So in adduction, the only muscle which can cause depression is superior oblique. So this is also called as copying muscle. Okay, copying muscle. Why is it copying muscle? Look at my eyes. So if a person in the exam wants to look at the next person's paper, okay, the right eye, if it wants to see anything at all, should adduct and look down, right? So that is actually brought about by the only muscle that is superior oblique, and that is the only muscle that the fourth nerve supplies also. And hence remember, superior oblique palsy is classically seen in fourth nerve palsy. Okay. There are other causes also. There is a condition called as Brown syndrome. Okay, so let's not get into the details of that. But superior oblique palsy is almost equivalent to fourth nerve palsy. So the eye can also be looking in and down. Clear? So one more point is, instead of giving you this image like this, they can see the patient's eye is okay out and down, okay, or I would say down and out. They can say that the patient's right eye is looking down and out. Okay, what does this mean? This basically means third nerve is gone. Okay, and when the third nerve is gone, what happens is the eye is now being acted upon by lateral rectus and it is also acted upon by inferior oblique, right? So inferior oblique does what? Depression. Lateral rectus does what? Abduction, correct? So these two actions will persist and that will lead to what we call as down and out appearance of the eye. So I hope it is clear to you now, right? So this is in I would say detail about third nerve palsy that I wanted you to know. Okay, right. Let us move on to the next question. Next question. A photo stress test is used to differentiate the lens and cornea function, retina and vitreous function, optic nerve and macular function, cataract and glaucoma function. So which of the following? Cataract and glaucoma condition, I would say. So the right answer here is optic nerve and macular function. Okay, I'll explain what is this photo stress test before we go ahead. Okay. So photo stress test helps in differentiating between the optic nerve and macular function. How is it done? The best corrected visual acuity. Okay, it's called as BCVA. Okay, first you record it for one eye. Okay, so once you record it, we need to shine a bright light into the eye for 10 seconds, and what you need to record is the time for vision to recover within one line of best corrected visual acuity. That is, if the person is able to read 6.6, okay, up till when he can read 6.9, the time is to be recorded. Okay, so I will deal with this in detail. Let's just go for a short technical break before which, after which we'll come back to this question. Welcome back after the technical short break. So now we'll continue with our explanation of this photo stress test. So like I mentioned, we are going to look at the BCVA, okay, of the patient, then shine the light for around 10 seconds. It should be quite bright. So the concept of retinal bleaching happens, okay. What is this retinal bleaching? You're going to bleach all the rods and the cones of the photoreceptors they have. And remember, the rods and cones are present in the entire retina, no doubt, but most of it in its highest density, that is number of cells per millimeter square, is actually maximum in the macula and more so in the fovea. Fovea is basically the center of the macula, right? So when you test the efficiency of these rods and cones to fight back or bounce back after they've been completely depleted of the photoreceptors, means you're actually doing it where you're going to check the function of the part of the eye where these cells are maximum, correct? So that is why these are an indicator of macular function, or in short, they, together with other tests, this photostress test is a compendium of macular function tests. Okay, right. So if the macula is affected by any condition as mentioned here by ARMD, which is age-related macular degeneration, macular edema, macular dystrophies, okay, the recovery time, okay, after the photostress test exposure may be significantly prolonged because the rods and cones are affected by some pathology. Now they're not working up to their full maximum efficiency, because of which this delayed recovery suggests an impaired macular function and indicates a macular disease. Clear? So you want to identify whether the macula is normal or not. You don't have, at least in those days, they didn't have all this advanced OCT and scans. So simply by shining the torch and observing for the time it took to recover, we could come to a fair idea as to whether the macula is up to the mark or not. Now, why do we have to worry about all these things? Before that, I'll also tell you what this optic nerve diseases is about. So in case of involvement of optic nerve, like in conditions of optic neuritis, ischemia, optic nerve degeneration, etc., following trauma, right? You know, right? Anterograde and retrograde degeneration. They primarily affect the nerve fibers carrying the visual information from the retina to the brain. These conditions, macula is not affected, it's relatively spared, and the recovery time after the photostress test is pretty normal. So that means it is not an optic nerve problem but a macular disease. Why do we have to know about this photostress test or any macular function test for that purpose? See, the vision drop or a decrease in vision could be because of multiple reasons. When the patient presents to you and the patient wants to know whether they are going to get a good visual recovery following their cataract surgery, okay, you need to prime them or make them aware of all the pathologies in the eye which are contributing to this vision loss, and let them know that post surgery, in case they have any of these problems, okay, their photostress test will come out to be positive, and they are mentally prepared to undergo the cataract surgery knowing that post the surgery they are going to have some amount of visual disturbance which may need treatment further for the macular disease for them to completely improve. So this is important from a very clinical point of view, especially before cataract in counseling the patient. Right. We need to know that, right, before us jumping to do the cataract surgery, correct? So let us look at what are all the macular function tests. See, basically they are divided into two groups. One is when there is clear media, when you are able to visualize the retina, or the opacity in the lens is not too bad to allow enough light. Okay, in that cases, simple tests like visual acuity, color vision, okay, we just discussed about photostress test, Amsler grid, very important. See, whenever there is any problem with the central vision, okay, central vision is what is carried out by our macula. Okay, so not only decrease in the acuity, sometimes there could be an alteration in the quality of vision. Okay, now what does this mean? Change in the shape. Okay, change in shape, that is called as metamorphopsia. Okay, now this metamorphopsia, what is it? It is basically a change in the shape of the things that we see. A square board may look more like a parallelogram and things like that. Yes, it is very much possible, and that is picked up best by Amsler grid. What is Amsler grid? Basically, there are 7 types of Amsler grid, but I'll keep the most common one here. They have multiple small squares like this, okay, like this, and there is a central dot. So the patient looks at this central dot and lets us know if any of these lines appear wavy or any portion of this goes completely missing. Okay, so that is called as Amsler's grid. It helps us identify two main things. One is metamorphopsia, where the lines may look wavy, and one more is scotoma. Scotoma is a part of the visual field turns black due to various reasons. Now, scotoma can be seen in case of glaucoma, etc. We'll be discussing that, but that is another thing which can be identified using Amsler grid, right? So 2-point discrimination is basically being able to identify two objects which are placed at a particular distance, around like 1 millimeter or 2 millimeter apart at a particular distance from the eye. That again is a very much a function of macula. Microperimetry is a test which is for the central vision, and FFA and OCT. I told you these are two investigations which are going to be like scans. FFA is fundus fluorescein angiography, where you inject a dye and look for its circulation within the retinal vessels and observe for any problems in the macula. Remember, macula, okay, has a foveal avascular zone. Okay, now why is this important? Because in FFA, as the central portion, right, of the macula that is not having any blood supply, it's called as foveal avascular zone. Okay, so now this foveal avascular zone can sometimes have liquid, or liquid I would say fluid collected underneath it, which can take up the stain. That is where what you diagnose as macular edema. Clear? So this is important. So macular edema is something that you can identify using FFA. Now, if the media is too, the media, or I should say the lens is too densely cataractous, you're not able to see inside, then you use these function tests in order to say, okay, post surgery, your recovery of vision will be quite good. One is laser interferometry, which is again a photo based test. Entoptic phenomenon. I don't know if you've observed, when you gently press your eye inside, anybody does, so you'll be able to see some stars or some lines, okay, in the black background, something like coming to you. Or if you see a bright source of light like a torch and then close your eyes, you will be able to see some lines. Those are actually the blood vessels, okay, blood vessels and anything else in the vitreous, like say vitreous opacities, etc., which are visualized by the patient himself or herself. To be able to do that, your macula should be in good condition. So that is again a very good indicator of macular function. Okay. Then ERG, EOG and VEP are together called as electrophysiological test. So I hope I've touched upon the various macular function tests, etc., in order to judge what is the quality of vision that the patient is going to achieve post a simple cataract surgery, uncomplicated cataract surgery. Okay, so this is the crucial point that this particular set of tests helps us in understanding. Okay, let's move on to the next question. Which of the following refractory condition, okay, refractive condition, okay, is depicted in this picture? Now in this picture, let's see the options: A, presbyopia; B, myopia; C, astigmatism; D, hypermetropia. Now I told you optics and refraction very important from NEET perspective or INECT perspective. Okay, so what you're seeing here is actually different types of images A to G, okay, that will be formed on the retina, okay, by an eye which has this type of a profile. Okay, so we need to understand that refraction is basically deviation of light rays the moment it enters the eye, correct? So what are the two main important refractive surfaces in our eye? Remember, our eye overall has a power of plus 60 diopters, because this plus 60 is actually a lot. Imagine light rays are coming from infinity, okay, and you want the whole of the light rays to immediately take a converging path. Why? Because the eye has to focus everything on this wonderful screen that God has given us called as the retina. Okay, so to be able to do that, the eye has to be a very, very strong, powerful, has to have a very strong, powerful converging optical mechanism, correct? So that is why it has a power of about 60 diopters lens, 60 diopters, okay? And as you can see here, it is a plus lens. So it is actually working like a biconvex lens. But here, this power is divided between two important structures. One is the cornea, the other is the lens. So here, the cornea contributes to about 2/3, that is 42 to 44 diopters of this power, okay. Lens contributes to 16 to 18 diopters of this power. Remember that this distance, okay, between the point where it enters the eye to the retina is only 21 millimeters roughly. It's only 2 centimeters. You can take a 15 centimeter scale and try to understand the actual size of the eye. Okay, so to be able to do that, these two are the structures which are most important. Now, when do you get refractive errors? Basics, hashtag basics, I would say. When this eye fails to be able to focus the light onto this retina for whatever reason, okay, that is when this refractive error comes, because the light rays are either getting focused in front or behind. So when they get focused in front, it is myopia. When they get focused behind, it is hyperopia. Understood? Now, as complicated as nature gets, the eye gets even more complicated. You see, light is going, this is, let's say this is the cornea, okay, light is going to enter from all directions, okay, and let us divide this cornea into multiple sections. Each of us don't have a very picture perfect, shaped, prolate shaped cornea. What is prolate is centrally steep and peripherally dense, okay. This is how our cornea is, peripherally flat. We have natural variations in the shape of our cornea. Lens pretty much is the same. It doesn't contribute too much to the refractive error, but cornea does. So there is, first point, there could be changes in the shape of the cornea. Secondly, the distance I told you, right, 21 millimeters need not be actually 21 millimeters. It can vary, and that variation can lead to the eye becoming shorter or longer. So from cornea to the retina, the length can vary. So that is the major concept that I want you to know. Okay, so these are the two variations which results in refractive error. Now, let's come back to the first point, that is cornea. In cornea, when there is a change in the refractive error, refractive shape, then that results in an unusual change at different meridia. That is, this part of the cornea may be different in shape from this part of the cornea, to keep things simple for you. Okay, so the vertical may be more steeper, okay, like this, and the horizontal may be less steeper, right? This is very much possible because nothing in nature is picture perfect, right? So that is exactly what you see here. I'll explain this image to you. See that you have to understand that they have taken rays emerging from two different meridia. Okay, this oval is the vertical meridia V, and this H is the horizontal meridia. Okay, so what you are seeing in pink color, can you see that this pink color is converging here itself, whereas this gray color is converging here. Understood? So when the refraction is happening differently in different meridia of the cornea, that results in what we call as astigmatism. So I hope I've made clear what is myopia, where there is focusing in front, hyperopia focusing behind the retina, whereas in astigmatism, the refraction in two perpendicular meridia or two different meridia, there are different types of astigmatism, they are happening in different amounts. This is all about refractive error properly if you want to understand. Now let's come to what is presbyopia. So this is the part where lens starts to contribute to refractive error. Understood? So I'll explain here. See here. So what is the muscle that controls the shape of the crystalline lens? So this is crystalline lens which is actually present in a bag, which is called as a capsule or the capsular bag. So God has given us the ability to automatically adjust the focus of this crystalline lens using some muscles, and those muscles are called as ciliaris or ciliary muscle, which is one of the intraocular muscles, and this muscle is purely under the autonomic nervous system. It is not voluntary, and that is supplied by the parasympathetic. Clear? How does this get supplied? Through the third nerve. The fibers come from the parasympathetic pathway into the third nerve, and that supplies the ciliaris muscle. Now, if the ciliaris is very well contracted, okay, this zonule, ciliary muscles will be like this, okay. If it is very well contracted, okay, the zonules become lax, okay, and the lens becomes more convex. Once the convexity of the lens increases, it allows the power to get increased to up to 4 diopters, not too much. The eye can't keep on increasing it. Up to 4 diopters it can increase and facilitate for near vision. See, an object is at distance, is coming towards you or near, you need to increase the power of your lens to be able to see this, and that is facilitated by the ciliaris muscle. So, which is supplied by parasympathetic, correct? So, this is actually the ciliaris muscle which is going to stay contracted to facilitate this. But remember, that too is a muscle. So, over a period of time, okay, these muscles with the process of aging tend to become weaker, and they no longer are able to keep it contracted for prolonged periods at this state of high convexity. That weakness, which develops around the age of 40 years, results in presbyopia. So, simple to understand is the process of aging where the patient begins to lose the ability to accommodate. Accommodation is nothing but increasing the curvature of the crystalline lens to be able to focus at near. So, I hope now you understood all the different types, and the answer to this question is astigmatism. So, like I said, it's most important for you to understand the core basics of things rather than trying to be able to solve, syndromes and everything. NEET and INICT is now focusing on these basic things and how is your ability to apply them to solve the questions. Okay. So, if you have your concepts right, there is no way you can go wrong in answering these questions. So, astigmatism is a common and generally treatable imperfection in the curvature of the eye that causes blurred distance and near vision. So, astigmatism, remember, it applies to both distance vision and near vision. It occurs when either the front surface of the eye cornea or the lens inside has mismatched curves. I told you, right, different meridia, they are differently steep and shallow. This causes the light to bend differently as it enters the eye, resulting in a refractive error. Understood? Now, it's complicated, but we need to understand this phenomenon of astigmatism to be able to give best visual acuity to the patient, correct? So, astigmatism is further divided into these types. Okay, see, understanding this whole thing, okay, was given by Sturm, and that is why this structure is called as Sturm's conoid. It's a cone in a 3D structure, and hence it's called as conoid, like trapezium, trapezoid, right? So it's called as Sturm's conoid. I'll explain to you how to remember or understand the naming of these refractive errors. See, it may look very tricky, but it's very simple. Okay, just know these two things: simple and compound. Okay, simple means one of the two things is on the retina. Compound means both are not on the retina. Not on the retina. One is on the retina, one is not. We saw, right, there are two points of focus, either front or behind the retina. So this is the way it is named. So simple means one is on the retina, I told you, the other is same as that of the name. Compound, one more point is, both of them, whether they may be not on the retina, but both of them are on the same side of the retina. Whereas mixed, okay, is each focus is on either side of retina. This is all. Now I'll explain it to you how to apply that here. Don't need to know about this alpha, beta. Don't confuse it too much. Keep it very simple. Now, when you talk about simple hyperopic astigmatism, okay, take this example. I'll tell you what is WTR, ATR. I will come to that. So, simple hypermetropic astigmatism. See, what this is the globe, okay. So, this is retina. I'll erase this just to make you understand. Yeah. So, now see here. This compound hypermetropic astigmatism, no, we'll start with simple. Can you see that one is on the retina? Same way in simple myopic, one is on the retina, correct? The other one, which is not on the retina, decides whether it's simple hyperopic or simple myopic. So simple myopic means the other focus is in front. Hyperopic means the other focus is behind. Whereas compound, I told you, they are both on the same side of the retina. So here hyperopic means behind. So both of them being behind the retina is simple hypermetropic. Whereas both of them being on the same side but in front of the retina is simple myopic. So these are the different types, and mixer, I told you, one is in front, one is behind the retina. Clear? So once you understand these concepts, you don't have to try to remember or mug up anything of these images. Understand the nomenclature, right away apply it. Okay. Now I'll just touch upon the part where you have to apply this. Okay, this is just knowing what it is. Before that, what is WTR, ATR? With the rule against the rule. Now, what is with the rule? Remember, we have an upper lid and a lower lid. So what it happens is, I told you about muscle of Riolan, right? It keeps us our lid opposed to the globe. Just not opposed. It also applies a little bit of pressure on the globe, because of which naturally, or I should say by rule, as they call it rule, the vertical meridian is steeper than the horizontal meridian. Understood? So vertical being steeper than horizontal is nature and the rule. So if that pattern is more, I would say, exacerbated or aggravated by this astigmatism, it is with the rule astigmatism. Meaning the vertical meridian stays steeper than the horizontal meridian on the patient. Whereas if it is against the rule, the horizontal meridian is steeper than the vertical meridian. So this is with the rule and against the rule. Why they call it with the rule, against the rule, right? So now why or how will they ask us this in the exam is very important. I'll tell you another thumb rule, which is I indicate using this arrow. Plus at 90, minus at 180 is with the rule. This alone you need to remember. So if they give you, let us say, they won't test you too much, but just they can ask you this: plus 2 diopter sphere minus 1 diopter cylinder at 180. So can you see that this is minus sign at 180? So that means it is with the rule. Similarly, minus 2 sphere plus 1 diopter cylinder at 90. This again is with the rule. So this I want you to remember to be able to answer whether it is with the rule or against the rule. Clear? What are the applications of this, knowing about all this conoid of Sturm, etc.? There is one test called as astigmatic dial. Okay, what happens is there are 12 spokes corresponding to the clock hours projected on the screen. Spokes are parallel to the principal meridians of the eye's astigmatism. So there is an astigmatic fan which is kept in front of the patient's eye, and they are asked to let us know that at which meridian, okay, do they see the image on the other side of the fan clearly, or the line which is seen most clearly. Okay, so those which are corresponding with the conoid of Sturm, okay, that is these alone, they are very prominent compared to the others, and that helps us determine the axis of the cylinder. Okay, so this is how you apply the conoid of Sturm practically while trying to understand the refractive error of the patient. The whole point of knowing all this is being able to apply it in certain tests, and one of them is astigmatic dial. There is one more device which I'll just let you know. It's a little complicated at this stage to discuss it, which is JCC or Jackson cross cylinder. Remember that this is also used to identify the particular, what shall I say, the axis of the patient's refractive status. But remember, at this stage, you need to know that this is also based on Sturm's conoid. Clear? So this is about astigmatism and other refractive errors in brief. So refraction is again the bread and butter of ophthalmologists. So they are going to test you in one way or the other in optics and refraction. Let's move on to the next question. A patient has loss of vision in the right half of both of the eye's visual fields. What is the most likely site of this lesion? So this again is a neuro-ophthalmic question. So they are saying, read the question very carefully, because many times they do not have to give you the exact visual field defect. They want you to decipher it based on your understanding of the question, and you shouldn't go wrong there. Now here, loss of vision in the right half of both of the eyes. So the patient, when they tell you, they are not going to tell you bilateral hemianopia, homonymous hemianopia, right? So you have to decipher it from the question. The patient is simply going to say, doctor, I am not able to see the right half of my vision. That's all. Which eye, what eye, nothing they will say. Okay. So here, to make things clear, they are saying that it is right half of both eyes. Remember, visual fields and diplopia charting are two investigations in ophthalmology which are recorded based on how the patient sees it. For example, there are other tests like OCT or other tests which are, based on what you see. Okay, the sides, I mean. But here, even for us to be able to understand it, it is often documented and printed as in how the patient sees it. Clear? So the right half, you must be thinking, why is the left half being shaded? No, like I mentioned, you are talking about it as if the patient is seeing it. So you are seeing it and you are saying that the right half is not being able to see. So can you see, this is the actual field defect. If at all the patient field defect is given to you as an image, this is what it will be given. So for you to arrive at this, you should apply that knowledge that fields and diplopia charting, it is often like what the patient sees. Right. Now let us try to name the field defect. Okay. Naming is the second step in the process. Now, what is homonymous? What is heteronymous? So just like we discussed a few thumb rules in case of neuro-ophthalmology third nerve, right? I'm going to discuss some ones here so that you can apply them and immediately get your answer. So whenever again, these are named based on these field effects, right? So they again are according to what the patient says. Homonymous means the same side of the visual field is gone. Homo means similar, whereas heteronymous means that the different halves of the visual field are gone. They are hetero, they are different, they are not the same half of the field, that is half or quarter or whatever. Okay, because there is homonymous quadrantonopia and all that. That is a little complicated, but remember, the same side of the visual field being lost is referred to as homonymous. Okay, whereas heteronymous is opposite sides. Now I mentioned hemianopia. Anopia is not being able to see, hemi is half of the visual field. So this is what the patient has. Now this is actually a right-sided homonymous hemianopia. So whenever you have a diagnosis, it has three parts in these sort of situations. One is which is the side, most important. Okay. Second is whether it's homonymous or heteronymous. Third is whether it's hemianopia, quadranopia, whatever. Clear? So here the homonymous hemianopia is actually the diagnosis. Always remember, anything beyond on or beyond optic tract, okay, it is homonymous, and the congruency. Congruency is another word. Congruency. Congruency is basically the similarity in both the eye's visual fields. If right eye is lost this much, left eye is also lost this much, then they are said to be congruent. Okay, so the congruency improves. This is another thumb rule. So this is one thumb rule. I told you that the same side is one thumb rule. Okay, so congruency increases as we go posteriorly. Okay, congruency increases as we go posteriorly. So with this, let us try to understand here. So optic tract onwards, it is of the opposite side and it is homonymous. Why? Why opposite side? Because in the optic chiasma, the fibers, the nasal fibers are going to decussate. Correct? So simply for your understanding, remember beyond optic chiasma, it is often the opposite side which is involved. So here we are talking about a right homonymous hemianopia, and because it is homonymous, it is optic tract or beyond. Okay, and it is right sided, so the lesion is in the left side. Okay, okay. So here it is right homonymous hemianopia. So the right correct answer is left optic tract. I hope you understood as to how I arrived here. Like I told you, students, it is not just about the diagnosis, it is about you having the right approach in order to get to the diagnosis. Clear? So, loss of vision in the right halves of both visual eyes suggests right homonymous hemianopia, just like we discussed. So, the lesion is likely to be situated in the left optic tract. So, it is responsible for the right visual field, lies along the upper anterior and then the lateral surface of the cerebral peduncle and is parallel to the posterior cerebral artery. So, let us understand the visual field defects. See, this is very commonly asked. Okay. So, very important to touch upon it in detail. Let us start. So, this is the optic nerve. Optic nerve is the culmination of all the fibers of the ganglion cells, retinal ganglion cells that join together to form the optic nerve, correct? So this optic nerve, you can see that the red is nasal and blue is temporal fibers. Temporal fibers do not cross, nasal fibers cross. Okay, so this is the optic nerve, this is the optic chiasma, this is the optic tract, okay, and this is the optic radiations, and finally this occipital cortex. Clear? Right. So now we'll start with the first one. Optic nerve is actually all the nerve fibers, both nasal and temporal, from the same eye. So any problem in the optic nerve, let us say there is traumatic optic neuropathy or any optic nerve avulsion in trauma or even optic neuritis, right? So that results in total visual loss restricted to one eye. There is no involvement whatsoever in the left eye. It is a unilateral pathology, so that eye's visual field is gone. Now let us move on to optic chiasma. See, optic chiasma, we'll be dealing with it in detail in a subsequent question, but I'm just touching upon here. It is bitemporal because the nasal fibers, as you can see here, gets involved. And as you can see, the temporal vision is taken care of by the nasal fibers, whereas the nasal vision is taken care of by the temporal fibers. This is the beauty of the design of the eye by nature, right? So, the nasal fibers being responsible for the temporal vision in both eyes are gone, but they are not the same halves. See here, this is the right half, this is the left half. That is why it is called as bitemporal hemianopia or heteronymous hemianopia, whichever way you want to call it. Now, let us move on to the third one. Third one is unusual, but I'll tell you one condition which causes this. It's called as olfactory groove meningioma. Olfactory groove meningioma, but not so common, where the temporal fiber of one side is affected and hence the nasal field is gone. Can you see here? It's not very common, but just know that it is theoretically possible. Okay. Now, once you cross the optic chiasma, it is very clear that it has to be homonymous. Correct? So, anywhere from the optic tract, be it LGB or optic radiations or occipital cortex, you are going to get a homonymous hemianopia. But there is one small concept which is actually this thing you see here is the centralmost part of the visual field, which is actually by the occipital lobe involvement in situations like that. That part in the occipital lobe is that of the macula. Okay, macula majorly contributes to the occipital tip, as they say it, occipital lobe's tip. Okay, that part has dual blood supply, and that dual blood supply is responsible for its pairing if one of the blood supplies are affected. Let us say there is a PCA stroke. MCA, that is middle cerebral artery, will still supply this portion of the occipital lobe, and the central portion of the vision is spared. So that is why it is called as hemianopia, homonymous anopia with macular sparing. So if this sort of a visual field pattern is seen in the field's examination, you know that the involvement is in the occipital lobe. Why are we knowing all of this is because this field test, you don't have to do an MRI, nothing. You can actually identify the exact site of lesion just by knowing the type of field defect it produces, right? So that makes your clinical work very easy. So this is the value of this particular field defect identification in cases of patients with field defects and possibly stroke. So many times we get referral from neurology to do fields and give them a report. That is to identify the site of lesion. Apart from the MRI, this is also a very useful clue. Okay, right. So this is another important point that I wanted to mention here. Let's move on to the next question. A 70-year-old patient presents with distant visual acuity of 618, which improved on pinhole testing. Okay, he gives a history of not needing glasses for near vision. Now, on ocular examination, findings as shown in the image were seen, which of the following refractive error is likely to be seen in the patient. So this is the image of the patient: axial myopia, curvature myopia, positional myopia, and index myopia. See, we'll dissect the question one by one. Okay, first is visual acuity of 618, which improved on pinhole testing, but they've not told us to what extent. Okay, whether it's improving to 6.6 or not, meaning there may be some improvement, yes, but it is not so important that they didn't give us 6.6 vision. Okay, so there is some amount of visual deficit whatsoever. Second point is very crucial. Okay, now the patient is saying, this is a very typical history. Okay, the patient says, doctor, I'm able to read the newspaper and all, even the smallest letters I'm able to read very clearly, only the distance, the bus number I'm not able to see. This is the concept of second sight. Okay, second sight, which is nothing but when the cataract ensues, the nuclear sclerosis allows for better visualization of near. The patient becomes nearsighted as the cataract matures. So it's a 70-year-old, so cataract is very much possible, and in the image also you can see the cataract. But what I want you to understand in this image is, this light you see here is of cornea. Okay, this imaging of this type or visualization of the lens of this type is called as optical slit. Okay, this is called as optical slit, because using light you're cutting through the lens to see the different layers, correct? So this is the cortical matter or the cortex of the crystalline lens, whereas this is the nucleus. Can you see that the nucleus is cataractus, and what is the color? It is like dark brown. Okay, dark brown. Okay, so cataracta rubra type of brown. So we'll know the cataract nuclear sclerosis, right? Amber, rubra, nigra. Okay, so it is almost NS4, nuclear sclerosis 4, right? So such amount of nuclear sclerosis, what it does, it changes the refractive index of the nucleus, making it higher in refractive index. This is what happens. And when any medium has an increase in the refractive index, what happens? It tends to become more and more converging. And this nature is very typical of myopic change, or it's called as myopic shift. And this type of myopic shift is called as index myopia. So axial, curvature, positional or index. Now you know why it is called as index, right? Because the refractive error is going to change and this refractive error is myopic in change. So it's called as index myopia. So that's the answer. Image shows a nuclear cataract. I told you why it's nuclear, which increases the refractive index resulting in index myopia. In its early stages, patients become more nearsighted and can experience a temporary improvement in reading vision called as second sight. This disappears once the lens turns yellow and clouds the vision. So you leave this patient alone for a few more months, the media itself will become so opaque that no light enters, and that is when I told you, right, the pinhole vision improvement will not happen, right? Let's come to the different types of myopia. Axial myopia, which is, I told you, right, we discussed before, the change in the length of the globe because of growth variations. Instead of growing like a globe, it grows like an ellipsoid or an egg-shaped eye. Okay, increase in the anterior posterior length. Second is curvatural myopia. In a condition, this is not in the lens, it can be in the lens also or in the cornea. I'll tell you the conditions. In lens, it is called as lenticonus. Now this lenticonus again is anterior lenticonus and posterior lenticonus. Anterior lenticonus is seen in Alport syndrome. It can be your question from a different subject altogether, like medicine or biochem. Posterior is seen in Lowy syndrome. Okay. So know the different features of these syndromes because it has a slight connection to the eye, which I would like to mention it here. Alport syndrome and Lowy syndrome. Okay. So those result in curvatural myopia because of lens. Lens becomes more convex due to the abnormalities. Second is cornea itself becomes more convex. That is seen in cases of keratoconus, where instead of being a prolate cornea, there develops a weakness in cornea because of which it becomes more conical, and that is called as keratoconus. Okay, we'll discuss keratoconus in detail because in undergraduation again that is one area in cornea which can be focused upon in detail. Okay, right. Next is positional myopia. So what happens in conditions like Marfan's and in case of homocystinuria, there is condition called as ectopia lentis. See students, I'm just trying to cover all aspects of a particular topic, maybe slightly out of way of this particular question, but our aim here is to touch on the high yield topic. Clear? So positional myopia happens because in these two conditions, the lens gets shifted out of its usual position. Okay, so let us say the lens moves a little forward compared to its original position. It is like as if the convex nature is now going to happen at a much earlier part of the traveling of light, correct? So here was the lens. Now if it is happening here, earlier the convergence happened here, correct? This is the normal position. Now the convergence starts happening much earlier because the lens gets shifted. So can you see this again worsens the myopia? The light gets focused much in front compared to what normally happens. That results in positional myopia. Now coming to index myopia, we already discussed the change in the refractive error. Lastly, myopia due to excessive accommodation. So we discussed in the case of the accommodation changes, right? Presbyopia. So presbyopia is when the weakness develops. On the other hand, there's the opposite of the spectrum, where the ciliaris muscle, because of long persistent near work, the muscles lose their ability to relax. So they are stuck in a contracted state and they're not able to relax. That is called as a spasm, correct? In any part of the body for that matter. So because of that, the eye is not able to go back to its relaxed position, the lens, and not be able to come out of its high convex nature, and that results in a constant myopia that is called as spasm of myopia or myopia of excessive accommodation. So now remember, myopia has a relation to a lot of things. We'll also see how hypermetropia is related to squint. So this I wanted to explain how myopia can happen in different situations, ultimately resulting in this refractive error of myopia. Right. Let's move on to the next question. An IOL has been placed in a young male following cataract surgery, which was uneventful. Question is, when will you remove the IOL? Okay. Uh, Options are, it should be removed if presbyopia has set in. See, it is a young male, so you're talking about less than 40 years. Okay. Second is IOL should be removed in case of posterior capsular opacification. So what is PCO? It is also called as after cataract. Okay. So what happens is the capsular bag which holds the intraocular lens becomes opacified for several reasons. Okay. It should never be removed and it should be changed even if the patient is asymptomatic. So it is not like your other prosthesis or anything which can be frequently changed. Explanting an IOL is actually a huge task, because to be able to get it out and place another IOL, you don't know whether you're disturbing the bag or what, capsular bag, right? So ideal way it is never removed. It's a part of the patient for the rest of his life. An IOL stays throughout the life, even in cases of PCO or secondary cataract. It's the other name, okay, or after cataract. It is cleared centrally by an ag laser alone, okay. Using a vitreous cutter, it was there before, but not now, okay. Posterior capsular opacification or after cataracts, okay, can easily be removed with high powered lasers which are available very easily these days. Surgical management of PCO is very rare. Okay, I'll tell you where it is done also. In children, yes, they are very thick and may require dissection, not discussion, dissection, okay, or they can be removed by a vitreous cutter alone. Tough and non-pliable membranes have first to be cut into smaller pieces before they can be aspirated, done with a Ziegler's knife. Clear? So we need to know what are the types of PCO and grades of PCO, students, because see, grades is what I want you to just know, because it's very useful in clinical application to decide the power of the laser. Okay, remember, it's not always the constant power you keep and then use that power itself for any type of PCO. You have to increase or titrate the power based on the thickness, and that titration is facilitated by understanding the grade of PCO. See, grade 0 is you can barely see any opacities, whereas grade 4 you can see so much of dot like opacities. So that brings us to a topic of types of PCO. Okay, so what are the different types? So one is capsular fibrosis. Remember, though this does not have a fancy name, this is most commonly seen in our clinical practice. Okay, whereas on the other hand, this Elschnig pearls and Sommerings rings. Okay, these are the fancy names of the types of PCO. What is the difference? Elschnig pearls is what you see here. You see many bubbles like deposits of posterior capsular opacification, that is called as Elschnig pearls. And also remember, the best way to visualize subtle PCO is by this mode. This is called as retro illumination. Nothing but placing the slit of your slit lamp in such a way that you see this red glow, and against this red glow these minor opacities become very clear. Understood? So capsular wrinkling and pigmentary deposits are less common types of PCOs, and Sommerings rings, they are often involving the periphery, so they become like a thick white plate which is seen here. Clear? Whereas the center is often not that involved, whereas Elschnig pearls causes much earlier diminution of vision, often seen around 1 to 2 years after cataract surgery. So these are all important things in improving the quality of vision following cataract surgery. What am I trying to say here is that in cases of Sommerings rings and Elschnig pearls, they affect the quality of vision, especially in patients who have multifocal IOLs. So very early identification and removal of this can really help in avoiding the undue dissatisfaction in those patients. Okay, right. So I told you in young children, the primary PCO, remember, young children can have congenital cataracts or developmental cataracts. Okay, they also have what is called as primary PCO. In them, you really don't wait, or you don't have to wait for IOL and then 2 years later they develop PCO. Many times they already have this posterior capsular opacification. At the time of surgery itself, you will be able to see it. Or Even if you are not able to see it at that time, when you see it at the time of surgery, it's called as primary PCO. During surgery itself, you notice that the posterior capsule is opacified. Many times what happens is, because they are very young, okay, before that I'll tell you how this PCO happens. So this is the capsular bag, right? So when you try to remove the nucleus and the cortex, some amount of cortical matter may get left out behind, okay, and even if it is in one corner, they and multiply to occupy the central part, which leads to diminution of vision. So it is the residual cortical cells which results in PCO. In young children, the process of healing, or I would say it is also a type of fibrosis which is healing. Capsular fibrosis is nothing but a process of healing, okay, that happens quite rapidly compared to an older person who has a lesser healing ability, right? So in them, this PCO is anyways expected. So to avoid a future procedure, a second procedure of YAG laser or anything, in children, we straight away go for primary posterior capsular opacification removal at the time of surgery. Okay, so anterior vitrectomy and capsulotomy are performed at the time of cataract surgery itself. So important concept, note it down. In children, when you do cataract surgery, it's crucial to know that you may do a primary PCotomy at the earliest at the time of surgery. Next very important concept, students, when you decide the type of IOL material, that has a saying in the rate of formation of this PCO. Remember, acrylic, silicon and PMMA, okay. So among them, acrylic has the least, whereas PMMA lenses have an increased risk of formation of PCO, and the edge design. Sorry, PMMA has the least propensity, whereas acrylic has the most, as indicated by this lesser sign. And edge design wise, square edge is more than round edge. Why? Because I told you, right, the migration of these cells is mainly dependent on how lax the capsular bag is. In case of a square edged IOL, okay, not that the entire thing is square edged, square shaped, the edges are sharp, okay, so it will be like this, okay. In a square edged IOL, something like this, the central part will be the optic, whereas the square edges, they keep the capsular bag in good tension, in stretched, and hence the migration of these cells is not very easy, and hence they have a decreased propensity to form posterior capsular opacification. So all of this can be potential questions about PCO, which is why I highlighted them here and I wanted you to know them as well. Clear? So this is about PCO. Next question. A 33-year-old male came with pain, watering in the right eye for 36 hours. On examination, a 3 cross 2 centimeter corneal ulcer is seen with elevated margins, feathery hyphae, finger-like projections and minimal hypopyon in the cornea. What is the possible answer here? So when you talk about, see, in fact, there is another question of fungal ulcer also I mentioned here, two questions for a particular reason. Remember, often for two reasons. One, often we diagnose most of them as bacterial, okay, and we often tend to miss out this fungal ulcer. And secondly, fungal ulcer has more characteristic features than bacterial ulcer, and hence it is not right on our parts to miss out on the clinical diagnosis. So based on clinical diagnosis itself, you can come to a diagnosis of fungal ulcer, because fungus takes much longer to grow on a culture media, Sabron, dextrose, agar, etc., for us to be able to introduce a fungal antifungal medicine. Clear? So once you clinically diagnose it, it gives you all the permission to start the patient on antifungals. So that is why clinical diagnosis of corneal fungal ulcer is important. So see here, elevated margins, feathery hyphae, important, finger-like projections, important. Okay, these are all indicative of fungal infection, and aspergillus is a common fungus that causes. Remember, this fungus is different in prevalence in different parts of the country. Okay, fusarium and aspergillus. Okay, now fusarium is more common in South India and aspergillus more common in North India. This was done by one of the studies called as MUT trials. I'm not getting to the details, but just know this. Why do we have to know this? not for just theory sakes, because they are susceptible to different types of medicines, antifungals, to different extents. Example, this is more susceptible to natamycin, and hence natamycin. And hence you start natamycin in patients with fungal corneal ulcers in South India, whereas aspergillus is more susceptible to voriconazole. Clear? This is the reason why you need to know this. Okay. So natamycin versus voriconazole. Now let us understand some basic characteristics. Okay. Here the onset of symptoms in bacterial keratitis is rapid, whereas in fungal keratitis it takes several days because the patient is almost asymptomatic. Only when the time they start developing a blurring of vision because of the extension of the ulcer to the pupillary region of the cornea, that is when they're like, okay, I've been having this problem for so many months now. Now it's causing blurring of vision, I'm not able to work. So that is the time they come to you. Whereas bacterial is way more painful, causes a lot of redness, watering, and they present to you at an earlier stage of the problem. So is acanthamoeba. So in acanthamoeba, again, this question I'm trying to cover the entirety of corneal ulcer. Okay, there they have again a very rapid course, and the pain there is out of proportion. So there is a very fancy way of doing it, saying it. In fungal corneal ulcer, the signs are more than symptoms, whereas in bacterial or acanthamoebic, the symptoms are more than signs. The ulcer may look so small that you'll be like, what is this patient even complaining about for so much pain? But this is the truth. The signs are more in fungal, whereas the symptoms are more in bacterial and acanthamoebic. So this is a very crucial point that I want you to know. See here, what is the history? Contact lens wear is common for both acanthamoeba and bacterial. Okay, trauma and ocular surface disease. Ocular surface disease includes dryness, etc. Okay, whereas a typical history of water exposure, diving in swimming pools, in local ponds, okay, see this history, they may have been treated as prior herpes simplex. There is one more, viral keratitis, which is not mentioned here. They have dendrites, pseudodendrites. I'll touch upon that also. Okay. Remember, acanthamoeba in the earliest phase looks like small dendrites. So it's very not very unusual for us to get confused between an early acanthamoeba and a herpetic ulcer. So they may have been treated with antivirals and they may not resolve. Okay. So what are the key differentiating features in slit lamp? This is a round or oval shaped lesion with anterior chamber flare. Okay. See, anterior chamber flare means that the anterior chamber or the iritis part onset is quite early. Okay. And also remember, they have punched out margins compared to feathery margins as we see here. Very crucial. The borders are very demarcated and punched out in a bacterial ulcer compared to fungal, where it is more irregular and feathery, okay, not very distinct. Second important point is satellite lesions. This is very, very typical of fungal corneal ulcer. Satellite lesions is when there is another small lesion which is not physically directly connected to the parent lesion. Okay. And there is also a lot of necrotic slough. Remember, it looks very dry, whereas the bacterial ulcer looks wet because a lot of dead cells, okay, and the fungal debris get accumulated in the corneal ulcer bed. It looks very dry. Okay. Whereas the bacterial ulcer, it is very actively multiplying and there's fast expansion. So it looks wet because there is a lot of pus and cells that are produced. Okay. So here epithelial disruption is seen early in case of acanthamoeba because that organism actively invades into the cornea. And this is most important. Perineural infiltrates or radial keratoneuritis. I hope it's clear. Okay, this is the reason for unusual amounts of pain that the patient experiences following an acanthamoebic ulcer. Okay, so what is important here is this radial keratoneuritis is the reason for the tremendous amount of pain that the patient experiences. Now coming to treatments, okay, fluoroquinolones, which is basically moxifloxacin, okay, those are the first line of treatment. But however, Some amount of gram-positive coverage is also necessary, for which you use fortified antibiotics. So fortified is cephalosporins, where you prepare it in a separate vial and give it to the patient for hourly administration. Second is natamycin and voriconazole and amphotericin. Amphotericin is all used in unusual cases like candida. So that is not frequently isolated, but natamycin is often the first line of treatment in South India, because I told you, right, fusarium. Here in acanthamoeba, these two important names you need to know, PHMB and chlorhexidine. PHMB is not very commonly available here. However, chlorhexidine drops can even be prepared from the mouthwash that we have. So these are important treatment. Propamidine also used, but mainly PHMB and chlorhexidine. So I hope I have touched in detail about these. One important point is, see the time it takes. Bacterial ulcer kind of heals faster, but fungal compliance is very difficult. You ask the patient to put drops for months together, they'll be like, doctor, I've been putting it for weeks now, it's still there. So compliance is crucial in case of fungal ulcer. It's going to take time. And I forgot this point, vegetative trauma. Okay, anything which involves animal or plant matter involvement in the injury. Example, fish tail or anything like that, animal tail, it happens, it's not unusual. So those you have to suspect fungal. Organic involvement, organic matter involvement, fungal. Okay. And yeah, so one important point, role of steroids. Steroids is used in keratitis to resolve the symptoms and inflammation, but remember, contraindicated in fungal. Whatever may be the severity. Anyways, I told you, right? In fungal, the symptoms are not too much, the patients don't complain too much, so you don't really need to worry too much about resolving the symptoms. So even otherwise, it is contraindicated in fungal ulcer. That is something I want you to remember. It is a must. Clear? So let us move on to the next question. The most common tumor of lacrimal gland: A. Pleomorphic adenoma, B. Mucoepidermoid carcinoma, C. Adenoid cystic carcinoma, D. Non-Hodgkin's lymphoma. So as patient presents to you with a swelling in the superolateral aspect of his or her orbit, you have to suspect the involvement of lacrimal gland. Lacrimal gland involvement can mean a lot of diagnosis. We will look at how to do it. Okay, so here it's a straightforward question. They've asked it saying it's a tumor. So it has to be a tumor, and they've not mentioned benign or malignant. So it's overall question. And the answer to it is pleomorphic adenoma. So knowing most commons, as you must be knowing right now, is a very important point in any subject, and so is in opthal. So pleomorphic adenoma is the answer. See, of all the epithelial lacrimal gland tumors, note this point. So lacrimal gland tumors we'll see are epithelial or other cells in origin. 55% are benign and 45% are malignant. So little more than half of them are benign. The most common is pleomorphic adenoma. So where does it come from? It arises from the acinar cells in the tubules of the lacrimal gland, but there are outer stromal cells, okay, which gives rise to the stroma. Okay, the secretion of the stroma makes it a very firm tumor. What is the important point? See, clinically, how do you differentiate between tumors? You do palpation, you see for the extent, and in some amount of involvement of the or disturbance of the adjacent structures, right? So because of this fibrous stroma, it can sometimes be less firm and to slightly hard nature. So it can look like a malignancy. That is the importance of telling you this. Okay. See, osteoid and cartilaginous metaplasia. It has a pseudo capsule. So pseudo capsule is when there is so much secretion of stroma, it looks like being encapsulated in a capsule, but it's actually not properly capsulated. So why is it important to know about so-called pseudo-capsulated? Because, excuse me, when you're trying to remove this tumor, right, you think it's a very capsulated one, it'll come out in toto. It may not, because it's only a pseudo-capsule, and you leave a part of this tumor inside, the patient is going to have recurrence. So recurrence after excision of pleomorphic adenoma is mainly attributed to this, this notorious pseudo capsule, because you think it's come out in toto, you've left a part of the tumor behind. So ensuring full removal is crucial. And surface bossulations and all are extra features. See, this is the classification I was talking about. Lacrimal gland tumors, 50% epithelial, 50% non-epithelial. Non-epithelial includes lymphoma and other, lymphoproliferative and other tumors. Of the 50% epithelial, 50 are benign, 50 are malignant, which we saw in the previous things. And of the 50% malignant, 50% are adenoid cystic and 50% are other carcinomas like mucoepidermoid. Okay. So now I hope it is clear to you about the classifications of the different tumors, okay, of the lacrimal gland. So this 50-50 rule is what I wanted to introduce here. It makes it easy for you to remember, right? So let us look at the different features. Correct. So now in pleomorphic adenoma, the median age is around, leave the last two, I'll come to that. That is NSOI and orbital lymphoma. First, let us understand the difference between the benign most common and the malignant most common. So malignant most common is adenoid cystic carcinoma. Okay. Though the median age is around 35 years, whereas median age is 40 or in fact 50. So adenoid cystic is not very usual in middle age. It's more in the early geriatric population, like around 55 to 60 or more than that. Pleomorphic adenoma is often painless. Okay. Whereas adenoid cystic carcinoma is painful. Why? Again, because you should know that it has a perineural spread. See, I told you I'm touching upon a little bit of extra topics related to this question. So adenoid cystic carcinoma is also something you need to know about. Okay. So because it has a perineural spread, it involves the nerves and that results in the pain. Speed of onset. It's a slow growing because it's benign in pleomorphic, whereas it's rapidly growing in case of adenoid cystic. Remember, the encapsulation is pseudo encapsulated, we discussed, whereas malignancy you don't talk about capsulation. It is often unencapsulated, which facilitates its rapid expansion and spread. Now coming to histo or the pathological examination, this has ducts and myxoid stroma. I told you, right, there's a lot of stroma like substance that is produced, which is necessary or which is the cause of this firm nature. Whereas here there are multiple patterns. Okay, there is Swiss cheese pattern, there is basiloid pattern, and Swiss cheese is the most common. What is so Swiss cheese about it? Nothing great. See, these tumors, no, they have a lot of vacuolations in between, okay, and that makes it looks like a Swiss cheese. So this is the tumor, a lot of cells will be there and suddenly one vacuole, okay. So this is the Swiss cheese nature. We'll be seeing one more Swiss cheese in the future in this PPT. I'll tell you what, okay. And lastly, treatment is excisional biopsy. You have to excise in toto, whereas incisional biopsy and excenteration may be required in adenoid cystic at the earliest stage, or else it becomes only palliative treatment, correct? So that is another important point I want you to remember about adenoid cystic carcinoma. I hope it is clear. Now we'll move on to the other two conditions. I told you that 50% are lymphoproliferative, right? So that is orbital lymphoma, which is often seen only in 60 plus years, okay, of people. Painless in nature, it is slow growing. Unlike other malignancies, lymphoma is not fast growing because lymphoid cells contributes a very small proportion of this lacrimal gland. So you can't expect it to multiply to such fast extent to cause an increase in size. So it's a very slow growing tumor. Like any other malignancy, it is unencapsulated. It is monoclonal. It's lymphoid cells which are monoclonal origin. Radiation or chemo. Remember, lymphomas often respond very well to radiation. Okay, so that is another point. Coming to NSOI, which is non-specific orbital inflammation. It's also older days called a pseudo tumor of orbit. Okay, pseudo tumor of orbit. Okay, and also it is very commonly seen in patients who have uncontrolled diabetes. Clear? So that is a very important predisposing factor. Yes, it is painful. Speed of onset is acute. It is not applicable because you're not talking about a multiplying cell here. It is basically inflammation. Okay, polyclonal infiltrate. So just like in any inflammation, you have a lot of inflammatory cells like neutrophils, the multicellular giant cells, okay, those sort of things. And paradoxically, in a diabetic, you have to start them on steroids. So you have to be concerned about their diabetic control And in spite of that, you have to start them on steroids in order to settle this out. Okay, to some extent low dose orbital radiation helps, but mainly it is by anti-inflammatory measures like steroids. So with that, we come to a brief conclusion of the orbital tumors and their variations. Clear? Now another question from optics and refraction. Right, a spectacle seen here is used in which of the following conditions? So options are A, progressive glasses for presbyopia, B, bifocal glasses for presbyopia, C, bifocal glasses for pediatric pseudophakia, D, bifocal glasses for adult aphakia. So first of all, we have to answer the first part of the question, whether it is progressive or bifocal. Remember, progressive will not have this conspicuous line in between of any sort, this line, curve, nothing will be there in a progressive. So this cannot be a progressive glass. It has to be bifocal. Now, when you talk about bifocals, okay, here bifocals can be given for distance and near in the same glass, and also remember these bifocals are of different types based on the need of the patient. Okay, so in cases of aphakia and pseudophakia, you do not advise bifocals because the purpose of surgery itself is for clear vision, and bifocals may not be the best option in pseudophakia. Better to go for progressives. Before that, always remember bifocals are preferred by patients who have not much to do with intermediate vision. Okay, if a patient is a computer working person or an IT professional in the age of 40, he wants to change over to something for presbyopia. Okay, you don't give it to them, but otherwise if a person has only reading activities, bifocals for presbyopia is the way to go. Okay, so this is actually a bifocal for presbyopia. Remember, presbyopia is the most common indication for bifocals, which have two different prescriptions in one spectacle lens. So this is of a different power, this is of a different power. Understood? The upper part of the lens has a distance prescription, while the smaller lower part has a prescription for allowing you to see at near. Clear? So these are the important points about the basic anatomy of a bifocal. It has different types. Okay, so different types you see here are executive, straight top and round top. Okay, so we'll just know a little bit about this bifocals because bifocals are still very commonly used among some of the elderly people. So now coming to this, okay, what are the features? I'll come back to that. If it is a round top, okay, like we see here, for this I want you to understand some basic points, okay, before we go ahead. So what is the type of lens used to correct hypermetropia? It is biconvex. What is the type of lens which is used to correct myopia? It is biconcave. Now here one important concept. You take these lenses, okay, in the midpoint. Can you see or imagine that this is actually like multiple prisms, okay? You have to imagine, okay, with all of their base facing towards the center point, correct? Like this. Whereas here it is exactly opposite. It's like as if you are splitting this lens into multiple small ones. Okay, now this is a little bit in detail, but if you understand this, you don't have to remember or mug up anything related to this. Okay, now this is about hyperopia and this is about myopia. So there are two concepts. One is image jump and the other is image displacement. What do they mean? The patient uses the same eye to see through different parts. So when the patient moves his eye from distance to near, suddenly the change in the type of the image is what these two refer to. So all of a sudden, the image appears to have moved, okay, from its existing position to a new position, that is called as displacement, okay. Whereas image jump is when the sudden increase in the size and the composition of the image of the object. Let us say there is a flower vase in front of you. If you look at it directly from distance to near segment through it, these two things will happen, okay. Now you want this to be as minimum as possible because it creates a lot of difficulty for the patient, correct. So always remember the near segment is always plus power, correct. So you are going to actually add plus lenses here, plus diopter lenses, and always remember, you see anything in near in the lower half of your visual field. You don't keep like this and read, you keep it like this and read. Reading is near work and you keep it like this. So you give any addition you want to give in the lower part of the glasses, correct. So now we understand these types. If it's a straight top, okay, if it's a straight top, one second, I'll erase this. Yeah, if it is a straight top, okay, what happens? You're going to have a plus lens like this, correct. So here what, these are all upward facing prisms, and remember this image jump and displacement is explained by this prismatic activity. That is why I took the pain of dividing this into small prisms. So because what do prisms do? They deviate an image and show it in a different position, correct. So to overcome this image jump and displacement, all you have to do is negate this prismatic effect. So if you have a straight top, it is like this, top is straight and the remaining plus lenses are like this. These are base down prisms. So this gets effectively cancelled and these two phenomena come down. So in case of myopia, it is better to choose a straight top lens, bifocal lens. Whereas a round top will be like this. Round top means you're keeping the biconvex like this. So here sorry, this is flat here, okay. So you're going to keep it like this. So you're keeping prism up once like this. So you're going to effectively cancel the positive one, the prism one. So if you are already hypermetropic patient is developing presbyopia, use a round top. If an already myopic patient is developing presbyopia, use a straight top. This is the basis, okay. And then to overcome all of this, they completely got rid of all these things and they went for executive. In executive, what happens? The lower half of this lens itself is modified and not an addition is not given. Can you see here? It is not like an extra thing is added. Whereas in those two types I mentioned, it's like as if an extra lens is stuck onto it. Clear? So see, it acts like a base up prism in the flat top. It like base is up, right? It's facing up. So it acts like a base up prism, and minimum image jump, image displacement, more for hyperope than myope. So in myopes, use a straight top, whereas round top is for, that's what, plus lens already the patient has, choose round top, minus lens, use flat top or executive type. For myopes, image jump is very difficult to ignore because it is in the same direction as the image displacement. So avoid round tops in myopes. So this is actually what you need to know. But I thought if you understand this, you won't get confused. So that's why I explained the basis of this flat top and round top. But nowadays, progressives are the order of the day. What is progressives? I'll show you. See, this is the anatomy of a progressive lens. So the distance part is actually seen when you look straight. As you come down, okay, you start looking down towards your near segment, straight away it is not jumping to a same near power. This is what is called as intermediate vision and seen by this progressive corridor. So there is a smooth transition of power change from here to here. Let us say this is plus 3 diopters and this is near add is some plus 2. Okay, so plus 2 plus 3 becomes plus 5. So when you change here, here you have a plus 4. This is a very crude example I'm giving you. So the patient is not going to have any of this image jump, displacement, nothing. Straight away the patient is going to have a smooth transition, and in fact if the patient wants to see an intermediate vision like a laptop, this is what facilitates it. The intermediate corridor is what he will see the laptop through, and this can vary in size. If you have a lot of intermediate work at different distances, you increase the intermediate corridor. So I hope you understood the difference between the different types of correcting presbyopia. Clear? So these are the different parts of a progressive lens, and this is the blending region. So you want to reduce this blending region if you want a broader intermediate vision, and all of them makes it slightly more costlier. But apart from that, what I want you to understand is that it has three portions, and the transition is quite smooth. It is not jumping or shifting immediately between two segments. Right. So that brings us to the end of that question. Clear? Now let us move on to our next question. All of the following are used to control raised IOP, which is intraocular pressure. So important students, for you to get oriented to some basic abbreviations in ophthalmology, of which IOP is one. We'll be seeing many more as we go through. So here it is an except question. So options are dexamethasone, clonidine, methazolamide and mannitol. They have been smart enough to give you drugs which are used in management of glaucoma, okay, controlling raised IOP, but not so commonly used or have been outdated. This is just to trick you, okay. So what is the possible options, right? So one second, yeah, clear. So now all of the following are used to control raised IOP. Let's start with option B, clonidine. You must have heard apraclonidine, brimonidine. So they are all derivatives of clonidine, and they are all alpha 2 agonist. What do? They act on the blood vessels in the ciliary body and decrease the production of aqueous. Okay. Whereas methazolamide, may not have heard, but you must have heard acetazolamide, dorzolamide, brinzolamide. I'm just touching on all anti-glaucoma medications as much as possible in this limited time. They are all what? They are all carbonic anhydrase inhibitors. Correct? So apraclonidine, sorry, acetazolamide, dorzolamide, brinzolamide, all calcium anhydrase, carbonic anhydrase inhibitors, and they are again used to control raised IOP by again decreasing production. Mannitol. What is mannitol? Mannitol is a hyperosmotic agent, just like glycerol, okay, which is given IV. It is not topical. It is given intravenous, which helps in drastic reduction, especially when the IOP is very high in case of acute angle closure attack, right? So immediately you start the patient on IV mannitol and the pressure drastically drops. Okay, so that is a hyperosmotic agent which is also used to control raised IOP. But dexamethasone is a steroid. It does not lower IOP. On the contrary, it increases the IOP. So that is the answer. Clear? So now you understood why they've given different medicines. You may not have come across it if they give you timolol, or let's say if they give you bitaxolol, or IOP beta blockers. You must have immediately or latanoprost. Okay, those are all very commonly used, but these are not so commonly used, and that's why they've chosen these. But you need to know a little bit about this AGM in detail. That is anti-glaucoma medicines in detail, because you touch upon it in pharmac, okay, and in ophthal also. So like I said, ophthal also has a very strong link to all the basic sciences, just like any other clinical field, right? And they test you in these areas. Let's also understand a little bit about DEXA, because DEXA is a double-edged sword, they say, or any steroid for that matter. Steroids are an indispensable part of treatment in ophthalmology, but we always have to take it with a pinch of salt. So any condition which needs steroids, also you should keep it in the back of mind to understand that they have adverse effects which require monitoring. They don't completely contraindicate its usage, but you also need to keep them on regular follow-up in order to mainly check two things: formation of cataract and also raise in intraocular pressure. There is an important concept They are called as steroid responders. See, it is very interesting to know this word because remember, steroid responder doesn't mean they are responding beautifully to the treatment of steroids. They are actually having a propensity to have a raised intraocular pressure when being administered with topical steroids or any systemic steroids for that matter. Okay, they are called as steroid responders. Okay, let's understand a little bit about steroids and their usage in opthal. Okay, so starting with dexamethasone is a corticosteroid medication that can actually increase the intraocular pressure when used. How all can you use DEXA or how all can you use steroids in general? I'll tell you. First is topical. Remember, topical usage of steroids is quite significant. Believe it or not, it's used in conjunctivitis. Why? Because apart from killing the organism using antibiotics, okay, many of them are often viral in nature, right? We know adenovirus causes this. So this adenovirus is going to be killed and taken care of by the immune system. Meanwhile, the patients are going to have a lot of symptoms like itching, burning sensation, watering. You want those symptoms to be subdued while the body takes care of this infection, for which you have to employ steroids. Okay. So next up, keratitis. I told you apart from fungal keratitis, we can use steroids in other conditions like bacterial keratitis once they are under the treatment of antibiotics, not isolated steroids. Scleritis, uveitis, okay, these conditions, remember, they are all inflammation. So best potent anti-inflammatory medicine is nothing but steroid. Okay, hyphema. Hyphema is blood collection in the anterior chamber, and blood is also a very good irritant and a stimulant of inflammation, so you have to use that. CME, cystoid macular edema. Cystoid macular edema is another condition which means which needs treatment with steroids. For it to not affect visual acuity, macular edema we already discussed. Remember, recalcitrant or refractory macular edema, okay, which does not respond to anti-VEGF. What are anti-VEGFs? Anti-vascular endothelial growth factor injections like ranibizumab, okay, bevacizumab, okay, these are all given for diabetics. So in them, if it's not working, you give steroid injection, which is called as Ozurdex. I mean, these are all trade names, but just mentioning it here to tell you the exact indication. So that is given intravitreally. Okay, CNV and endophthalmitis also provided. CNV is choroidal neovascularization. All that, yes, to reduce the inflammation, you give it. Subconjunctivally, post surgery, it is given in order to reduce the ocular inflammation, and it is also given in cases of severe uveitis. You want better concentration in the anterior chamber, you give subconjunctival midricaine injection, okay, of which steroid is an important component. Okay, so topical, I told you conjunctivitis, scleritis, etc. Okay, scleritis, even episcleritis for that matter. Subconjunctival, I told you, it is given in case of post surgery and also following in cases of severe uveitis, and intravitreal is for posterior segment problems. What are the adverse effects? These are often adverse effects following systemic administration, whereas topically or ocularly it can lead to posterior subcapsular cataract, especially on long-term administration, elevated IOP, delayed wound healing. That is why you don't want to give it in active epithelial abrasions and in case of corneal ulcers when the epithelium has not healed. Then corneal re-epithelialization is delayed. Secondary infections also can happen. What happens when you give them conjunctivitis? Later on when they get it, they keep on putting it without asking the doctor's permission, right? So you have to instruct the patients. Coming to the IOP elevating potential, dexamethasone has the maximum, followed by prednisolone, fluorometholone, hydrocortisone, etc. Dexa has the maximum potency to elevate the IOP. Okay. So with that, we come to the conclusion of this session before we break for lunch. So I will meet you on the other side where we'll be discussing many more questions. Everyone. So after the lunch break, I think everybody is all charged up to continue with the opthal session, right? So let's see what we have next. Which of the following is true about optic neuritis? That is the question. A. Most common cause is multiple myeloma. B. Oral steroids are the treatment of choice. C. RAPD is present. D. CT scan is the investigation of choice. So this is a question which expects you to know everything inside out about optic neuritis. So just like refractive errors, optic neuritis is also a very important condition simply because it is an ophthalmic emergency. There are only a few conditions which are ophthalmic emergencies which require immediate attention, and intervention at the right time can go a long way in the visual recovery. Okay, so one such condition is optic neuritis. So they're asking which of the following is true. So the first option given here is multiple myeloma. See, it is not multiple myeloma, but it is multiple sclerosis. Both are absolutely different in nature, except for the fact that they have multiple word in common. So you have to read your options very carefully is what they are trying to imply by giving this question. Second is oral steroids or the treatment of choice. See, like I said, it is an autoimmune condition, multiple sclerosis, and we all know steroids are the best immunosuppressants we have at our armamentarium. But also, what they need you to know is how do you administer these steroids for the best efficacy. Of course, oral steroids are a part of the treatment of optic neuritis, but the first line of treatment is actually IV methylprednisolone, and this is given by a study called as ONTT study, Optic Neuritis Treatment Trial. But anyways, this is all not absolutely for you necessary to know. But remember, it is through the intravenous route that is given in a particular protocol for 3 days, followed by which you give oral steroids. That is the right way of treating. So oral steroids is not the treatment of or the first treatment of choice. RAPD is present. What is RAPD? RAPD is relative afferent pupillary defect. So RAPD is also one condition which is very classically elicited in order to come to a diagnosis of optic neuritis. And always remember, RAPD is a sign of optic nerve disease. You do not get RAPD in a macular lesion usually. So for all said and done, RAPD, you think of optic nerve pathology, any pathology, we will discuss that. Things like even optic neuropathy, like traumatic optic neuropathy, that also can have RAPD, right? And one more point is color vision. Okay, color vision is again a parameter of uh, optic nerve activity, and that too specifically red desaturation. Okay, so what is this red desaturation? If you, oh God. Sorry about the small interruption. We had a technical glitch at our end. We will continue. So I was saying about RAPD, relative afferent pupillary defect. So relative afferent. Right. Sorry for the small technical glitch. We are back live. So we were discussing about RAPD, which is relative afferent pupillary defect. So RAPD is very much a feature of optic nerve problem, right? So RAPD being present is the right option here. And often remember, it is not CT scan but MRI which is the best way to diagnose this because it is a soft tissue pathology. So for bony problems and blood related things like stroke, subarachnoid hemorrhage, etc., yes, CT can prove to be of good help. But anywhere there is a subtle pathology related to soft tissues, like in this case optic nerve, it is best picked up by MRI and not CT. Okay, so MRI you see that there is an increase in the thickness of the dural and the meningeal sheets around the optic nerve because that is the exact site of inflammation in optic neuritis, correct? So let us discuss about optic neuritis. So clinical features include decreased visual acuity, visual fields, defects, decreased brightness and corneal sensitivity. I was telling you, right, the classic red desaturation. So what is this red desaturation? We were talking about it. Let us say there is a red colored sketch pen that you keep in front of the patient. You ask the patient to see the sketch pen or any red colored paper. It could be anything which has bright red color in it. So you ask the patient to see that through the normal eye and compare it with the pathological or the suspected eye. He will notice a distinct dullness in the the bright color of that. The saturation of the red is better appreciated in the normal eye compared to the affected eye. That is called as red desaturation, which is seen as decreased color sensitivity. And RAPD. How do you elicit RAPD? It is the swinging flashlight test. Okay, swinging flashlight. So what is RAPD? Paradoxical dilatation of the pupil upon shining light after coming from the normal eye to the affected eye, because when you shine the torch it should constrict. Because there is no afferent nerve which is working properly, that is the optic nerve pathology, instead of constricting or remaining constricted, it paradoxically dilates, that is RAPD. Okay, so pathognomic feature is RAPD, which is relative afferent pupillary defect, and red desaturation we discussed. Now, what are the other some named phenomena which are associated with optic neuritis is what we need to know. First is the Pulfrich phenomenon, which is motion of pendulum appears elliptical owing to altered depth perception. So before days when we didn't have the ease of access to MRI, these were some tests which also added clue to the diagnosis, right? So the motion of the pendulum, instead of going in 2D, it used to go in 3D to patients who had this optic neuritis in the affected eye. Because the depth perception being at different points of time, the pendulum was observed to be as if it is either in front or behind the actual plane of motion. Okay, this is due to the delayed conduction in the demyelinated nerve. Understood? Next is Uchthoff's phenomenon. Okay, worsening of symptoms with heat or exercise, which is often improvement when 50% after recovery. Okay, so even after the patient has this recovery from this episode of optic neuritis, they can still have the symptom of Uchthoff's. Okay, so these two named things I want you to just keep a note so that they can ask you in exams. Phosphenes are flashes of light induced by eye movements. Remember, optic neuritis, right? There is one more history which can be given to you, which is actually pain on eye movements. This is because optic nerve has a sheath that it shares with other extraocular muscle sheaths also, like superior rectus. So when there is movement, these sheaths, the inflammation is always involving the entire sheath, right? So optic nerve sheath along with the superior rectus muscle sheath, they are all inflamed, and when the eye moves, this inflamed sheath is stretched and irritated. So that is why they have pain on extraocular movements. Then this auditory clicks is another phenomenon. The CN7, that is cranial nerve 7, innervates stapedius and patient hears clicks with effective transmission. So these are all some extra points that you need to know about optic neuritis in multiple sclerosis. Now coming to etiological classification. See, optic neuritis has several causes. We discuss as a prototype about multiple sclerosis, but a number of causes can result in optic neuritis, of which the degenerative or demyelinating type is most common. Others are autoimmune, ischemic, hereditary. Okay, there's one called as Leber's hereditary optic neuropathy, which is again studied as a prototype. Okay, but they won't ask you in detail about all of this, right? Diagnosis, I told you, best for diagnosis is MRI and not CT. And this is important. This NMO, which is actually neuromyelitis optica. Okay, neuromyelitis optica, which is also called as Devick's disease. Okay. So this is actually antibodies against aquaporin 4 and as called as anti-NMO antibodies. Important for you to know is that Devick's disease is a cause of bilateral optic neuritis. Often optic neuritis is unilateral, can have the other eye involvement on a later date. But in Devick's disease, the patient can have bilateral optic neuritis is the important point I want you to know. So like I mentioned, typical and atypical. They've classified it as typical and atypical. So all these things you see here can all cause optic neuritis and has been classified based on etiology. But our main area of focus should be multiple sclerosis. Okay, next question. Which of the following is a direct gonioscope? So now we are touching upon another important area, which is glaucoma. Gonioscopy is actually nothing but visualization of anterior chamber angle. And remember, anterior chamber angle is a crucial anatomic structure which determines the propensity for a person to develop glaucoma. Okay, so we need to see and peep into the angle in order to identify any pathology that is causing obstruction to the outflow of aqueous, right? So here you can see there are multiple names, and based on the person who's invented them, they have multiple, they wanted recognition, so they've ended up naming all of the lenses against their own names. And here there is nothing else exceptional to do but to remember these names, because they were the ones first who let us see into it, and hence we have to give them the credit. So of them, what you need to know is Copies and Richardsons are direct, whereas Goldman Z's are indirect gonioscopes. Okay, now what is so direct or indirect about it? That is what you need to hear. So here this is 2 and 4. Okay, gonioscopy, like I mentioned, is for the evaluation of angle. Two types, direct and indirect. In indirect gonioscopy, the light rays will be reflected by using a mirror, whereas in direct, the gonio lenses will be used which are viewing directly into the angle, whereas in indirect gonioscopy, the image of the angle is formed onto a mirror, which is what is visualized by us. Okay, in direct there is no mirror. Okay, right. It is of two types, Goldman and Zeiss. Direct is of two types, Copy and Richardson. One important point which I want you to know is when you're looking at the anterior chamber or the eye under slit lamp, normally you can't see the angle without any aid. Angle can't be seen. So why is it that it can't be seen is again a feature of optics. Okay, so this is the angle, right? So from here iris comes and this is the angle. So what happens? This is the phenomenon of total internal reflection. Okay, so when the light comes here, this is what you want to see, right? So this is the object and the light has to come here and be visualized. So when you draw the angle of incidence, angle of reflection, everything, the light is going to move from cornea to air. Okay, so cornea to air, it is dense to rare medium, and hence if this angle is more than the critical angle, which is 46 degrees in this case, in the comparing the refractive index of the cornea and the air, etc. Okay, so if it is more than 46, which it is because it's coming from a corner, this is more than 46, there is total internal reflection. So that is why you're not able to see the angle. Now what are you doing by keeping a gonioscope, either direct or indirect, is you are negating this rare medium and you're again creating a dense medium using glass. So this is either made of glasses, right? Glass lenses, gonio lenses are nothing but glasses, and hence this is not rare medium compared to this, and hence light goes through. So in direct gonioscope you will be seeing it here as an observer, whereas in indirect gonioscope this gets reflected and you will be seeing it here. So this is the difference. I hope now it's clear to you. And the concept of critical angle and total internal reflection is the basis of having to use a gonio lens, direct or indirect, in order to visualize the angle. This is the concept I want you to know. Now these are some of the advantages and disadvantages of lenses. See, remember, for remembering this whole thing, only point you need to know is gonio direct is lens, gonio indirect is mirror. Okay, with that you can understand and answer all of this. So disadvantages is just a repetition of the advantages. So we'll not deal that. We'll just look at the advantages. Convenient. Let's see. Often, though it is indirect, it is of much more ease for us to do it because the patient has to be in sitting position, and it is with the help of an equipment we use day in day out, that is a slit lamp. So the patient need not lie flat. Slit lamp examination provides better details, so you can zoom in and you can adjust filters, and it doesn't need any extra instrumentation to see that. It is less time consuming. And dynamic gonioscopy, which is you can press on the cornea and increase the flow outside and see if the angle is opening up or not in case of indentation. Okay, that is possible in direct gonioscopy, indirect gonioscopy. But what is the problem is, like we said, they are mirrors, so the mirror image is produced, okay, and the depth of the narrow angle cannot be seen. So these are some of the disadvantages, and that is the advantage of lens. So it is a straight on view, okay, less distortion, okay, view is more panoramic, you can see almost the entire angle at one shot. In a mirror you have to keep rotating it. So these are some of the advantages and disadvantages, but basically know that indirect gonioscopy, though shows a mirror image, etc., it is often the one that is commonly used because of its convenience, and the patient was also much more comfortable compared to this direct. And direct is often used in operation theaters when the patient is lying flat under the operating microscope, especially for congenital glaucoma. Okay, congenital glaucoma or early glaucoma, where you use it for kids. It's called as EUA, examination under anesthesia. So I hope it's clear to you now as to what is the difference between direct and indirect. Clear? Let's move on to the next question. What is the sequence of staining in case of dry eye? So you need to know a little bit about the stains in ophthalmology, because that's a common thing we use on a routine basis in ophthalm, right? So three main stains are fluorescent sodium, rose bengal and lissamine green. Okay, let us see the order. The right order is first is fluorescein, then lissamine, then rose bengal. Okay, why is it so? So firstly, fluorescein is the most common stain that is used day in day out in our ophthalm practice. So what does it do? It stains all the areas where there is a defect in the epithelium. Let us say a patient comes to you with excessive photophobia watering, and the patient says, I got hit by my child's hand yesterday. But when you see the slit lamp, you may not be able to see the abrasion, so you immediately stain. When you stain, that particular small trough or the small abrasion will lodge the stain and not get washed off by blinking. So that part can easily be picked up in case of fluorescent stain. Okay, stain is the area where epithelium is absent. It can be used for evaluation of dry eye and corneal ulcers. Okay, now coming to lissamine green and rose bengal. See, remember, it is not only the cornea, but sometimes you need to stain the conjunctiva. Why? In cases of conditions, I'll tell you, in case of OSSN, that is ocular surface squamous neoplasia. So these neoplastic cells, not only do they multiply rapidly, they also tend to die off fast. So you need to know whether there is a lot of cells which are lying dead onto the conjunctiva, and to be able to pick that up is where you use rose bengal. So rose bengal has a very crucial role in identifying dead cells that are present in the conjunctiva. So that is clear. But rose bengal has a lot of problems. Firstly, it is not very easy to procure. Okay. Secondly, when you do this, there is severe stinging sensation for the patient. I mean, all you do is just put a little bit of dye on the surface and the patient complains and winces in pain, because per se the squamous neoplasia may not be painful, but this one will induce so much pain that the patient will be so dissatisfied. So to overcome these difficulties is why we introduce lissamine green. It has a very similar role, but it's way less stinging compared to what you get when you stain it with rose bengal, right? So that is why lissamine green is more preferred compared to rose bengal for staining. Okay, see here. So fluorescein dead cell staining is not there, for which you need rose bengal or lissamine green. Okay, healthy cell staining is done by rose bengal only. So if you want to identify live cells, both lissamine and fluorescein cannot do it. Okay, so in that case, you have to depend only on rose bengal. Significance of the staining, I was telling you, right? So significance is the stain detects the cell reception and increase in the permeability. So I told you, if there's a defect in the epithelium, that is best picked up by fluorescein. Whereas if the mucinous layer, we know tear film has three layers, right? First, outermost is the lipid layer, then is the aqueous layer, then is the mucin layer. So mucin layer is affected when the cells that produce mucin, that is goblet cells of the conjunctiva, are not functioning or are destroyed due to tumor. So that can be picked up by using rose bengal. And lissamine green also, like I said, stains the dead cells, right? Dead and devitalized cells. So with what do you see all of this better? First is yellow barrier filter, second is green barrier filter, third is red barrier filter, and these filters are very much available in the slit lamp. So you just need to push the knob to get into these filters to be able to visualize them better. Is it clear? So these are the different stains which are very commonly used to stain the ocular surface. Now, you stain all this, and then what do you understand? Based on staining, it's not just positive or negative. Also, the pattern that is picked up by these stains go a long way in giving us clues to diagnosis. Okay. So see here, if it is in the interpalpable region alone that the stain is picked up, then it is because of rapid, evaporation of tears, that signifies dry eye. Okay. If there is a horizontal band across the inferior 1/3 of the cornea, that's because the eye is not closing properly while the patient is taking rest, and there is exposure to cornea, that is called as that is indicating lag of thalamus. If there is a superficial punctate staining, that is because of SLK, which is superior limbic keratoconjunctivitis, seen in thyroid, usually thyroid eye disease. Okay. And also floppy eyelid syndrome, where the closure of the lid is not proper and gets everted easily. Okay. Then comes central punctate type of pattern, which is focal epithelial punctate keratitis, that is called as Stuyvesant's keratitis, and also EKC, that is epidemic keratoconjunctivitis. Okay. Inferiorly, if the same punctate is seen, see, so this is superior, central and inferior, you have to talk about soft contact lens wear. You have to think whether that is the cause and ask the patient the proper history. So these are some of the causes for different types of straining, and this is again a pictorial way of representing the same. Okay. So like I mentioned, these are all the causes. Clear? Right. Let us move on to another neuro-ophthalmological field. So now I want you to, even before I start describing this, be in a position to say that it is not the same halves, so it is heteronymous, and it's the temporal aspect of both eyes, so it is bitemporal, and half the field is gone, so it is bitemporal hemianopia. When it's bitemporal, you don't have to mention the side because left or right, because it is both sides that are affected. That is why it is heteronymous. And bitemporal can happen where? In only one place, which is the optic chiasma. So right away, you know the answer, you don't have to bother reading the other options, correct? So it is bitemporal hemianopia. Okay, person loses the outer or the temporal visual field in both eyes, means they have difficulty in seeing objects on the sides, which is particularly problematic for peripheral vision. Because if these patients are the ones which are going to start driving, etc., they won't be able to identify the vehicles that are trying to overtake them, and might end up crashing onto some tables which are kept on the side of the hall or the corridor. So those sort of things can happen because of this temporal loss of vision. Okay, so see, this again we've discussed in detail, and I've just highlighted the site of this problem which can result in this particular bitemporal hemianopia. But what I wanted to highlight here is that the optic chiasma itself can manifest with multiple types of field defects, of which I wanted to bring your notice to two things. One is this junctional syndrome. See, that is important because it also brings to us to another very important anatomical feature called as von Willebrand's knee. So what is the von Willebrand's knee? Can you see here in the left optic nerve, the optic nasal fibers, they don't go straight like this. They are coming here and taking a turn and going. I hope you are able to make it here, right? So they're able to they're taking a turn, and so what happens is, if there is a lesion here that is just in front of the chiasma in the optic nerve itself, a part of the nasal fibers also get affected. See here, so the right optic nerve, it is gone, the right field is completely gone, whereas the left side, a small portion of this is also called. So this is the junctional problem or the junctional syndrome. Okay, similarly, when this bitemporal hemianopia is there, right, which we all know about, when the crossing over is happening, the posterior most also can get involved, leaving the anterior fibers. See, this is the anterior fibers which are going like this and going. So their anterior gets involved, whereas here the posterior most alone, the small portion getting involved, leads to central involvement more than peripheral involvement. Okay, so this is called a central bitemporal hemianopic scotomas. Okay, so these are some of the variations that I wanted to let you know before we proceed with it. Don't have to get into other complicated ones, just these two things which I wanted to know you to know as variants of optic chiasmic problems. So von Willebrand's knee is the anatomical point that I want you to know here, and the reason why junctional scotoma happens or junctional syndrome happens. Right. Let us move on to another question. For which condition is this surgery as shown in this figure done for? Keratoconus, keratoglobus, Vaux limbal girdle, or corneal dystrophy? So what you're seeing here are actually two plastic rings. They're actually two different pieces, okay, which are embedded in the cornea itself. Okay, and so all four are corneal problems. So it has to be a corneal problem only because the rings are in the cornea, and it is done for a condition called as keratoconus. What is this? They are called as corneal inlays. So problem in keratoconus is there is steepening of cornea. Okay, there is steepening of cornea, unusual steepening resulting in a conical shape. Okay, now what you want to do in this procedure, they are going to insert the rings like this. We are seeing the cut section. So the rings will be inserted like this, and it will stretch out the cornea and prevent it from becoming more and more conical. That is called as corneal inlays. It is a progress. Let's discuss about keratoconus, because I told you KC is one condition which is somewhat to be known in detail as far as cornea goes. Progressive eye disorder causes the cornea to become thin and bulge out like a cone. Now, the point here is the hydrops is acute corneal edema and clouding due to break in the Descemet's membrane. I'll explain this. So what is hydrops? Hydrops is the terminal end complication of keratoconus if left untreated. So what happens, this goes on becoming steeper, 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 and there is constant stretching, right, at this level. So this is when I'm talking about in the ring. So here, if it becomes steeper, at one point of time, they're all membranes. So Descemet membrane is also an elastic structure, which beyond a point gives way. Descemet membrane is what? The fourth layer or the fifth layer in the cornea, right? So innermost, second layer, that is endothelium following the Descemet's membrane. So that when it gives way, what happens, that is the membrane which is very important in maintaining the corneal transparency by not allowing the fluid to enter into the anterior chamber. So now when that breaks because of excessive stretching, the fluid enters into the corneal stroma and causes an opacity which is called as hydrops. So it is acute corneal edema and clouding due to break in the Descemet's membrane, which may be painful or painless depending on the involvement of corneal nerves. Decreased IOP heals over 6 to 10 weeks and scarring can occur. Imagine if this happens in the center, then the patient's vision is lost forever, because the scarring will lead to obstruction in the field of, obstruction in the light from entering. Can occur occasionally with stromal neovascularization also. So anytime there is a scarring and all this activity happening, the vessels invade into the cornea, which is no longer transparent, and that can also further obstruct vision. So what do you do? How do you diagnose? The most important is corneal topography. What is topography? Even in geography, the same thing, understanding the surface of a particular structure. In geography, it is about earth, whereas here it is about cornea. So you want to understand whether the surface is irregular or whether the surface is highly steep. These things can be well made out using topo. Okay, so this is a more advanced way of doing it, but there is a simpler way which was earlier available, which is keratometry. Keratometry, you must have heard, is being done in order to identify the curvature of the cornea, which is often done even for identifying the intraocular lens power. Correct? We know, right? SRK formula, A minus 2.5 L minus 0.9 K. This K is keratometry value, right? So that is identified, and if the keratometry between the two meridia, we saw astigmatism, no, this is a very important cause of irregular astigmatism. So if K1 and K2 are going to differ by more than 1 to 1.5 diopters, that is vertical and horizontal, there is keratoconus that you must suspect. Is it clear? High cylinders are a very important indication for keratoconus. Okay, so that is the earlier way of doing it before we had topo. Right now, treatment consists of contact lenses. Now there are very special contact lenses available for keratoconus, because it's not just about being optically helpful. That meaning, it is not just about allowing the patient to see better. There are ways to try to control or curb the disease process also, and unlike the other lenses, these lenses have to match the contour of the cornea in order to be able to stuck there and not fall off. Imagine you are going to see, already the cornea is quite steep. If you are going to keep a normal contact lens like this, where will it get attached? It has no place to attach, and then it won't stay on the eye, right? So that's why they have special lenses called as row scale lenses, scleral lenses. Okay, so they have modifications in the shape which allow them to be a better fit a keratoconic cornea. So of them, you need to know rigid lenses, piggyback lenses, okay, row scale. Okay, these are some names you need to just know that they exist. But contact lens is one major way of treating. Remember, often they do not accept spectacles because spectacles do nothing for the surface of the cornea. They fare well much better with contact lenses in place. Okay, so one thing is corneal collagen cross-linking is another important point which I want you to know. So corneal collagen cross-linking is a method where we use riboflavin, vitamin B2, and show UV light which strengthens the collagen. So why is this weakening happening? Because the collagen in the cornea is not strong, it is not meshed up well. So when we show this light, there is better cross linking between this collagen and they don't tend to give way for the cornea to become more steeper. So that is corneal collagen cross linking. I told you about Intax to stop progression. It stretches this out and doesn't allow for further conification of the cornea. And last, let us say the patient failed to come to us at early stages and ultimately ended up with high drops and scarring. Now you have nothing to do but replace the cornea with another one. That is when you end up doing penetrating keratoplasty, like I said, for advanced cases and supportive for high drops. Okay, before you transplant the cornea, there are some basic measures you can do for high drops. That is, use steroids, cycloplasty. Why do you use steroids? It is an anti-inflammatory, decreases the amount of possible scarring in the future. So by doing that, you're trying to at least reduce the amount of scar. And if the scar is somewhere in the corner and not obstructing the pupil, you can even avoid surgery. So that depends. So steroids is an important role, and bandage contact lenses in order to further prevent any damage or weakening. So I hope I've touched upon all aspects of keratoconus. Okay, so keratoconus can definitely be a potential area from where they ask questions from cornea in NEET PG and INICT. Okay, so this is in again detail in a flowchart format about options. And then one more is phakic IOLs. See, remember when you have such a thin cornea which is ectatic or protruding out, you can't think of doing laser surgery on that, because you do it and there is all chance of further weakening of the cornea. Correct? What do you do in laser surgery? You lift up a flap, fire laser and make the cornea thinner to correct for the refractive error. Now with this cornea already being so thin, you can't even think about refractive surgery on the cornea. That is when you decide to place a lens. Once all this disease is stabilized, you still want to give better vision to the patient, you place a lens on top of the existing crystalline lens. That is why it is phakic. Phakic means the existing crystalline lens is already there, you're not disturbing that. On top of that, you're placing another lens that is called as phakic IOL, intraocular lens. Okay, so these are all different types of ways to manage keratoconus. So once again, I'll tell you students, keratoconus is a very important topic from NEET PG perspective at the undergraduate level. Just to know the basics, how do you diagnose and treat? Okay. Right. Let's move on to our next question. A patient presents with unilateral proptosis and bilateral sixth nerve palsy. What could be the possible cause? Remember, whenever you talk about a bilateral problem, it has got to do with some structure which is present on either side of the midline. Correct? So let us see the options. Cavernous sinus thrombosis, orbital cellulitis, retinoblastoma, and thyroid ophthalmopathy. Okay, now what are the conditions in this which can happen bilaterally? Retinoblastoma can happen, yes. Orbital cellulitis possible, yes. And if the patient is very immunocompromised, yes. Thyroid orbitopathy, yes. And cavernous sinus thrombosis, yes. But how many of them affects the sixth nerve? They are saying bilateral sixth nerve palsy, but the proptosis is unilateral. If this is bilateral, at least we can think of these causes. Thyroid cannot directly cause this. Retinoblastoma cannot directly cause this, because they are all intraocular, like they are not going have nothing much to do with the sixth nerve, right? Orbital cellulitis again is the much more anterior pathology and nothing to do with sixth nerve, whereas cavernous sinus thrombosis has a lot to do with sixth nerve. So the answer is cavernous sinus thrombosis, and I will tell you why. See, it is the most probable cause of both unilateral and bilateral abducent palsy. It is one which occurs when there is a blood clot which forms within the cavernous sinus, a venous sinus located in the base of the skull behind the eyes. It contains the sixth nerve within its substance. This is what I want you to know for a fact. See, other cranial nerves are a part of the wall of the cavernous sinus, whereas sixth nerve is a part of its substance, which is very much within the content cavity of the sixth nerve. I'll show you the image, then you will understand better. See here, these are all cranial nerves which are there in the wall. Whereas see this is our abducent nerve which is bang in the center within the substance of the cavernous sinus. So it is the nerve which gets involved the earliest in a cavernous sinus thrombosis. Okay, so that is important. The earliest nerve to get affected in CST also is sixth nerve, because you can see why, right? And it is also very commonly involved in carotico-cavernous fistula. Why? Because it is very close to carotid artery, correct? Internal carotid artery. So these two conditions, sixth nerve is a very, very important thing you should not miss. Okay, so let us see. We already discussed this, that lateral rectus is supplied by sixth nerve, which brings about the abduction of the nerve, right? Abduction of the eye. So what are the findings? Usually unilateral, can be bilateral. Why? Because there is an intercavernous sinus, intercavernous connection between the two sinuses on either side of the sella turcica, the middle line. Okay, so they are connected by interconnecting channels, and hence the infection from one area or the thrombosis from one area can easily spread to the other side without having to wait for the infection to happen on the other side of the face. Okay, so usually unilateral, can be bilateral. Orbital congestion, lacrimation, chemosis, eyelid swelling. Okay, all of this is because when there is cavernous sinus thrombosis, it is the main reservoir for drainage of all the veins from the eye and the orbit. So when there is obstruction there, none of it is going to drain, and hence eventually they are all going to bulge up, have stasis, and that will result in this problem. So sixth nerve palsy results in ophthalmoplegia, proptosis because of venous congestion, and they can also have corneal anesthesia. Why? Because 5-1, that is ophthalmic division of trigeminal, is in the wall. Okay, so ophthalmic division gets easily involved, because of which you have corneal anesthesia. Facial numbness again because of V1, V2, and Horner's syndrome. Why Horner's syndrome? Because the sympathetic plexus travels along with the internal carotid artery, just winding around it, and it is going to come and supply the pupil, and of course the other parts of the eye through the ciliary ganglion and etc. Not ciliary ganglion, through the sympathetic plexus. See, this is again a fancy name that is given because those days they used to value such findings to identify the site of lesion. So when there is Horner's with sixth nerve, it is called as Parkinson syndrome, and you know the fact that it is in the cavernous sinus. Clear? So this is why identifying multiple symptoms and coexisting findings are crucial to localize the lesion. Clear? So this is what I wanted to let you know. And yeah, this table I put here because I want you to know that cavernous sinus, though is an intracranial venous sinus, the affection and the involvement are because of relatively different reasons. Okay, see, cerebral venous sinus thrombosis, like superior and the inferior sinuses, sigmoid sinuses, okay, sagittal sinuses, so all of them they get involved because of other reasons, like you talk about consumption of OC pills, okay, oral contraceptives, and if the patient is on hormonal therapy, okay, these are all reasons for that to get involved. And also remember, the cavernous sinus is very notorious to get involved because of any infection in the face. You must be knowing the dangerous area of face, right? This is the nose, this is the lips, and they draw a triangle like this. So any infection here, you should not, break your pimples and things they say, because there is these venous sinuses, they do not have the venous connections, they do not have valves. So directly carry it into the cavernous sinus, and that can lead to thrombosis. So see here, person with recent facial infection, anything, even otitis media, those things are also drained by the cavernous sinus. So all these infections are an important source of CST compared to CVST, which is because of other reasons. Okay, and CT is more useful here than MRI, MRV, because here the source of the problem can also be easily identified. Let's say there is orbital cellulitis, or if there is any other otitis media or things like that, cholesteatoma, they are better identified with CT compared to this thing. And treatment again is different. This is more of oral anticoagulation, because that has not much of an infective etiology, whereas antibiotics and steroids with or without is the main role of treatment in cavernous sinus thrombosis. So they are slightly different, though they may be both intracranial venous sinuses. So I hope it is clear, right? So along with that, it is also important to know that this cavernous sinus drains through superior and inferior, ophthalmic veins and vortex veins, etc. So learning a little bit of cavernous anatomy is anyways important beyond ophthal also. So I hope you make yourself quite familiar with the anatomy of cavernous sinus. Clear? So with that we come to the end of this question. Let's move on to another interesting one. Esotropia is commonly seen in which condition? A. Myopia, B. Hyperopia, C. Astigmatism, and D. Emetropia. So it cannot be emetropia because or else everybody will be having esotropia, correct? Emetropia is basically the patient does not have any refractive error, so that is not the right answer. See, the basis, or I should say the foundation of entirety of the squint and refraction lies in one concept of accommodation and convergence. I will break it open for you today. Remember the triad of near, which everybody knows. It's not something that you've not heard of. The 3 C's, correct? But just knowing it is one thing and applying it is another. So what are the 3 C's? Convergence, constriction of pupil, and curvature of lens. Constriction of pupil, curvature of lens increases. So they happen together. That's it. This is the mantra of squint and refraction. Okay. So the moment there is increase in the curvature of lens, you should know that there is increase in the convergence. Clear? Which is the refractive error? Where a person tries to increase the convergence of lens in order to compensate for his or her refractive error. That is the answer to our question. Are you clear? So the patient wants to increase the curvature, and by doing that, because these 3 happen together, they are unfortunately increasing the convergence, leading to esotropia. That's all. This decodes the question for us. So tell me, which is the refractive error that needs increase in the curvature, or in another way, more of plus power? It is hypermetropia. So the answer blindly you should say is hypermetropia, because this is the reason. Always remember that convergence and curvature increase. What is this increase in curvature that I am talking about? It is simply an effort to accommodate. The patient is going to try to see what is hypermetropia. Farsightedness. Why is it farsightedness? Because the patient is having difficulty in being able to see near. So all the patient is trying to do is basically try to focus for near by increasing the curvature, but while doing that, the eye is going in for ESO. Okay, but it is not as simple as this. Now there is a concept of AC by A ratio. I will not confuse you too much with all this, but just basic things I want to tell you is AC by A ratio is accommodative convergence by accommodation. That is, for every diopter of accommodation, how much accommodative convergence is happening. Okay, remember this is not the same for all. This is done in prism diopters. Okay, it varies from person to person. If this ratio is high because of whatever reasons, okay, let's not deal with that. If this is high, what usually the patient ends up doing for what a normal person does, the convergence becomes way more than what a normal person does. Okay, so the AC accommodative convergence is very high. So for one diopter, the patient might end up converging way more than 15 to 20 prism diopters. That results in excessive inward divergence, or that is called as esotropia. Okay, so we'll see here. Children will develop excessive amounts of eye crossing, esotropia at near, such as while reading. Okay, so what are they doing while reading? They're basically trying to see for near, and that is what is causing this esotropia, correct? So accommodative convergence, and that results in esotropia. This is an effort to correct farsightedness, hyperopia, and they may have perfectly straight eyes when looking at distant objects. So you should not forget that they can actually have absolutely normal looking eyes when they are looking at distance, because they are not having any effort to try to see for near, right? So that AC by A ratio, none of that comes into the picture at all. So you don't have to worry about it when the patient is looking at distance. And many patients, they look at distance, we won't even pick up the squint. So that is why you ask the patient to look for near also when you are trying to assess for squint. Right. So ESO deviations, latent or manifest convergence of visual axis. It is also the most common deviation, which is seen around 50 to 75%. Okay. So first is pseudo esotropia. Okay. What is this pseudo esotropia? So sometimes what I've noticed is the examiners want you to know the pseudos of things. Okay. So what is this pseudo esotropia? So pseudoesotropia is when the patient is actually orthophoric but has the appearance of esotropia due to several reasons. What are the several reasons? I'll tell you. First is the patient has a broad nasal bridge. So when this happens, what is the main problem? The broad nasal bridge, right? So the eyes will look as if they are very close to each other. Okay, or if it's slightly to one side, the eye will look as if it is turned inward, but it's actually orthophoric, right? Second is prominent medial epicanthal folds or negative angle kappa. So what is this prominent epicanthal fold? So remember, this is the eye, right? So when this eye comes here, correct? So when this eye comes here, the fold of skin, okay, this is the eye. There is an extra fold of skin that runs from the medial canthus to this one. So when that happens, this fold of skin makes it look as if the space is reduced. Okay, that results in what I said as esophoria, pseudo esotropia, right? Negative angle kappa is little complicated. I'll just try to explain this with a picture. So there are different axes as far as vision goes. Okay, one is the pupillary axis, second is the optic axis. Okay, so these points are for I would say calculation purposes, they take different points between two different lines between two different points in order to understand the orientation of the eye. Okay, so here, for example, the optic axis is between the center of the fovea and the object of interest. Okay, that is optic axis, whereas pupillary axis is the line that runs bang in the center of the pupil, right? So when there is a slight difference in these two, okay, that is called as angle kappa. Okay, so when patient can have a negative angle kappa, it looks as if the eye is in esotropia. So these are all the causes of pseudo esotropia. Clear? Now one more word I want you to know is phoria and tropia. Phoria means, phoria is latent. Excuse me. Usually you don't identify, but if you close one eye, then the squint becomes prominent. That is called as phorias. Phoria means latent deviation. Okay, it is controlled by fusional mechanisms, may manifest under certain conditions. Intermittent is when it is not often present but seen occasionally by the parents, and when they come to us with a video of noting that, but when we examine it may not be there. So we have to know that these are all different types of tropia. Same thing applies also to exo also. Exophoria, exotropia and things like that. Okay. So esotropia is clear cut. There is no, confusion at all. There is squint all the time. Right? So with that, we come to the end of that question. Let us move on to the next one. A 15-year-old female with myopic astigmatism refuses to wear glasses. What would be the ideal management is what they are asking. Option A, LASIK. Okay. Option B, femtolasic. Option C, ICL. And option D, spherical equivalent lenses. Right? So remember, you're talking about a 15-year-old girl in this question. Correct? So most of these options are actually refractive surgeries. And remember, nothing before 18 or even after 18, not before the power is stable for 1.5 years, can you even bother about considering refractive surgery. So LASIK is out, femto-LASIK is out, and ICL is nothing but implantable collamer lenses. Okay, these are again intraocularly placed lenses on top of the actual lens, and that helps in correcting the refractive error. Now, the simplest way which we are left out with is spherical equivalent lenses. What are these spherical equivalent lenses? See, the most appropriate management for a 15-year-old girl who is not compliant with her glasses for her myopic astigmatism. What is myopic astigmatism? You have to give minus lenses along with cylindrical lenses. Correct. So you have to give it along with cylinder. Now the problem here is, many times when you include a cylinder, some patients they are not very comfortable because it causes a little bit of an image distortion in the image. Okay, like for example, I'll tell you, this is one of the complaints of patient whom I had to deal with myself. So this patient was a user of computer. Of course, he was doing his college days. Okay, whenever he used to see the laptop after changing to new spherical with cylinder lenses, the monitor used to appear more of a trapezoid rather than a rectangle, meaning the lower end or the upper end used to be like much lesser in width compared to the bottom. So these are some of the complaints that they have, and this, the patients may not be in a very knowledgeable position to be able to tell us that okay, this is what has gone wrong, that is not right. So it is our duty to pick it up. So that is when the spherical equivalent lenses come into great help. Now what are the spherical equivalent lenses? See, I'll tell you first what is spherical equivalent. Now equivalent means something that is almost the same but not exactly the same, right? So or else it would be equal. So equivalent is you try to mathematically substitute the cylinder using sphere. How do you do that? This is the formula. Spherical equivalent is sphere plus cylinder by 2. That is half of the cylinder's power is to be added in diopters to sphere, and you give it that lens. See, the quality and the accuracy of vision may be slightly not up to the mark, but the comfort of vision may improve. So that is why in this patient, that is a very ideal way about going it. And we saw already, right, Sturm's conoid. So this is again a problem with astigmatism. So what happens? Sturm's conoid is like this, I told you, and when these converge, okay, so they are going to converge at different points, correct? So this is the interval of least confusion. That is, only here will the patient be able to see somewhat clearly. So we saw an oval here, we saw an oval here, and here the midpoint, okay, is where the image is formed as a circle. And this is called as circle of least confusion. Is it clear? So circle of least confusion, and our aim of doing all of this, changing it to spherical equivalent, etc., is to try to get the circle of least confusion to fall on the retina exactly. Okay, so in astigmatism you need to give cylinders, and this circle may not be falling on the retina. So we have to try to, as you can see here, see, the patient is getting distortion because either the image is more towards this or more towards this, right? So that is the problem, and to address that, this is one way to go about it. In spherical equivalent, remember there is no cylinder. You are trying to compensate the cylinder by giving an additional sphere. Is it clear? So let's see the explanation. The most appropriate way is spherical equivalent, correct? They are non-invasive and reversible option that can effectively improve the visual acuity and provide clear vision when worn. In case of a non-compliant patient, it is important to choose a management option that is simple, convenient, and easy to use. Spherical equivalent glasses meet these criteria. They only require the patient to wear them during waking hours to achieve clear vision. Okay, so this is the point. See, we saw about astigmatic dial, right? So this is another point of learning why we need to, or how we can apply the Sturm's conoid in practical ophthalmology. Clear? Right. So with that, we come to the end of that question. Let's move on to the next one. So here we are seeing a case of a 1-month-old baby, okay, coming to us with watering eyes and a cloudy cornea. They just say identify the diagnosis. Okay, so cataract, can it be cataract? Possible. Congenital glaucoma, ophthalmopneumotroph, mucopolysaccharidosis. All of them can cause corneal opacities or opacities in the media, not corneal opacities. But remember, it's a 1-month-old child. Okay, the cataract will not have a cloudy cornea. Watering of eyes also will not be there. Ophthalmopneumotroph, watering of eyes will be there, but they will not have cloudy cornea. Mucopolysaccharidosis, they will have cloudy cornea, but not watering of eyes. Can you understand? So this question actually tests you on different fronts. They expect you to know about ophthalmopneumotroph and mucopolysaccharidosis to be able to say that it is not the answer. So these conditions like ophthalmopneumotroph and congenital glaucoma, which is the answer for this question, excuse me. So these are all very high yield topics and easily one-liners can come from them. So right, let's continue. So I was saying the most probable diagnosis is congenital glaucoma. What is congenital glaucoma? See, in congenital glaucoma, there is an abnormality in the development of angle structures. I'll show you the image. See, this is trabecular meshwork. This trabecular meshwork actually should be allowed to be having a way once, see, this A is normal development, B is abnormal development, okay. So what happens, this actually should recede back, okay, can you see here, and this should open up, clear. So only when that happens, the fluid can come here and get out through the trabecular meshwork, correct. But what happens, instead of that happening, this movement does not happen at all, and there is a membrane that is formed here, okay. Remember the name, it is Barkan membrane, Barkan membrane. Is it clear? So this Barkan's membrane is the reason for the fluid to be not able to exit the eye through the trabecular meshwork, right? So why does what has all of this got to do with the manifestation we are seeing here? Let's see. Lacrimation, photophobia. Okay, and cloudy cornea. This is a triad that you see in case of congenital glaucoma. Okay, why is there clouding of cornea? Because when there is lack of drainage, there is increased IOP. Whenever there is increased IOP, this increased intraocular pressure, no, it pushes the fluid inside the stroma of the cornea across the descemet membrane. Okay, so it is called as being more than imbibition pressure. Imbibition. So when the fluid enters into the stroma, it is no longer transparent because the corneal fibrils are disturbed in arrangement. Okay, so that results in a cloudy cornea. Excessive tearing or epiphora, because they are not able to drain properly. Yes, so lacrimation I told you, right? Because the corneal nerves are also stimulated. Okay, they are stimulated to a great extent because of this disturbance in the corneal homeostasis, and that is the reason for that. Light sensitivity is because the corneal nerves are stimulated, they are very sensitive to light, like we get in case of corneal ulcer, right? So when all the homeostasis in cornea is disturbed, these features happen. Okay, photophobia, lacrimation, and cloudy cornea. Now coming to this very important feature called as buphtalmos. What does buphtalmos means? Ox eye. So because the fluid anterior chamber intraocular or the AC is not draining properly, okay, aqueous is not draining properly, the whole eye, and remember the sclera is very much stretchable in a child, in a baby. It is still not very rigid, so it's like a balloon, okay, which gets bloated up with a lot of fluid getting accumulating inside, and it looks as if the eye is so big like that of an ox. That is why the affected eye may look larger than normal, and that is why it is called as ophthalmos. Okay. Now redness and swelling of the eye, it may appear red and swollen. Okay. This is not always seen, but it can also be seen. Okay. So treatment is definitely surgical. Okay. You can't say I'll put anti-glaucoma medications only and wait till the child grows up. No. Okay, once you get the pressure under control, you have to first examine under anesthesia. Okay, so for that, the corneal edema first has to settle. Once the corneal edema settles, you can examine under anesthesia and then decide on the type of treatment you want to go for treating this. Okay, goniotomy is the preferred choice in less than 1.5 years of age. Okay, and what do you do here? You actually incise the trabecular meshwork under direct gonioscopy. I told you, right, we discussed about different types of gonioscopy. So in the theater, direct gonioscopy, what were they? Kopy and Richardson. Okay, Kopy and Richardson. So use Kopy's lenses and you cut open the trabecular meshwork, but remember it requires clear cornea. If the cornea continues to be cloudy, there's no point doing that. You have to do through an external method called as trabeculotomy. Both are otomy, remember. Okay, it's an ab externo procedure. Okay, if the goniotomy fails twice also, you need to do this. Instead of trying to visualize it from the outside into the eye, visualizing the angle, you do it from outside itself. If both of them don't work, you do a conventional trabeculectomy with mitomycin C. Okay, trabeculectomy, remember, is the surgical treatment for glaucoma even in adults. Okay, so in cases where both of them don't work, you have to go for trabeculectomy in adults. Okay, so I hope you understood the treatment modalities for congenital glaucoma. And lastly, which is not often done at all, if you ask me, is the cycloablation of ciliary body, which is a cyclodestructive procedure is what we call it. We don't do it in children because the eye will go in for phthisis. Okay, in very old adults, in aged people who have no vision in the eye, okay, it is PL negative, that is perception of light negative. Okay, in such patients, when the eye is painful blind eye, we do cyclodestructive procedures, not often done in children at all, because they have a long life to live. We can't straight away go for cyclodestructive procedures and result in a phthysical eye. I hope now you understood the different methods of treating congenital glaucoma. Okay, let's move on to the next question. A patient presents with the following finding. What is the most likely complication associated with it? See here that the lid is not usual. Okay, the part of the lid here is actually missing. Okay, so the question is, which of the following is the most likely complication? Okay, cataract can happen. No, cataract is about the lens inside. Difficulty in extraocular movements, it is a problem with the lid. I would say it is more like a lid coloboma. Difficulty in ocular movements is not likely. Glaucoma, not at all. So answer is exposure keratitis. See, this lid problem is often neglected by many people. Okay, when the patient is trying to close the eyes, automatically a phenomenon called as Bell's phenomenon comes into picture. Correct? But believe it or not, many people, okay, around 20% of the people may not even have a proper Bell's phenomenon, which is not pathological. It may be just absent at all for a few people. Okay, in them, when they close the eyes, the eyeball is still here and it is not going up like it does in a normal person. So in them, what happens, if you close the eye, still the cornea is very much exposed to the external environment. Like at night when they're sleeping, imagine the cornea is constantly dried and you're not blinking also, correct? So constantly dried, and that part of the epithelium becomes weak and sheds off. When that happens, an epithelial defect develops. So that is called as exposure keratitis. It is a condition where cornea becomes dry and damaged due to inadequate eyelid closure and incomplete blinking. Okay, leading to exposure of the cornea to the environment. In severe cases, it can cause corneal ulceration and scarring. I told you, right? When the cornea is affected, it can result in discomfort, pain, blurred vision, we know. Affected individual may experience difficulties in moving the eyes freely due to discomfort caused by the exposed cornea. So the difficulty in ocular movements was an option, but more apt option here was exposure keratitis. Okay. This in that case can lead to restricted eye movements, affecting the ability to focus on objects or track moving objects effectively. Okay, so that is the answer to that. Exposure keratitis is the answer. If the eye is well closed in a patient even with poor Bell's phenomenon, don't worry, just waking time, put lubricant twice or twice a day. Okay, but if conjunctiva is visible, you need to apply more lubricants. We even give HPMC, hydroxypropyl methyl cellulose gel, at night time, whereas if the cornea is visible, you have to take some measures like lid taping or something, or else this problem can lead to dire consequences like corneal ulcer and perforation, because this happens daily. It's not like one time injury. This is going to happen daily, every day you sleep, and this is going to create a lot of troubles for the patient in that eye. This is often following lag of thalamus, which is seventh nerve palsy like Bell's palsy, but other conditions like lid coloboma you see here also can result in this problem. So I hope now you understood the reason. Also remember the choroidal coloboma, okay, and optic nerve coloboma, they are all different. Okay, they are all because of choroidal closure problems, choroidal fissure closure problems. Whereas lid coloboma is completely different in etiology, so don't confuse that. Okay, not all colobomas, even iris. Okay, not all colobomas are because of the same etiology. Lid coloboma is a completely different problem because of the facial appendages coming together. Okay, that I want you to remember. Let's move on to the next question. Okay, a 20-year-old male presents with golden brown ring over iris on examination. What is the next done procedure to diagnose the condition? A. Ceruloplasmin, B. Serum iron level, C. Alpha-1 antitrypsin, and D. alpha-fetoprotein. So remember, again I have chosen certain questions which have a lot of relevance to a general doctor, okay, in the subject of ophthalmology, because these questions can be asked even from medicine point of view, because we have a lot of patients who are referred to us with this golden brown ring, okay, and the question here I have not changed a word, because this is exactly how they send us also. They say it is over the iris, but actually if you look at it, it is over the cornea. Okay, so the point I'm trying to say is the ceruloplasmin test that you're going to do is actually going to help you diagnose Wilson's, and many neurologists often send them to us in order to diagnose Wilson's disease and look for KF ring. So the answer here is actually KF ring. It is a ceruloplasmin test that is most often used along with the copper testing to help diagnose Wilson's. It is a rare genetic disorder, and excess copper is not removed and it builds up in the liver, correct? Now KF rings are dark rings that appear to encircle the cornea of the eye and are due to copper deposition in the Descemet's membrane. Where it is deposited is another important question. Okay, seen in Wilson's disease, and also remember it can also be seen in chalcosis also. Okay, the chalcosis lentis on the other hand is due to deposition of copper in the lens capsule, which is again seen in Wilson's disease and characteristic sunflower cataract. Clear? So this sunflower cataract and case of ring go hand in hand. Clear? And remember, it also can happen in multiple myeloma and lung carcinoma as paraneoplastic syndrome. A couple of points about KF ring. Two things. One, it starts superiorly, then inferiorly, then encircles. Okay. And secondly, it can disappear. Yes, it can disappear once you control with chelating agents like EDTA. Okay. Disappear on treatment. These are two questions which can be asked as which of the following is not true about case of ring. So these two things are important. So first it starts superiorly, then goes inferiorly, and then encircles all 360 degrees. So it is not on the iris but on the cornea. That is what I want you to remember. Clear? So we'll go for a short technical break and be right back. Right, welcome back after the technical break. Let's move on to our next question. The most common eye manifestation in Sturge-Weber syndrome. So, Sturge-Weber syndrome has a lot of systemic manifestations also, and this group of diseases put together called as phacomatosis. Okay, phacomatosis. I've tried to include one more question from there, but it is very crucial for you to know these phacomatosis because they're all syndromic diagnosis, right? So they can pop up from any subject like general medicine or ophthalmology or ENT, right? So they are multidisciplinary in themselves, which makes them a potential question from any subject for that matter, right? So they're asking what is the most common manifestation in Sturge-Weber syndrome from eye perspective. A. Uveitis, B. Glaucoma, C. Retinitis pigmentosa, and D. Keratitis. So it is definitely glaucoma. Okay. So this is very classical because the side of which the port wine stain, okay, is noted is the side which gets involved in glaucoma. This is very crucial, and that is the side which has leptomeningeal angiomatosis also. So this Sturge-Weber is actually called as leptomeningeal angiomatosis. But what I want you to know is which side gets involved by port wine stain has all the pathology starting from the eye to the brain. Okay. It is a neurocutaneous syndrome characterized by angiomas in the face, choroid, and leptomeninges. I told you. This facial capillary vascular malformation is called as port wine stain or nevus flammeus and usually seen in the territory of the trigeminal nerve. What is a triad? A red or pink birthmark called port wine stain, a brain anomaly or abnormality called as leptomeningeal angioma, and increased pressure in the eye, which is glaucoma. Clear? So this triad of which eye is a part is glaucoma. What are the other findings? Dilated tortuous vessels of the conjunctiva and episclera, conjunctival or juvenile glaucoma, especially if the upper lid is involved. I told you, right? When there is involvement of the upper lid, you have to diagnose whether the patient has glaucoma or not. So often what happens when this can be seen in middle-aged or even in children, okay, in teens. So they get referred from pediatrics and general medicine in order to rule out glaucoma because they diagnose, we send, we diagnose, they send. So that is how it works. Other findings are heterochromia iridis, angiomas of episclera. So all the vasculature, okay, around the area that is involved are abnormal. So this can also have corkscrewing of vessels. Okay, but often this corkscrewing is very classic of another condition called as CCF, which is carotico-cavernous fistula. But just remember, vessels look very tortuous. I told you it's mentioned, right? Cortico-cavernous fistula. Okay, so then I told you that the vessels in the retina can also get involved, leading to choroidal angioma, hemangioma, which is called as tomato ketchup fundus. Don't confuse it with CRAO. That is splashed tomato appearance, tomato sauce appearance. That is, it's as if it's spilled all over, whereas here it is that small area which appears in that color. That's what tomato ketchup fundus. Splashed tomato sauce or tomato ketchup, whatever. Okay. Clear? So that is it. And peripheral retinal AV malformations, just like a hemangioma which happens in the mid periphery or center, we can have AV malformations, and even the retinal pigment epithelium can get involved. That leads to pseudo RP, pseudo retinitis pigmentosa. So it is not RP in Sturge-Weber's, it is pseudo RP. That is why retinitis pigmentosa was given as an option in the 4 options in this question. So phacomatosis includes Sturge-Weber syndrome, okay, Wyburn-Mason syndrome, all these syndromes like neurofibromatosis, tuberous sclerosis. Tuberous sclerosis causes retinal angiocytoma, astrocytoma, okay. So that is another condition, okay. So these phacomatosis are very, very important from any entrance exam point of view, any subject, okay. Right, let's move on to the next question. All of the following are causes of expanding blind spot except. So first is optic disc hyperplasia, papillary edema, metilated nerve fibers, and POAG. So I think I gave you the answer away. So remember, what is this blind spot caused by? Only then you will know the enlargement. So blind spot is the part of the retina where there are no photoreceptors. Okay, so the entire retina has photoreceptors of different density. Of course, the central part has more, periphery has lesser intensity, but this optic nerve head, where all the retinal ganglion cell fibers exit the optic nerve, it is actually a space. There's no photoreceptor there, right? So it doesn't pick up light, and hence that is what is actually the reason for blind spot. Clear? Now, anything that increases this area of non-visibility is going to cause increased or enlarged blind spot. So, optic disc hyperplasia is a pathology of optic disc, yes. Okay, papilledema, yes. Okay, because there's going to be fluid accumulated around the optic nerve. Metilated nerve fibers are nothing but loss of or failure of disappearing of metilations around the optic nerve, and they appear like yellowish fibers. So all these three cause, whereas POAG, there is actually death of cells within the optic disc, not the around the optic disc. Clear? So that is why primary open angle glaucoma. So I told you, right, POAG is a recognized abbreviation in ophthalmology. So some abbreviations we need to know. Clear? So the blind spot in your field, also called as physiological blind spot, is a small area on the retina where there are no light sensitive cells, and as a result you cannot see objects that fall within this area. Clear? So primary open angle glaucoma typically does not directly cause an expansion. However, it can lead to visual field defects. We will be discussing that. Okay, but however said and done, it does not cause an increase in the physiological blind spot. No. Okay, it is damage due to increased intraocular pressure, can result in specific types of vision loss. What are the reasons for enlargement of blind spot? Often remember, they are neurological or neurosurgical emergencies. Like papilledema. Why does papilledema happen? Papilledema, remember, is only papilledema when there is fluid accumulation in both the optic nerves, not only one. If it is one side, it is disc edema. And papilledema is a term that should be used only when there is an increase in the intracranial pressure leading to increase in the fluid collection around the optic nerve, not otherwise. Okay, so anytime you say papilledema, you must remember that there is something wrong inside the eye, inside the head, which is increasing the intracranial pressure. It could be anything. Okay, so that means it is something that you need to refer to a neurologist or a neurosurgeon for identification properly and management. Okay, so extremely high blood pressure, okay, extradural or subdural hematoma, cerebral abscess, okay, bitemporal hemianopia is seen in pituitary tumors. Okay, so these are all cases which cause enlargement of blind spot because of papilledema, pituitary adenoma. Okay, some ophthalmic conditions also cause. Okay, so of them is optic disc drusen, tilted disc, peripapillary atrophy, especially in long-term aged degenerative changes, they also can cause. So some important causes we've learned. So what does enlargement of blind spot look like? It looks like this. See, this is the blind spot. Around the blind spot you see a scotoma. Many times it's not as typical like this, but yes, an ideal picture would look like this. Clear? So blind spot enlargement is something which should be treated with most urgency and identified with the cause. Okay. Let's move on to another question from a new topic of retina. Identify the following pathology in the histopath picture given below. Okay, so this is a histopathology of retina, because see, these are all the bipolar cells and other things, and this is the photoreceptors. So this is the RPE. So it is between RPE and Bruch's membrane. So it has to be drusen. Let's see what drusen is. Drusens are extracellular deposits of lipids, proteins and cellular debris which are collected within or beyond the layers of retina. They are small globular plaque-like deposits between the basal lamina of RPE and the inner lamina of Bruch's membrane. So this is the basal lamina of RPE, okay. This is RPE and this is Bruch's membrane, and exactly between the two, not only does it get deposited, it also elevates the RPE like a mound. Okay, so that is another important identification. One more point is they show autofluorescence. Okay, it is not fundus autofluorescence, fundus fluorescent angiography. It is fundus autofluorescence, which is they have an ability to fluoresce even without having to inject dye. Okay. Next question. So drusen, where do you see drusen? I'll just touch upon a little bit about it. So AMD, what is AMD? Age related macular degeneration. Okay. So this AMD is two types, dry and wet. So dry ARMD is manifested by drusens. Wet ARMD has multiple types. Just remember that CNVM, okay, is one aspect of wet ARMD. Okay, drusens again can be different sizes. Okay, small, medium, large, 63 microns, less than 63, 63 to 125. These are all not necessary for you to know, but what I want you to know is more than 125 microns. Okay, this drusen is typically seen in ARMD, okay, age-related macular degeneration, and this drusen over a period of time can further cause retinal thinning and lead to what is called as geographic atrophy. Geographic atrophy. Now they can get deposited in different patterns. Okay, there are a lot of fancy names about it, malatesia, levitensis, etc., etc. But remember, drusen is a typical sign that you need to pick up in patients with age-related macular degeneration, and not confuse it with hard exudates. Okay, hard exudates, which is seen in conditions like diabetic retinopathy and hypertensive retinopathy, etc. They are all in the outer plexiform layer. See, this is actually a histopath picture, but what we see is actually OCT macula, which is a live cut section of the retina, right? So there you need to identify the lesion based on the site of the lesion. Where it gets deposited determines the type. You can't really take a sample from the retina, right? So hard exudates are seen in DR and HTN, diabetic retinopathy and hypertensive retinopathy, excuse me. Whereas these are drusen is seen in ARMD. So ARMD dry type is characterized by presence of drusens. Okay, let's look at the next question. Again, neuroopthal, which of the following is the nucleus for upward gaze? So remember, these are all one-liners. There is nothing in detail you need to understand, conceptualize about it. This is a straightforward question. The answer is interstitial nucleus of Cajal. Okay, so there's one in cerebellum also, but this is another one. Okay, so this group of cells within the medial longitudinal fasciculus of brainstem. Okay, MLF. You know where it gets important? This medial longitudinal fasciculus is what is involved in INO, internuclear ophthalmoplegia. Okay, so do give it a read, just know what it is at least. Okay, this MLF is responsible for maintaining the ocular control and head posture. Okay, this lesion problem here will lead to a problem in upward gaze. So let us see the pathways in brief. I've got two good pictures which explain this quite nicely. Okay, so this is in up gaze. This is the rostral interstitial nucleus of Cajal, okay, of MLF. So from there, the posterior commissure to the third and fourth nerves. Okay, this is for up gaze. Why third and fourth? Okay, so here you need contraction and relaxation of certain muscles to bring about up gaze. Okay, whereas down gaze, same way, it is from the rostral interstitial nucleus. Okay, and it also goes down gaze also. Okay, so up gaze pathways originate in rostral interstitial nucleus of MLF and project dorsally to innervate the oculomotor and trochlear nerves, and lesion to both the axon bundles are necessary to produce the up gaze problem. Okay, it is a feature of the dorsal midbrain syndrome. Okay, down gaze also originate in there, but probably travel more ventrally, and bilateral lesions are needed to affect down gaze. So you need to know that the pathways of upward gaze and down gaze are almost the same, whereas lateral gaze is different. That is PPRF. I'll just add a point here. The lateral gaze, okay, medial and lateral gaze, that is by parareticular pontine formation. Okay, parapontine reticular formation. Parapontine reticular formation. Okay, so no, vertical is internuclear rostral internucleus of Cahal, okay, of MLF, whereas PPRF is for horizontal gaze. Clear? One word you need to know for both: MLF vertical, PPRF horizontal. Clear? Great. So just knowing a little bit of anatomy, and in fact functional anatomy, can be tested in our exams too. Okay, right. A band shaped keratopathy is due to deposit of which of the following? Calcium, amyloid, iron, melanin. So the answer is calcium. Also remember, the reason I put this picture is because sometimes they don't even tell you the diagnosis that this is band shaped keratopathy. They'll just give you the picture and say which of the following. Of course, it could be anything like amyloid also, which presents like this in types of corneal dystrophy. But what I want you to know is, we saw a Swiss cheese there, no? Swiss cheese appearance in case of adenoid cystic carcinoma. This band shaped keratopathy also has a Swiss cheese appearance. That is why I put this picture here. Can you see these holes? They're actually here also. I don't know if you're able to see. Okay, these holes are nothing but amidst the deposition of calcium, there is a penetration of the corneal nerves which creates these openings. Okay, so this looks like a Swiss cheese appearance. Clear? And it is because of calcium and nothing else. So band shaped keratopathy is due to dystrophic deposition of calcium. It is a disease process which occurs from subepithelial calcium hydroxyapatite deposition, leading to opaque band like horizontal plaque across cornea. It is a band like deposition. Okay, this opacity often impacts the visual axis, leading to decreased visual acuity. Multiple causes can cause this BSK. Okay, most common is uveitis. Remember, uveitis, that too in a condition called as JIA, juvenile idiopathic arthritis, is very notorious. Anterior uveitis happens here. It is very, very notorious to cause band shaped keratopathy, interstitial keratitis, superficial keratitis. See, all conditions which linger around chronically. Okay, phthisis, sarcoidosis, trauma, intraocular silicone oil. See, this is a iatrogenic cause. What happens in retinal detachment? For maintaining the attached retina following surgery, we infuse silicone oil in the vitreous cavity. Even that over a period of time can cause silicone oil deposition, leading to band shaped keratopathy. Vitamin D intoxication, Fanconi syndrome. See, all of them are situations, milk alkali syndrome, all of them are situations which cause excess of calcium and decrease in phosphates or counter calcium substances. And so overall calcium, whenever it is high, okay, or calcium is deposited as a result of inflammation. These are the two reasons why this gets deposited in the cornea, leading to band shaped keratopathy and drop in vision. Clear? So some causes I have mentioned it here, but remember, most important cause as far as an ophthalmologist goes, it is uveitis and interstitial keratitis. That's why I put them as the first two causes. Of course, phthisis, all of them are also known to cause BSK. Clear? What is important is it can happen or be put across as a question without giving you a diagnosis that it is BSK. It is that much of a spot diagnosis is what I am trying to say. Right. Let's move on to our, before that, I told you that it is calcification of basement membrane of the epithelium, Bowman's and anterior stroma with the destruction of Bowman's membrane. Okay. So calcium salts are extracellular so I was telling you that calcium deposition can happen when there is excess of calcium, but the cause will determine where the calcium gets deposited. See here, when the process is due to local ocular disease, it is extracellular in deposition, whereas systemic calcium metabolism problem like milk alkali syndrome, hypophosphatemia it is intracellular. So this is the way it differs in deposition of calcium between the etiologies. How do you treat? Chelate with topical disodium EDTA, okay, ethylene diamine tetraacetate acid. And also remember, other things which can cause this deposition are gout and hyperuricemia, but that is because of deposition of urate and not calcium, and that also results in this kind of a band, but it is more brownish in color, unlike here what you see as a whitish band. Clear? So uveitis is also a major contributor to causes of band shaped keratopathy. I hope I made myself clear with BSK. Okay, let us move on to the next question. Very simple. It may look very simple, but there is a lot we need to know about this question. A subconjunctival hemorrhage is seen in all except. Always remember, students, even in our other lectures, I've always mentioned, be very careful about all except questions. Always have an eye out for this word of except, because it completely changes the paradigm of how we look at it. So first is passive venous congestion, second is pertussis, trauma, high IOP. So while you think about it, what is the cause of this subconjunctival hemorrhage usually? Remember, trauma is the most common cause. Okay, so how so common? Because in our post graduation days, or sometimes even in undergraduation, they ask what are the non-traumatic causes of SCH. You see, everybody says trauma. First thing they ask is what are the non-traumatic causes. So passive venous congestion, yes, it causes, because there is so much increased intravenous pressure that there is oozing out. Where do you get such image or pictures? We discussed, right? Cavernous sinus thrombosis or any orbital apex syndrome, tumor pressing on to the superior and inferior ophthalmic veins. They all cause venous stasis, increase in the hydrostatic pressure, and some amount of blood oozes out into the subconjunctival space. Pertussis. What is pertussis got to do with this? That's a thing that's got to Bordetella pertussis is going to affect the lungs, those sort of things. Why coughing? Why here? Because remember, every time a person has a bout of violent cough, the pressure and the tension inside the vessels of head and neck increases. Okay, so that episode or multiple episodes of such similar cough can actually lead to subconjunctival hemorrhage because of rise in the intracranial pressure. Again, the venous drainage is impaired, and that results in this problem. So pertussis can cause. Trauma, we all know, can cause. High IOP does not cause. Remember, glaucoma cannot manifest with subconjunctival hemorrhage unless there are other reasons to cause that. Like I told you, right? Keratoconus fistula, okay, or Sturge-Weber syndrome. Those things where there is a vascular pathology associated with glaucoma, yes. But simply a rise in intraocular pressure will not lead to subconjunctival hemorrhage, because these vessels are outside and the pressure that's increasing is within the anterior chamber. So one should not confuse between the two. Let's look at the list of causes. Okay, violent coughing, powerful sneezing, heavy lifting, vomiting. In fact, patients who have a lot of vomiting following food poisoning, etc., they also have this kind of so whenever patients come to me with SCH and then tell me that they've not had any injury, first thing I ask them is whether they've had any recent episodes of vomiting, because they don't even think it's relevant and they don't tell us. Heavy rubbing of eyes, very interesting and common also. So the vessels in the conjunctiva, they're very fragile. So I've seen patients who rub the life out of these eyes when small dust falls. And what happens when there is a abnormal friction against the underlying sclera or the overlying lid, these vessels can get ruptured. Severe eye infection. I'll tell you what is eye infection in the next slide. Okay, and trauma. What are the risk factors? Hypertension. Already the intravascular hydrostatic pressure is high. Their vessels are fragile. That's more than enough. You touch it, it will bleed. Blood clotting disorders, we know why it bleeds. Diabetes is also said to predispose. So what do you do for subconjunctival hemorrhage? First is, it looks very scary when the patient looks at the mirror. They don't know that it is just subconjunctival. They'll be so scared. So first thing is to reassure the patient that it is not something that you need to be drastically worried about, and it is going to self-resolve. Posterior extent is important. Remember, sometimes when there is trauma not in the eye but in the forehead, there is a tendency for people to identify ecchymosis and subconjunctival hemorrhage. So the posterior extent is crucial. If you're not able to make out the posterior extent, you definitely have to do a CT to look for any anterior fossa hemorrhage or something, because it is actually continuation of that. The floor of the anterior fossa can get broken, and that can actually manifest as SCH, and that can actually look like an ocular problem. But you need to see the posterior extent. If it is not made out, it's not just the eye that is involved. And vitamin C has a very important role because it strengthens collagen. So it really helps in healing process pretty much. Now, this is what I was talking about. These are the notorious organisms which cause hemorrhagic conjunctivitis. Okay, hemorrhagic conjunctivitis, and this enterovirus 70 is the top of the list actually. So enterovirus 70 and Coxsackie, okay, these are all viruses. When they affect the conjunctiva, they cause conjunctivitis, and they have a propensity to damage the conjunctival vessels. That results in manifestation as SCH rather than just simple congestion and discharge. Okay, so that is why I wanted to keep it separate. Okay, let us move on to some basic sciences. Sclera is thinnest at which of the following areas? One is limbus, 2 insertion of extraocular muscles, 3 optic nerve, and 4 on the nasal side. Now, why do we have to bother where it is thinnest? See, sclera being thin, first, any cases of blunt trauma like punching of the eye or a tennis ball coming and impacting the eye, there is always a risk of not perforating, there is always a risk of ocular rupture or globe rupture. Okay, and where does any closed cavity rupture? At its weakest point. So sclera is a structure which covers almost entirety, and of course cornea. Now, if a patient is presenting to you, okay, with a history of a tennis ball or a cricket ball coming and hitting the eye, and you look at the patient's eye, it looks very swollen up, okay, and when you retract the lid and see, the cornea is intact, but the eyeball looks very collapsed, or very, the lid may be appearing swollen, but the eye may be actually very supple. Supple is the right word. Okay, so you know that somewhere the eyeball has given way. Now, where will you go searching for it? You will try to search it at the places where it is most gullible or vulnerable to rupture, and that is why you need to know the thinnest point of sclera. Is it clear? So, of all these options, if you look at it, the actual answer is insertion of extraocular muscles, and they say just anterior to the insertion of extraocular muscles. On the other hand, sclera is quite thick at the limbus and also at the site of exit of optic nerve. Except for that, across the optic nerve, it is a small perforated plate called as lamina cribrosa. Clear? So this lamina cribrosa is a perforated plate of sclera through which the optic axons exit. It is thinnest, just behind the insertion. I said anterior, just behind the insertion of rectus muscles, and thickest at the posterior pole around the optic nerve head. I told you, right? So that is not the place you, luckily it is quite thick there. Or imagine as ophthalmologists, when we try to explore the wound, how in the world can we go and reach the optic nerve right bang at the posterior most aspect? So that is not the common site of perforation. Okay, it is 0.4 to 0.5 mm, just slightly thicker at the equator, and 0.6 mm thick anterior to muscle insertion. So 0.3 posterior and 0.6 anterior. So around the extraocular muscles is where it is highly probable that you are looking for a opening or a perforation of this globe at the time of wound exploration following blunt trauma to the eye. Clear? So you see here, this is a nice pictorial representation saying the same thing. Okay, so that is one thing. Now secondly, another clinical application I will tell you, just to remember these facts. In squint surgery, you have to actually isolate the muscle from its insertion. Either you tighten it, which is called as resection, or loosen it, which is called as recession. All that is okay, but you have to be extra careful when you're trying to release the muscle from its insertion, because the sclera is very thick just posterior to it, right? So in order to try to cut off the muscle, you shouldn't end up perforating the globe and causing the globe to collapse. After all, that patient would have been coming for difficult extraocular movements. Now, once you perforate the globe, gone case, the patient is going to develop all sorts of intraocular complications and lose his vision, right? So this is another reason why you need to know that sclera is thinnest at these points. I hope I made myself clear. So that is why it is important to know that it is. And yeah, one more point is on the go, I'll just touch upon this spiral of Tilloch's. Okay, spiral of Tilloch's, which is actually Mills. The arrangement of these insertions of these extraocular muscles is in a particular spiralist pattern that is called a spiral of Tilloch's, and these numbers are actually to be remembered: 5.5, 6.5, 6.7 and 7.9. Medial rectors, inferior rectors, lateral rectors and superior rectors. Okay, so you see they are not all inserted exactly in the same circular point at different points. Okay, it's not in one circle, it's actually a spiral. Okay, so that is why it's called a spiral of Tilloch's. Just while we were talking about the insertion of the muscles, I just thought I'll make a mention about it. Right, let's move on to our next question. Right, ophthalmoplegic migraine means. So when you talk about migraine, you know headache is an inevitable part of it. So headache with irreversible loss of optic nerve function, no. Recurrent third nerve palsy associated with headache, possible. Headache associated with multiple cranial nerve, yes, possible. Headache associated with optic neuritis, no. So when you talk about ophthalmoplegia, it is of two types. Ophthalmoplegia. One is external, the other is internal. Correct? So this external is when the extraocular muscles are involved. Internal is when the intraocular muscles like ciliaris, sphincter pupillae and dilator pupillae are involved. So let's not bother about that here. We are talking about an ophthalmoplegic migraine. That means there is some problem with the extraocular movements, and that is because the nerve palsy is involved. But remember, it is not only the third nerve palsy. It is multiple cranial nerve palsy associated with headache, and often they are recurrent. See, ophthalmoplegic migraine, more recently renamed as recurrent ophthalmoplegic neuropathy. See, they've renamed it in order to avoid any confusions regarding the nomenclature. Okay, it is an uncommon and poorly understood condition with incidence of 0.7 per million. What does it manifest as? It manifests as episodes of ipsilateral headache followed by a palsy of one or more ocular nerves, cranial nerves, that begin immediately or up to even 14 days after the onset. So you need to keep the patient on follow-up for 2 weeks. Once they have an episode of bout of migraine, you keep them up on follow-up, especially if they've had a previous history. It may persist for weeks to months and is typically reversible. It goes off, comes back, goes off, comes back, and that's why they've renamed it as recurrent ophthalmoplegic problem. And most common nerve, of course, is third nerve. That doesn't mean it is the only nerve, followed by abducent. Trochlear involvement is unlikely. So, multiple cranial nerve is the right answer, but trochlear nerve is not commonly involved. It is quite rare to see its involvement. Right. Let's move on to another question. So, a patient was suffering with ptosis with hypotropia. After an injection of a certain drug, considerable improvement is seen in both these problems. Both the ptosis also got better and hypotropia is also better. Possible diagnosis is which of the following? Sixth nerve, Tolosa-Hunt syndrome, myasthenia gravis or nystagmus. Okay, let's get to it. See, they are having ptosis, which means LPS is a problem. I told you, right? Levator palpebrae is an extraocular muscle supplied by the third nerve, which is responsible for keeping the lid up. They also have hypotropia. That means SR is a problem, superior rectus is a problem. So it could be a third nerve palsy, but they have not mentioned anything else. Okay, that is one thing. And which third nerve palsy improves after certain injection? That is the biggest giveaway we have for this question. Sixth nerve palsy does not improve. Nystagmus does not improve. Tolosa-Hunt syndrome is actually an inflammation that happens at the orbital apex that results in multiple cranial nerve palsies, but there is no evidence of multiple cranial nerve palsies or any evidence of fever or things like that. So the answer is myasthenia gravis, and the drug injection is anticholinesterase injection, which is edrophonium. Okay, we'll see that what it is, tensilon. So answer is myasthenia gravis. So myasthenia gravis, students, is very important topic again because it has a very close relation to physiology. It has also a very close relation to neurology, right? So myasthenia is an autoimmune disease which results in muscle fatigability and weakness throughout the day. Symptoms improve with rest. Its main symptoms, for which they often refer to ophthalmologists, are ptosis, diplopia, and variable extraocular muscle palsies. And remember, the muscle palsies you see here, no, they don't fit into any particular picture. See, if you talk about a third nerve palsy, then the third nerve should at least involve, leave the pupil, maybe diabetic, but it should at least involve all the extraocular muscle that supplies that's supplied by third nerve, right? That also doesn't happen. So because they get involved very partly, some muscle is good, some muscle is not good enough, and mostly the anti-gravity muscles are the ones which get affected because they have to work constantly in order to maintain normalcy, correct? For example, levator has to work constantly, and in a condition where its neuromuscular junctions are chronically bombarded with antibodies by myasthenia, you can't expect it to keep the lid up all the time. So eventually it becomes fatigued, and you see these sort of episodes more in the evenings. So what I'm trying to say is, the history itself is very clear that only certain muscles are involved, and that does not fit into even a proper third nerve palsy. So again, variable extraocular muscle palsies is a very important reason for you to rule out myasthenia. Or incomitant strabismus, like I said, because of improper involvement of different muscles, very incomitant. What is incomitant? The uniformity between two eyes is not same. Or to put it in a so-called classic definition, the amount of deviation remains constant in all cases in a concomitant strabismus. The textbook definition, but to understand, they're not the same in all cases. That's all. And external ophthalmoplegia. Okay, so remember, myasthenia is a problem with the neuromuscular junctions which have nicotinic receptors. Getting back to physio, I was telling you, right? So it is not going to affect the muscarinic receptors, which are the receptors in the involuntary muscles inside the eye, and hence you do not get an internal ophthalmoplegia in case of myasthenia gravis. The pupil is not going to get affected in myasthenia gravis. Clear? So what are the tests? We were talking about a certain drug which improved it, right? That is tensilon. So edrophonium chloride inhibits the acetylcholinesterase, the enzyme that is responsible for breaking down acetylcholine and causing the weakness, thereby prolonging the presence of acetylcholine at the neuromuscular junction and hence enhanced muscle strength. It is useful only in patients with objective measurable findings on physical examination like ptosis or atropia, just like in our patient. In ptosis, a positive test is elevation of eyelids in just 2 to 5 minutes post administration of tensilon. A negative response is no improvement even after 3 minutes. Clear? So this is a very easy test that can be done in a hospital setup, but always remember, edrophonium can elicit a severe anaphylactic response. So it's not every time you just go in right away and give a tensilon to everybody. So you need to do a test dose and all that before you proceed. What are the easier ways to do it? Okay, for which we have two wonderful tests. One is the ice pack test, which is very easy, no side effects. Okay, it is very simple, can be done in the clinic, highly sensitive and specific. Okay, so ice pack is applied over closed eyelid for 2 to 5 minutes, and the ptosis improving by 2 mm or more itself is enough. On the other hand, why does it happen? Because when you're giving ice pack, you're reducing the temperature. Enzymes work at best at body temperature and a particular temperature. You're dropping it, the temperature, and hence helping in curbing the action of this enzyme acetylcholinesterase, because of which ACH prolongs in the synapse and muscles work better, right? So that decreases the muscle contractility, results in a false negative result. Yeah. So prolonged cooling, that is very negligible. They say can decrease the function of the muscle itself by decreasing the contractility, but that's less important. Ice pack is very simple test you can do. Now sleep test is a simple clinical test where the patient is asked to note if there is a marked improvement in symptoms upon wakening. This can be done in the office if the patient is very sleepy. Very funny, but still. Okay. Then comes, see, now these tests have some amount of sensitivity and specificity, right? Now we need a foolproof test because we are going to start the patient on some physostigmine and other treatments, especially if the patient going to have a systemic myasthenia, they can even die of breathlessness because the respiratory muscles, what if they stop functioning, right? So that is where you need repetitive nerve stimulation and single fiber EMG. Don't have to get into the details of this, just remember there are neuromyological studies which help in identifying the efficiency of the synaptic junctions. Clear? RNS and EMG, single muscle EMG, electromyogram. Okay, this is more than enough for myasthenia. Nothing is going to come out of beyond this thing for myasthenia. Clear? Great. So we've covered myasthenia also. Now let's move on to a little bit of orbit and oculoplasty. The medial wall of the orbit is formed by all of the following except. So I guess by the time I had my sip of water, you would have figured out that it's an all except question. So remember, in fact, the medial wall of the orbit has a lot of activity going on. Firstly, it is formed by 4 bones. Anteriormost is the frontal process of maxilla, then the lacrimal bone, then the ethmoid bone, then posteriorly the sphenoid bone. Okay, almost no other wall is constituted by 4 bones, and each of them have a very interesting clinical application which I would like to touch upon here. Now the frontal process of maxilla is not to be confused with the frontal bone itself. So the answer is right away in front of us, it is frontal bone. But this frontal process of maxilla, okay, is one which has the infraorbital nerve. Somewhat, in the junction between the main body and the frontal process, and the anesthesia of this nerve happens in floor fracture, orbital floor fracture. So this is the first clinical point I wanted to say about the first part of the medial wall. Number 2, lacrimal bone. We all know lacrimal bone, very fancy. Why? It is also called as lamina papyracea. It is also the second most common bone to be involved or broken in trauma. Okay. One more point. You must have heard about the procedure called DCR, external DCR. Okay, is connection between the middle meatus of the nose and the lacrimal sac, correct? That happens or is created through the lamina papyracea because it's quite easy to break. Okay, so lamina papyracea. I hope it's clear. So these are all the clinical applications of the the lacrimal bone or the lamina papyracea. Then comes ethmoid. Why is now ethmoid part important? See, just medial to the ethmoid is what? The anterior middle ethmoidal hair cells, correct? You must have learnt in ENT. So this sinusitis of these sinuses, hair cells, okay, that gives an easy way to enter into the orbit, leading to orbital cellulitis. So remember, most common cause of orbital cellulitis is actually paranasal sinus infections. So the route through which it enters the orbit easiest is ethmoid, okay, and then sphenoid. Sphenoid is by the lesser wing of sphenoid. Sphenoid not so much, but you can access sella turcica, they say, through the sphenoidal bone. Okay, lesser wing. When you want to do a transnasal procedure to reach the pituitary, that is the clinical application. You go in through this part of the sphenoid, they say. So ultimately, each bone that contributes to the medial wall has a lot of clinical significance, and so do the other walls also, each of them. So it's important for you to know that, to enjoy the process of actually learning about the different parts of the walls of the orbit, right? So as you can see here, this is the frontal process of the maxilla, lacrimal bone, ethmoid bone, and posteriorly is the sphenoid bone. Okay, So here I have given the different parts which contributes to different parts of the orbit, different bones. So just have a look at it. I mean, if you allow me, I could take a whole 2-hour class just on the walls of the orbit, because each of them is so important for an oculoplastic surgeon, right? Great. So with that, we'll move on to the next one. See, like I said, the question setters are quite fancy about the pseudo things. So they again have asked which of the following causes pseudoproptosis. We saw pseudoesotropia, now we are seeing pseudoproptosis. Hyperthyroidism, high myopia, orbital pseudotumor, or optic nerve glioma. Remember, some terminologies you need to understand with ophthal, which cannot be any other way. Okay. Proptosis simply means nothing but protrusion of eyeball. Okay. Whereas the next one, exophthalmos, means it is often referring to thyroid eye disease. It is not something you can actually use interchangeably. Okay, but not everybody follows this rule, but just know it for a fact. Okay, so now they're asking pseudoproptosis, meaning the eye looks pushed forward, but it is not actually pushed forward. Means the eyeball itself is big enough, giving us an appearance as if it is pushed forward. Okay, so hyperthyroidism, actually because of the accumulation of glycosaminoglycans in the retroorbital or retroocular space in the orbit, there is pushing. So that is not the answer here. Orbital pseudotumor also, there is inflammatory enlargement of the intraorbital retroocular structures, that is extraocular muscles. Again, that is pushing. So that is also not the cause. Then comes optic nerve glioma. Glioma is a tumor which is fluid filled, and it is going to arise from the optic nerve, which is again the same intraconal retroocular intraorbital space. That is also pushing. So that is also not that is also proptosis. Okay. Only thing is high myopia, like we've discussed before. Can you see how this refractive error is coming even up to orbit? So the eyeball itself looks elongated. It is elongated and it looks as if they are having proptosis, and that is why it is referred to as pseudoproptosis. So I hope I made myself clear that high myopia is actually a case of pseudoproptosis. We'll see what are the other causes. It is a disorder that can be caused by high myopia, can mimic proptosis. Other conditions are lid retraction. See, lid retraction can happen in thyroid eye disease even without proptosis. So in earlier stages, what is lid retraction? Is there is a involuntary component of LPS. What is LPS? Levator palpebris superioris. Okay. This involuntary component of LPS is called as Muller muscle. This Muller muscle is supplied by sympathetic nerves. Now this Muller muscle being supplied by sympathetic is overactivated. We all know that the sympathetic activity is augmented by thyroid hormones throughout the body, right? That is why they have tachycardia in hyperthyroidism and Graves' disease, etc. So similarly, that augmentation of sympathetic activity on the receptors of Muller's muscle leads to its overactivation, leading to the lid appearing slightly more elevated. What is basically proptosis? You can't really see how front it's come. You basically see the extra amount of sclera that is visible. Okay, based on that you call it proptosis or not. Okay, so I'll tell you, normally if you take, this is the cornea. Okay, the upper one, they say 1/5 of the cornea is covered by the lid and lower limbus is touched by the lid. Now, when the lid goes up, you see this sclera above the lid. Definitely it looks like it is proptosis, correct? In proptosis, that's what happens. The eyeball is pushed forward, so the lids appear to have gone back. What if the lid itself has gone back because of some problem in thyroid eye disease? That is lid retraction. So lid retraction, and how do you differentiate it? You measure the proptosis using exophthalmometer. Exophthalmometer, that is named after Hertel. Just letting you know. Okay, including eyelid retraction, ophthalmos, and asymmetric orbital size. Is it clear? So eyelid retraction I told, ophthalmos we just discussed, congenital glaucoma, and asymmetric orbital size is seen in craniosynostosis. See, remember, craniosynostosis is again a topic in itself. Apert syndrome, Cruzon syndrome, Pfeiffer syndrome, Carpenter syndrome. So those are all commonly asked, I would say, quiz question sort of a thing, but not too sure as to how much that is focused in pediatrics. But they all can cause bony abnormalities in the orbit and very shallow orbits. These shallow orbits are the main reason for this looking like as if it's proptosis, but it's not actually pushing forward by any ocular, normal structures getting inflamed or anything. Okay. So that is craniosynostosis. In fact, this is called as exorbitism. Okay. Let's move on to the next one, pseudotosis. What is pseudotosis? Like I said, if the eyeball is moving front or looking elongated, it looks like pushed out. Okay. Now, what if the eyeball is going in or smaller? So, nanophthalmos, microphthalmos, all the eyeball is smaller. So, instead of covering the upper 1/5 of the cornea, it is going to cover almost half of the cornea, and that looks like ptosis. But actually, it is not a problem with the lid. It is because the eyeball is smaller, the lid is falling further, and that is looking like it's drooping. So, phthisis bulbi, this I'll come to hypotropia, dermatochalasis, enophthalmos, contralateral eyelid retraction. Okay, so hypotropia and contralateral eyelid retraction or proptosis. Now, the biggest way we measure something is abnormal is by comparing it with a contralateral eye, correct? So, in case of contralateral eyelid retraction, the normal eyelid looks as if the lid is drooping. So, by mistake you can end up diagnosing ptosis, but it's actually pseudotosis. On the other hand, same thing with proptosis again happening, it's the same funda. Now, let's look at hypotropia. What is hypotropia? Is when the eyeball is tilted downwards due to whatever reason. Okay, it could be because the inferior rectus is entrapped in a blowout fracture. So many reasons are there. What happens? The superior rectus now is going to not either functioning not properly because of a partial third nerve palsy. Okay, so even if a normal person looks down, can you see that the eyelid follows? So imagine if an eye is locked in the downward position, obviously the lid will be at a much lower position compared to normal, which is normal response. But you should not mistake it for ptosis thinking it is pathology. That is why that is also pseudotosis. So the concept of the pseudo may actually look, why are they even bothering about it? But it goes a long way in teaching us to understand the concepts on the basis of naming different pathologies. So do not neglect these pseudo things and try to understand why they are called pseudo. It gives you a very good and deep understanding of the problems. Okay, right. Let's move on to the next question. Optic nerve glioma is associated with which of the following? NF1, VHL, I forgot about VHL while listing the phacomatoses. Von Hippel-Lindau syndrome. Okay, Sturge-Weber we already discussed. It's either NF1 or NF2. Remember, again, some of the common optic nerve tumors, they divide themselves into two teams, NF1 and NF2. NF1 causes optic nerve glioma, NF2 causes optic nerve meningioma. So this is the beauty. I'll come to that. See, why is NF1 so important or neurofibromatosis 1 important for us? Because the NIH criteria for diagnosing or establishing the diagnosis of NF1 has several ocular findings in it or ocular criteria in it. I'll show you. First is 2 or more of neurofibromas any type or one plexiform neurofibroma. What is a plexiform neurofibroma? The eyelid is like this, okay. So there is a thick neurofibroma which is coming like this, okay. This results in what we call as S-shaped ptosis. This is an eye finding, okay. Second, Lish nodules. These are all iris nodules. You will see, I'll show you. These are Lish nodules. Okay, so they are again characteristic of neurofibromatosis. And then again, optic nerve glioma. Do you understand? So of so many 6 or 7 findings, of which 2 at least is required, 3 of them are actually ocular. So the role of an ophthalmologist in diagnosing an NF1 is actually crucial. Okay, so I told you, right, this is optic nerve glioma. Optic nerve itself gets enlarged, and this is called as pseudo CSF sign. CSF is often restricted to the intracranial cavity, right? But here when this swells up, it looks like as if a pocket of CSF is sequestered just behind the eye. That's called a pseudo CSF sign. Clear? Let's move on to the next question. A patient with ptosis presents with retraction of eyelid on chewing. This is called as third nerve misdirection, crocodile tears, Marcus gun jaw winking, Duan's retraction. Wow. Okay. So each of them are very important topics or syndromic topics. Let's not get into the details of that. But the one you're seeing in front of you is important. That is Marcus gun jaw winking syndrome. What is important here? Can you see that the patient's right eye is ptotic? On moving the jaw, okay, the eyelid opens. So it is a congenital ptosis associated with synkinetic movements of the upper lid on masticating movements of the jaw. Okay, so there is an abnormal connection between the lateral pterygoid and levator palpebrae superioris. So this is by the third nerve, this is by the fifth nerve. MAC-MAST, right? All the voluntary muscles supplied by the fifth nerve, right? It is usually unilateral but rarely present bilaterally, affects equal proportion. Now, okay, let them move the jaw. What is the problem? Let it open up. So firstly, it is not a treatment that you need to understand. In fact, when they talk or when they chew, the eyelid opens up, they look relatively normal. But for us, it is important because, see, this problem requires a two-step procedure. Okay, what happens is often for a congenital ptosis, I'll just touch upon this because ptosis can feature as a question. Okay, congenital ptosis, you do a frontalis sling procedure. Okay, frontalis sling, just that much you know, enough. So what do you do in frontalis sling? You're going to take this and attach it to the occipitofrontalis muscle so that the eyelid remains open. But when you do this procedure, imagine if the Marcus gun is still intact. Then every time you move the jaw, the eyelid is further going to retract open. So for that, you need to first take care of this jaw winking by doing a surgical procedure and then do a two-step procedure for correction of ptosis. With jaw movement, jaw winking syndrome, it is a two-step procedure. That is why as ophthalmologists, we need to know it. Okay, another fancy name, the exact opposite of Marcus gun jaw winking is Marin-Amart syndrome. So here what happens is there is facial synkinesis, meaning the eye movement is going to happen, but not when the patient is chewing. The ptosis gets induced when the patient is chewing. So just the ulta of this thing, I wanted to make a note. It happens because of aberrant seventh nerve regeneration. Okay, voluntary movement of the lower facial muscles. Okay, and it's not the jaw, the lower facial muscle that includes smiling, just talking, those sort of things. Okay, so it's not between the fifth and third, it's between seventh and third. Okay, right. Let's move on to the next question. Which of the following is not useful in the treatment of chalazion? So what is chalazion? Like I said, I'm trying to touch upon the common ocular complaints that the patients come to a general doctor, right? So that is the focus of medpg as far as ophthalmology goes, is that rather than trying to delve into the different surgical types and the capsular capsular techniques of phacoemulsification, is not what they're looking for. They want you to be able to answer the management and diagnosis of common conditions that can present to a general doctor. Okay, that you should know in proper detail, right? So chalazion is basically chronic granulomatous inflammation of chronic granulomatous inflammation of meibomian gland. Okay. What I want you to know is they are asking not useful, that is, it is an all except question. Warm compresses useful, intralesional steroids useful, topical antibiotic plus steroid useful. You do not do an incision and drainage, but you do an incision and curettage. I'll tell you what is the big difference is what you may ask. There is a very important difference as far as concept and science goes. Let's understand the theory before we get to it. Chalazion must be differentiated from hordeolum, okay, either internal or external, because they result from acute purulent inflammation of eyelid glands. And external involves the eyelash follicles, okay, which is also called as stye. Okay, external hordeolum is the same as stye. Internal hordeolum is an infected chalazion. Note this point. It arises from the bacterial infection of the meibomian gland. Another classification describes as deep and superficial chalasia. While inflammation of the tarsal meibomian glands causes deep chalazion, inflammation of Z's gland causes superficial chalazion. Okay. A small asymptomatic chalazion can be left untreated. Conservative treatment includes lid, massage, warm compression and antibiotic, steroid, eye drop or ointment. However, with the administration of topical or local steroid agents, intraocular pressure should be monitored and treatment course should be limited. You can't forever keep giving topical steroids. Persistent chalazion may be surgically excised. Topical antibiotics are useful if there is blepharitis. Okay. Alternatives include injections of the lesion with steroid or 5-fluorouracil. So we also covered the injection part. Leads to resolution and repeated 1 to 2 weeks later if it persists. So a week or two later, if it persists, you can repeat a dose of injection. However, due to several drawbacks like skin necrosis, subcutaneous fatty, you're talking about the eye, which is one of the most important parts of the face as far as cosmesis goes. So they come to you for swelling, looking ugly, and then you operate on it and it further leads to irreversible complications like skin necrosis. Then the patient is going to be very unhappy with you. So considering all these, we don't really do this intralesional steroids nowadays. However, some things like the surgical treatment, okay, in the form of incision and curettage. It is not incision and drainage. What is curettage? Just like we do in obs gynae, okay, you use a chalazion scoop and you go inside the cavity and break all the loculi, okay, where there will be sequestered or collected granulomatous content, and you make sure that the whole cavity is clean of this granulomatous content. Only then will it make sense for you to call it curettage. Or else in case of hordeolum internum, you just go make a nick, drain the pus and come out. You don't go and break the loculi, all that. So it is in fact very different between drainage and curettage. I hope I made myself clear. Just like in obs gynae where you go in and curettage the endometrium, similarly here you go in and curettage all the loculi using a chalazion scoop. Clear? So these are some common conditions which you need to know the exact difference between stye, hordeolum, chalazion, and how the treatments are very different. They are not just the same. You can't just go and insert, put a nick on top and then clean it. That's not how it works. Okay, the lid has to be everted, then a chalazion clamp has to be inserted. Okay, so those things matter. Right, let's move on to a little bit of electrophysiology. B wave in ERG arises from, so this is the structure of an electroretinogram graph. Okay, so some people consider C wave, D wave, some people consider oscillatory potentials, but the most important from an undergraduate perspective is A wave and B wave. You have to know where it comes from and what it does. So A waves come from the photoreceptors and B waves come from bipolar cells. So the right answer here is bipolar cells. I'll show you in this image. I'll just zoom it now. See here, these photoreceptors, okay, they contribute to the A wave, which is a negative wave. Okay, because we all know, we learnt it in physiology, the activation of photoreceptors is not by depolarization like it happens with the rest of the nerves, but it is by hyperpolarization. See how physiology links back here, right? This is actually a test which is done in ophthalm department, but the basics are basics. So it is hyperpolarization and hence the A wave is negative. Okay, whereas B wave is from the bipolar cells, which is again depolarization, and hence it is positive. Oscillatory potentials are from the amacrine cells, they say. Okay. Now let us understand each wave. Mainly three waves. A wave originates from the photoreceptors, it is a negative wave. B wave is from Muller cells on bipolar cells, has the largest amplitude. So any pathology which affects the Muller cells will result in decreased B wave, whereas photoreceptors, it results in decreased A wave. Okay. Now C wave is prolonged positive wave arising from the RPE, and beyond RPE the neurons are recorded by VEP, visual evoked potential, okay, which is a function of the optic nerve. Clear? Oscillatory potentials, they say, arise from amacrine cells, but it is not given too much of a importance here. Just know A waves where they come from, B waves where they come from. Okay. Now clinically, what is the point of knowing about these? First, diagnosis of retinal and prognosis of retinal disorders like retinitis pigmentosa, diabetic retinopathy, retinal detachment. Okay, all these problems in the retina can be established at a very early phase before it becomes obvious clinically using ERG. Okay, so even conditions like chalcosis or iron foreign body. Okay, if you suspect there's a foreign body embedded somewhere in the retina, ERG helps us pick it up very nicely. Okay, when fundus examination is not possible, okay, like in case of corneal opacities, dense cataract, we also saw, right, in case of opaque media, one of the macular function tests is actually ERG, correct? Vitreous hemorrhage. In these cases, media are not clear, so you can't really see what's going on. You can't use a OCT. B scan to some extent can tell you only the anatomic integrity. It doesn't tell you whether it's functioning properly. In such situations, ERG can be of great use. Okay. Right. So we touched a little bit about ERG. Just one point about EOG, which is electrooculogram. Max to max, which they'll ask you, is what is Arden's ratio. Remember, Arden's ratio is between the light peak and dark trough. Okay. So this is this. Okay. So light peak and dark trough, the ratio should be more than 1.8, and currently it is useful for only one disease, which is actually Best disease. Okay, Best vitelliform dystrophy, that is about EOG, and BEP is a way to test the function of the optic nerve, and not so commonly employed. Okay, great. Now let's move on to the next question. Subretinal demarcation line or watershed line, okay, is seen in fresh RD, old RD, ROP or RP. Okay, so there are some classic signs of a long-standing retinal detachment. Why do you need to know about this? Because a long-standing RD has a very poor prognosis compared to a fresh RD. So a fresh RD, you treat it immediately, you do a scleral buckling, you do a pars plana vitrectomy, and then you do a silicone oil, okay, and gas tamponade, you stick it back, the chance of it reviving with its function is much higher. Whereas if you see a patient who presents to you after long days or long period of not being able to see through an eye, and then you see some long standing, uh, RD signs, then there's no point jumping in and being very aggressive about the surgery and operating. You have to take a guarded stand on that, right? So what are those such signs? Okay, see, first is they are often very thinned out retina. Okay, the retina is not thick and healthy, it is very thin, papery like. They are often inferior in nature with small holes. Two important points: the secondary intraretinal cysts and demarcation lines. Okay, so these 2 points are classic. You cannot have any doubts here. The moment you see intraretinal cysts, because it's been detached from its nutrition and everything for a long period of time, so there is a lot of cystic changes which are ways for the retina to try to compensate for nutrition, right? So cystic changes because of degeneration, right? So they happen, it is a clear-cut sign that the retina is detached for a long period of time. One more important point is the Schwartz-Matsuo syndrome or Schwartz syndrome. Remember, RD often results in decrease in the intraocular pressure. Okay, when you have a retinal detachment, check the intraocular pressure, it is reduced. But there is this syndrome where there is high IOP associated with rheumatogenic RD. Okay, so the exact mechanism they say is not clear, but the pigments from the RPE, they get detached and then they go and block the trabecular meshwork, and that is why they lead to decreased outflow. These are all the postulated mechanisms, but just know about Schwartz syndrome. It's not always that the IOP is low in case of retinal detachment. Okay, right. So that is the end of that question. Great. So now we come to another important question, which is cherry red spot. Now this cherry red spot is a very important thing as far as again pediatrics is concerned. Okay. It is seen in all except. Now you need to know a list of conditions which shows cherry red spot. Okay. CRAO, CRVO, Berlin's edema, Niemann pick. Remember, CRVO does not have cherry red spot, rather it has macular edema. Okay, so all the others have cherry red spot. So CRVO results in blood thunder fundus or splashed tomato fundus. Clear? So see, such is the huge list of all the conditions which cause cherry red spot, of which we have central retinal artery occlusion, galactosialidosis, GM1, GM2, macular hemorrhage also sometimes can cause, Tay-Sachs disease causes. Okay, so a lot of systemic conditions can cause cherry red spot, and they can get referred to us to diagnose this cherry red spot either through indirect or fundus photograph and so on. Okay, why does this cherry red spot happen is because the central part of the macula, okay, it is actually fovea, okay, which does not have any glial cells. It has only photoreceptors. So due to whatever the reason of insult it may be, it could be because of CRAO, where there is death of photoreceptors and the glial cells. Okay, all the photoreceptors, when they die, the underlying choroid becomes more prominent. Okay, compared to the surrounding edema, which makes it lighter in color in appearance. Okay, so death and edema of the surrounding tissue along with the unusual conspicuousness of the underlying choroid is what gives this cherry red spot appearance. Clear? So even in case of gangliosidosis, there is deposition of this substance around the glial cells in the perifoveal space, and that is why you have this cherry red spot appearance. Clear? Great. So let's move on to our next question. Grid photocoagulation is indicated in CSME, ischemic maculopathy, macular hole, and PDR. So, grid photocoagulation, remember students, is or was the mainstay of treatment before anti-VEGF was anywhere in the picture. Okay, so what was this used for? Clinically significant macular edema. Remember, diabetes can cause two types of macular problems. One is macular edema, one is macular ischemia. Okay, now what does this grid laser do? Now, laser when applied to different parts of the retina can be for different purposes. I'll tell you. First, let's see what grid photocoagulation is. It is a laser treatment that uses a focal or a grid pattern. Here it's grid photo, so it is grid pattern to create microscopic burns in the retina, which is of this size, this pulse duration, all that you don't have to mug up. Okay, okay. Used to treat areas of diffuse leakage and capillary non-perfusion on fluorescein angiography. Right. So this is what I was telling you about. A focal laser, you go to the area of leaking vessels and you fire at that. For example, we have new vessels, new vascularization in proliferative diabetic retinopathy, PDR, which was one of the options. Okay, There you don't do grid laser, you do focal laser, because these areas you see here are where the new vessels must have come up. Okay, so in them you need to do focal laser so that you seal off that area and prevent it from leaking further. What does it leak? Blood. Okay, blood or fluid. So that is focal laser. Now grid laser is what you do for macula. Okay, in the macula, leaving the central foveal region, which is important for visual acuity, around that you do fire laser in grid patterns like this. What is the point? You are trying to again seal off the leakage, but remember you should not do it in diabetic macular ischemia, because already there is ischemia. You do this, there is further death of cells and you are going to have a decrease in the visual acuity. How do you know it is edema or ischemia? You do FFA. See here, capillary non-perfusion areas on fluorescein angiography. Okay, so when you have non-perfusion areas in the center, you should avoid, or macular ischemia in the picture, you should avoid grid laser and again use anti-VEGF only. And lastly, pan-retinal photocoagulation, we all know it is to remove this hypoxic retina and make it anoxic. Why? Because when there is hypoxia, they release VEGF, vascular endothelial growth factor, and that causes new vessels to grow, and that new vessels will bleed and cause problem. Why worry? Just burn the retina where it is of least importance to us, in the periphery. In the periphery, if you burn the retina, you are not going to affect the central vision, and you are going to decrease the demand of oxygen or production of VEGF, thereby avoiding the complications which cause the central macular edema or proliferation of new vessels. Is it clear? So you make it hypoxic to anoxic. Anoxic, they don't want oxygen anymore because they're dead. But extensive PRP can result in reduction of peripheral fields. Yes, that is a known complication, but compared to losing valuable central vision, that is relatively okay. Great. Now let's move on to another important topic. A 28-week-old baby suffered from respiratory distress at birth. So 28 weeks, it is preterm. Respiratory distress syndrome is present. 14th day developed sepsis. At what postnatal age should the baby undergo retinal evaluation? Remember, screening for ROP is crucial. Okay, according to the National Neonatology Forum, okay, clinical practice guidelines, which is 2020, one of the recent guidelines, okay, it should be performed at 4 weeks postnatal age. If the gestation at birth is not confirmed, because some parents may not have given us proper LMP, so that situation, it should be done 2 to 3 weeks postnatal age. So not beyond 4 weeks. Okay, it should not be delayed beyond 4 weeks. The first point of ROP screening is to identify the neonates which are actually eligible for ROP, facilitated by maintaining ROP screening diary in which infants are listed as per the screening schedule based on eligibility criteria. Okay, the first ROP screening should take place by 25 to 30 days of life itself, which is nothing but 4 weeks we were talking about. This is possible with the coordinated effort of all healthcare personnel involved in childcare. Yes, so it is actually a community ophthalmology topic and retina topic hand in hand. Okay, should be screened before discharge even if this is early. Okay, screening should take place in the SNCU, neonatal care unit, okay, for inpatients, and outpatients should happen in eye departments. So what I want you to know is screening within 4 weeks is absolutely crucial, and you have to look for signs of increasing risk of ROP like respiratory distress, sepsis, all these factors and administration of oxygen. These are the main risk factors for development of ROP, so they should be frequently screened if they have presence of these symptoms. Great. Okay, let's move on to another retina question. Okay, enlarging dot sign on FFA is seen in which of the following? So this question is important for its short forms. CME and CSME in the same question, can you believe it? So you need to be very clear. CME is cystoid macular edema, and it is not only restricted to diabetic retinopathy. It can happen even in pseudophakia, okay, and that is called as Irwin gas syndrome. We saw that it can also happen in uveitis, intermediate uveitis. We saw that it can happen in posterior uveitis, right? So that is about that. CSR is central serous retinopathy. Coats disease, it is seen in young males, okay, within the first decade of life, where there is peripheral vascular problem, okay. Last is CSME, which is clinically significant macular edema, which is a type of or classification given for diabetic retinopathy by ETDRS. So CSME is often restricted to diabetic retinopathy, but CME is not the same as CSME, okay. Great. So answer to our question is CSR. Why? First of all, it can FFA can show CSR in the retinal blood vessels. Okay, the dye travels through the body and can be seen by a special camera, which is a red free filter camera. Okay, some patterns we will see here: ink block or smokestack pattern. Okay, this ink blot is nothing but this enlarging dot sign. See what happens: you take a tissue paper, you pour a drop of ink, you see that the ink slowly spreads through the tissue paper, correct? Exactly same thing happens here. So this is the ink block pattern. Slowly this increases in size, and that's why it's called as enlarging dot sign. And smokestack pattern is because it's as if the fluid is going against gravity, like a smoke arising from a small source of fire. So that is why it's called as smokestack pattern. Okay, so these are two important patterns that is seen in case of CSR in FFA. We'll just go for a short technical break and be right back. Right, welcome back after the technical break. Let's move on to the next question. CNVM is seen in all of the following except. Okay, so remember, short forms I told you are important. CNVM stands for choroidal neovascular membrane. Why is it different from the other neovascularization? Remember, choroid has choriocapillaries, right? So choriocapillaries. These capillaries are restricted to sub-RPE choroid. Okay, in the choroid they have. What happens in CNVM is there is a breach in this Brooks membrane and it comes to lie either under the RPE, okay, RPE, or above the RPE or above it, okay. When that happens, it leaks fluid and again can result in macular edema. So the problem manifests as macular edema and diminution of central vision. But if you treat it just for macular edema, it's not going to get resolved. Okay, so it's not like diabetes, you control blood sugars and give anti-VEGF, it's going to get sorted out, right? You have to identify the cause of the CNVM and be positioned to treat that. So here, what are all the reasons why this choriocapillaries are going to invade into this sub-RPE or above RPE space? Before that, CNVM, two types, classic and occult. So what is classical CNVM? It's when it's above the RPE and can be visualized through the fundus examination and all that. It is classic, it is seen there. But occult is when it is under the RPE, okay, and it's not visualized, but it's just going to continue to leak fluid, okay. So that is occult CNVM, while this is classic CNVM, okay. So it is seen in all except these conditions of them. You need to identify which are the ones which are going to facilitate the breakage of this RPE or Brooks membrane. Clear? So first is hypermetropia. Myopia, there is stretching, correct? Stretching of the globe because it's becoming elongated. See, from question number 1, I think we are still stuck with refractive errors. That is how they are all interlinked. So myopia, there is stretching and hence there is breakage of Brooks membrane and infiltration of the CNVM. Choroidal rupture, yes, as the name says, there is a rupture and disturbance in the homeostasis, yes. Third is angioid streaks. Angioid streaks is actually another condition where again the pathology is in the RPE and Brooks membrane, okay. That is following many conditions you get angioid streaks. Of some of them I'll let you know. Paget's disease of bone, Paget's disease, okay, pseudoxanthoma elasticum, okay, no need to know all of them in detail, just pseudoxanthoma elasticum, okay, and mainly you need to know Paget's disease of bone, okay, and also sickle cell. I forgot sickle cell, that is again a very common thing you must be knowing, okay, which is a general body condition which can cause this. So these can lead to angioid streaks. So there are multiple conditions. See, angioid streaks, age-related macular degeneration. Actually, wet ARMD is manifested as CNVM. Okay, don't bother about so many diseases here. Some of the important ones alone, even diabetes to some extent can cause, but chronic retinal detachment, choroidal rupture, okay. See, so many conditions, including myopia, okay, retinitis pigmentosa, VKH, all of them can cause. So just remember the ones that I've ticked here, okay. So they are relatively important as far as our learning goes, but there are numerous conditions which can cause CNVM and it's not unusual. Clear? So ARMD wet type manifests as CNVM, okay. Along with that, you should know choroidal rupture, chronic retinal detachment, myopia, okay, retinitis pigmentosa and VKH. I hope it's clear. So the answer to this question is hypermetropia. In hypermetropia, the eyeball is smaller, it's not stretched out, so there is no risk of formation of CNVM. Okay, next, retinitis pigmentosa is not associated with. It is again a all except question. Remember students, retinitis pigmentosa is a very so-called quiz type or a need PG type of question because it has a lot of systemic association. Okay, so what is the feature you see in retinitis pigmentosa? First, you see optic atrophy. Okay, you see attenuation of retinal arteries, attenuation of arteries, and also you will see bony spicules, which is very classic. Okay, bony spicules in mid periphery of retina. This is the classic triad. Okay, now they can be associated with multiple systemic manifestations. Why am I mentioning this is because when you identify or diagnose RP, you have to refer them appropriately to different specialties to diagnose and treat the other conditions which the patient may not know. I'll tell you what. First is Usher syndrome. They have sensory neural hearing loss. So you have to refer them to ENT to diagnose and treat them so that they can see. Patient not having visual loss from childhood may not even notice it. But you know how it affects? It impedes their development and functioning. They may not be able to listen to class. Okay, they may not be able to enjoy music. So you have to take all that also into consideration. Okay, Lawrence Moon Beetle syndrome leads to hypogenitalism. Okay, and obesity. Clear. Refsum's disease leads to deafness again and arrhythmias. Okay. Basson-Conswick syndrome leads to acanthocytosis, which is basically a problem in the shape of the RBCs. What does that lead to? It leads to anemia. Okay. Friedreich's ataxia, Kearns-Sayre syndrome, important. Why? Because, see, Kearns-Sayre syndrome has external ophthalmoplegia also. This is again an ophthalmic manifestation. Okay, RP and external ophthalmoplegia, they can have cardiac conduction defects which can be fatal. Okay, so remember Kearns-Sayre syndrome, it's pretty important from NEET perspective. Okay, so just remember Usher's and Kearns-Sayre's if you can't remember anything else. Okay, Usher's means deafness and there are multiple types that we have to know. So at least know that it causes sensory neural hearing loss along with RP. Okay, next. Rubeosis iridis is seen in all except. What is this rubeosis iridis? See, whenever you have an unusual set of vessels inside the eye, it is a problem, right? So you have it in the retina, that bleeds, that results in vitreous hemorrhage, that leaks, that results in macular edema. These are all things you see in case of proliferative diabetic retinopathy, correct? Or even in cases of central retinal vein occlusion, okay? But when those vessels are seen in iris, that is called as rubeosis iridis, meaning the VEGF that is secreted by the hypoxic retina we discussed in that laser question, that travels via the vitreous and it comes and produces new vessels in the iris. Iris is the next vascular structure, right? Vitreous does not have blood vessels. So coming from the retina via the vitreous, it leads to formation of new vessels around the pupillary margin. Okay, and if you see rubeosis iridis even before dilating, you have to know that there is something going wrong which needs immediate attention to identify what is the factor that is demanding so much oxygen, okay, or new vessels. Okay, so it is seen in all except seen diabetic retinopathy. Yes, we already discussed that in detail. Okay, Eales disease is said to be again periphlebitis. Some studies say that it is attributed as a form of autoimmune vasculitis following tuberculosis, but some say no, it is just related, it is positive, etc. So remember that is also a vasculitis. In retinopathy of prematurity, we already saw that it is basically abnormal development of the blood vessels during the maturation because a lot of things have impeded it. For example, in ROP we saw for screening, right? If you administer oxygen or if there is a developmental problem leading to sepsis, respiratory distress, okay, all of them lead to development of abnormal vessels. Instead of the normal retinal vasculature, development of abnormal vessels. That leads to rubeosis iridis. So the only condition which is pretty benign, okay, and leads to only fluid accumulation in the layers of the retina is CSR or central CNS retinopathy. We saw, right, enlarged blot sign, enlarged dot sign, correct? See this. Proliferative diabetic retinopathy, CRVO, and ocular ischemic syndrome. What is OIS? When there is a vertebral insufficiency or when there is a carotid block, okay, due to atherosclerosis, the amount of blood supply and oxygen that is supplying the eye itself comes down. Means the eye is requiring more oxygen, so it is trying to produce more VEGF, and that leads to rubeosis iridis. So a lot of other conditions like ocular tumors, chronic uveitis, coats, eels, these all can lead to production of VEGF and bring about formation of new vessels in the iris, which becomes a huge problem because they are so fragile. Okay, two things happen. One is from the iris, it will go on traveling via the iris into the angle, and there it will heal with fibrosis, closes down the angle, and that leads to what we call as neovascular glaucoma. Once you see rubeosis iris, damn sure you must do gonioscopy, because if you don't pick up the vessels in the early stage and you don't treat the main problem like CRVO or diabetic retinopathy, once it becomes a neovascular glaucoma, it is also called as refractory glaucoma. One of the types of refractory glaucoma. No matter how much anti-glaucoma medicines you keep pushing, the patient is constantly going to lose vision and eventually end up blind. Okay, so neovascular glaucoma should not actually be allowed to happen, but if it happens, you have to pick it up at the earliest stage. It has 5 stages. Let's not get into that, but the earlier you pick it up, the more chances that you can save the eye from going blind. Clear? So that is the whole reason I included this rubeosis iris, to emphasize on the importance of neovascular glaucoma. Okay, rubeosis iris means already the vessels are in the anterior chamber. Now anytime they may already have been in the angle, or anytime it can invade the angle, and that's it. NVG sets in, you cannot do much to save the eye. Great. So with that, we come to the end of that question. So I told you ROP is also one cause. Okay. So vasculitis or any vascular problem that leads to decreased oxygen supplied to the eye will result in neovascularization. Clear? It is not the same as CNVM. I want you to be very clear. There the problem is different because there is a breach in the Brooks membrane and invasion of the choriocapillaries. Whereas here there is production of new vessels. Clear? Okay. Right. Let's move on. Next question. Which drug treats ocular hypertension but causes apnea in infant? So anti-glaucoma medications is a topic which you need to know in detail, like I said, because it's related to pharma also. Okay. So options are brimonidine, latanoprost, timolol, and dorzolamide. Each of them belongs to a different family. They have a different profile, different indication, mechanism of action, and set of adverse effects. Let's deal with them in detail. The answer here is brimonidine because the alpha 2 receptors are also present in the CNS. So even administered in unusual concentrations, this can go and block the alpha 2 receptors in the CNS, causing CNS depression. And it also causes this depression in important areas like respiratory center. That results in apnea. Okay, we'll see the complication or the side effects. Okay, reported neuropsychiatric events with the topical administration of brimonidine itself. Okay, anxiety, apnea, asthenia, cyanosis. Cyanosis is because of the cardiac centers getting depressed. Okay, improper oxygenation. Okay, such is the profile of brimonidine related complications, and that is why it is not to be used in children. Okay, it is best avoided in children because it can lead to all these things, and as children and kids we may not be in a position to elicit the reason for their symptoms, or they may not be in a position to explain it to us, and we may not pick it up and can lead to dire consequences. Clear? Good. Next, let's touch upon a little bit of squint also. Yoke muscle of right lateral rectus. See, yoke means, the immediate word that should come to your mind is Herring's law of equal innervation. Okay. So remember, yoke muscle is always of the opposite eye. So when they talk right lateral rectus, it has to be left. So for us, all of them are left. Okay. Now, lateral rectus in the right eye, what does it do? It brings about abduction. So which is the eye which is going to help doing the same thing? That is yoke muscle. But this muscle should be of the opposite eye. So if a person is looking to his right, which is actually what is brought about by right lateral rectus, the left eye has to move medially. So the answer is left medial rectus. Now this is quite, this may look very simple. Why have I put it here? Because a small change in the question can completely throw you off the floor. Because let us say if they ask what is the yoke muscle of left inferior oblique, that is where we find it difficult, correct? Because lateral rectus, medial rectus is too easy or cakewalk for all of us, for which I wanted to simplify, and that is why I have included this picture here. This picture, you practice it and you learn it, and with this picture in mind, you can answer this yoke muscle just out of the top of your mind. Okay, now in these pictures, the arrows are very clearly showing what is the yoke muscle. For example, okay, in this case, if you're talking about elevation in abduction, superior rectus's yoke muscle is inferior oblique. Okay, if you're talking about depression in adduction, right superior oblique yoke muscle is left inferior rectus. Clear? So this image you must be able to draft it at any point of time to answer oblique related questions or superior questions without any problem. Okay. So this is important, and they've given the nerve that innervates it. I think we know this from LR6SO4, so we don't have to worry too much about it. Okay. Let's move on to our next question. Which of the following is not a grade in BSV? BSV is again a recognized abbreviation, which is binocular single vision. Correct? So what is binocular single vision? See, binocular single vision is what facilitates you to see an object in front of you as a single object in spite of having two eyes. Correct? So it has 3 grades, and this is given by Worth. Okay, Worth's grades of binocular single vision. So first grade is fusion, second is simultaneous perception, third is stereopsis. So the answer here is retinal correspondence. See, retinal correspondence has nothing to do with BSV. In fact, it does in one way. There is normal retinal correspondence and abnormal retinal correspondence, which are all mechanisms to deal with squint. Okay, mechanism to compensate squint. Okay, clear? So what is fusion? Fusion is, see this image here, it has a similar image in both the charts, but one part of it is missing. In this one, the flower is missing. In this one, the tail is missing. Okay, so when you see it, you actually don't see it as two different things. This is all done through a thing called a stereoscope, an equipment called stereoscope. In a normal person, it will not be identified separately and will see as one image. Whereas simultaneous perception, see here, there is cage, there is nothing common between the two images. Here, there is something common, and hence the eyes are able to fuse it. Whereas simultaneous perception is grade 2, right? So there's nothing common, but still the eyes are able to join together and simultaneously perceive both, and looks as if the bird is in the cage. Now comes stereopsis, where they are at different angles, okay, and still the object is perceived in 3 dimension by stereopsis. Okay, so that is the 3 different grades of binocular single vision. Clear? Now, treatment of refractive accommodative esotropia is, see, I told you we discussed about AC by A ratio, right? So this is where it comes into picture. Now, when you talk about accommodative esotropia, okay, it is 2 types. One is refractive, the other is non-refractive. What did we discuss? We discussed that in cases of accommodative esotropia, the plus power, the amount of accommodative convergence happening for accommodation is more. Okay, so when you brand it as refractive, that means the problem this is happening is because of the refractive error. So simply all you need to do is give them corrective glasses. On the other hand, if it is non-refractive, that means even correction of refraction is having residual esotropia. In those cases, you need to consider surgery. So answer here is actually glasses. Let us see. It is an inward turning of one or both eyes that occurs with the activation of accommodative reflex or the near reflex, near triad we discussed, no? It is a dynamic process in which the curvature of the eyes, natural lens is temporarily adjusted to focus at near, and convergence is described as convergence of the eyes in response to the accommodation. The amount of convergence to accommodation is AC by A ratio. Okay, so what do? This child having esotropia, and when you're correcting the refractive error by giving the plus lenses here, automatically that squint is corrected. You don't have to do any surgery. Okay, so this is what I wanted you to know. When they say it is refractive, blindly go for the option of glasses. Okay, refractive is corrected by glasses, you do not need surgery. Okay, now let's look at the next question. Limitation of both adduction and abduction is seen in which of the following? So Duane's retraction syndrome, just know about this 1 or 2 lines. Okay, this is a little tough question. It was asked in the INICT pattern in previous year AIMS paper. Okay, this is again a part of congenital cranial disinnervation disorders. It's a group of diseases again. Okay, congenital cranial disinnervation disorders. So what are the options we have? First is Duane's type 1, type 2, type 3. In Duane's type 1, okay, there is poor AB duction because the third nerve, there is no supply to the sixth nerve. Okay, whereas in type 2, there is poor AD duction. That is, from the third nerve, there is extra supply to the sixth nerve apart from the usual sixth nerve. So this MR supply is reduced. Clear, the strength is now divided between the two. Whereas here, there is no sixth nerve supply at all. Can you see here? Right? In type 3, what happens? Sixth, you get a mild agenesis, okay, and the split between the two, LR and MR, is equal. So both of them are going to be equal in strength. So neither adduction happens nor abduction happens. This is the basis. Okay, all what matters is whether the sixth nerve is also supplying it or not. That is what makes the difference. Clear? So here limitation of both means that both adduction and abduction are restricted as in type 3. However, remember type 1 is the most common. Okay, don't bother too much about the head turn and all that. Just remember 3 types. Okay, and in type 3 equally innervated by third nerve. Why is this all going on? Because the third nerve is disinnervating along with the it's by mistake innervating the lateral rectus also. That is the problem. Okay, so in this case the strength of supply may vary, but see here in type 1 the third nerve split innervates LR and MR, and most of the nerve goes to MR. So LR does not get any signal from 6th, somewhat it gets from 3rd, but majority of the strength is still with the medial rectus, which is correct. So abduction is not possible. Clear? So just know this table after understanding the concept. Understanding the third nerve is the culprit, unnecessarily going and doing the sixth nerve job. Okay, even if it is present or not, if it does, that is where the problem is. In type 2 sixth nerve is working, but still third nerve goes and adds the strength to the sixth nerve. So lateral rectus is having extra strength now. Clear? So that is the Duane's retraction syndrome that I wanted to talk about. Okay, right. So this is another squint question. Because squint is not very often dealt with in our undergraduation days, I just thought I'll include a couple of questions before we proceed to the next topic. Okay, squint surgery, muscle resection. Okay, read the word carefully. Resection that leads to A, weakening, B, strengthening, C, paralysis, D, lengthening. So remember, resection is a term for making the muscle shorter. Okay, so you take out, even in tumors, no, you resect, you take out a part of it or the whole of it. So you make the muscle shorter by cutting out a belly portion of the muscle, and you make it shorter and hence increase the strength. A muscle is long and lax. You make it short, it works under higher tension and works better. Okay. Plication is the term for making the muscle shorter by folding it over. So what you do, you fold on top of it and reduce a part of the belly of the muscle that actually functions. So you're making it weaker. So here you're not going to affect the origin or insertion. In plication, you're just folding it on top of other and reducing the arc of action. Correct? You have to imagine, very simply to remember, our teachers used to say, it is like as if you tie a rope to a door and see how you can open. Okay. So when you have a lot of folds in the rope, the effective force that is transmitted is lesser. Correct? So that is what plication does. Recession, what it does, instead of attaching it at its original, let's say you attach it at the handle of the door, instead of that, you remove it and attach it in the middle of the door and you apply the same force. Will it open? No. It will require more force to open, or it will work at a weaker position. So that is called as recession. It is moving the muscle back to make it less tight. So this analogy really helps of attaching a rope to a door and trying to open it. Okay. So slackening a muscle is recession, tightening a muscle is resection, reducing the movement arm is Faden's procedure, which is plication, and changing the vector force. In cases of oblique squints, we also transpose the muscle. So that is little complicated surgery. Just know resection, recession, just the names and the purpose. Understood? Okay, right. So this is again a question on squint. I'll just touch upon it. Which of the following is not a feature of paralytic squint? Diplopia, compensatory head posture, amblyopia, and secondary deviation being more than primary. Okay, this has some important concepts, so I'll take a little bit of time here. They're asking for not a feature of paralytic squint. When you talk of paralytic squint, you talk about nerve palsies like third nerve, fourth nerve, or sixth nerve. For simplicity's sake, let's take sixth nerve. If there is a sixth nerve palsy, the eye will not be able to abduct. So patient will have diplopia. So this is not our answer. When there is diplopia, to avoid diplopia, they have different head postures, of which three types are there. Face turn, chin lift, head tilt. In our previous discussion of PYQs, we've dealt in detail with the question of fourth nerve palsy. If you have time, please have a look at it. Okay, so in the face turn is when there is a lateral rectus palsy, when the patient is not able to abduct, what happens is they try to keep it in this way. So if the right lateral rectus is gone, they will not be able to look like this, no? So if they keep it like this, there will be esotropia. So to compensate for that, they keep their head like this. So that is compensatory face turn. Chin lift is when they have ptosis. When they have ptosis, to be able to see, they lift their neck up. Okay. And head tilt is seen in superior oblique palsy. Okay. Secondary deviation is more than primary deviation. This is a very, very interesting concept that I want you to know. Okay. See, secondary deviation is what you see after you remove the obstruction, whereas primary deviation is what you see with the obstruction on. Okay. So in case of a squint, this is again about Herring's law. Okay, an application of Herring's law. In paralytic squint, what happens? Let us say lateral rectus is palsied. Okay, when there is, when you look at the patient normally, okay, the eye will be in esotropia because of normal action of medial rectus, which is still functioning. Okay, now what you need to do is you need to put the obstruction on the normal eye. So what will happen if the patient is able to abduct? Okay, then they will be able to take up the central fixation. But in this case, you can't. Okay, what happens to the obstructed eye? That is also going to go for ESO, correct? EXO. So now, when you take off the obstruction, this eye is going to come back and fix it. So the secondary deviation is going to be more than primary deviation. Okay, in paralytic squint. Whereas in case of concomitant squint, like for example in case of tropia because of alternating squint. Okay, in those situations the primary deviation will be more than secondary deviation. Clear? So it is, let's read this carefully. Lazy eye, yeah, I forgot to tell you the answer. So amblyopia does not happen in paralytic squint because amblyopia is a process which happens during the time of development. So at the time of development of the eye, that is in the early childhood, if the eye is not getting enough stimulus, the eye goes to become lazy. Okay, it is reduced vision in the eye caused by abnormal visual development early in life. It generally develops from birth only up to like 7, maximum 10 years of age. On the other hand, paralytic squint is not a common finding you see in this age group. It is often like nerve palsy or anything which you see more in adults and elderly people. So amblyopia is not a feature of paralytic squint. Clear? Okay, let's move on to out of squint into other topics. Yeah, all of the following are treatment of myopia except, I told you myopia is something we could not escape at all, right? LASIK, phakic IOL, radial keratotomy and collagen cross-linking. So we already discussed about LASIK and phakic IOL, right? So radial keratotomy, again, what does it do? I'll tell you. What is the problem in myopia? It is steep. So you want to flatten out the cornea. So in radial keratotomy, you make incisions in the periphery. Actually, you make only 8 of them like this. 8 to 6 of them. Okay. So when they heal, it flattens out the central cornea and you're taking care of the curvatural myopia part. Okay. So that is again useful in myopia. But collagen cross-linking, where did we discuss? We discussed it for keratoconus. Okay. Collagen cross-linking is an minimally invasive procedure which is used for keratoconus. The standard treatment protocol is Dresden protocol, which was formulated by Wollensack. Okay, just know the Dresden protocol. Okay, I told you we use riboflavin 5 phosphate drops, and you show UV light, UVA of 370 nanometers for 30 minutes while continuing to instilling the above drops every 5 minutes. So this is what you do for collagen cross-linking. At the end, we apply topical antibiotics, soft BCL with good oxygen permeability. So with that, we know what is the treatment for myopia, and definitely it's not collagen cross-linking. Mydriatics to be used in a 3-year-old for refraction. Very interesting question. See, whenever you do refraction in children, often they are very unreliable. So you want to repeat it, you want to negate any obvious avoidable errors, right? So you do cycloplegic refraction. Remember, cycloplegia is nothing but you are paralyzing the ciliaris. So you want to take accommodation out of the picture. Now in children, remember accommodation is very strong. They have fresh muscles, strong muscles. So they accommodate to such an extent that they can go from hypermetropia into minus power. Can you believe it? So what do they do for hypermetropia? They actually increase the power by using accommodation, by adding plus power, by increasing the plus power by increasing the curvature. That is what accommodation we do. The muscles are so strong that they overcompensate, and that results in what we saw, spasm due to accommodation. We saw, right? Myopia. It causes pseudomyopia. So many kids, they'll be coming to us with severe headache, and when we check, it will be myopia. So when you do cycloplegic refraction is when you end up having plus power. That is done only after cycloplegia, and cycloplegia, remember students, in children it is always by atropine, because atropine is the best cycloplegic for such strong intraocular muscles in children. Now, to be able to do that, you have two formulations. One is the drops, one is the ointment. In children, it is ointment and always ointment. Why? Because atropine drops, the moment you instill it, it can go through the nasolacrimal duct and get absorbed through a very vascular nasal mucosa. And atropine in such concentrations in children is more than enough to cause all that symptoms, mad as hatter, red as beet. We saw, right? We see, right, in forensic that the side effects of atropine poisoning. So all that can very much happen in children. On the other hand, you use ointment, two advantages. One is it stays longer and helps in better efficacy. Second, being ointment, it doesn't get absorbed into the nasal mucosa and into the system, leading to these complications. So Definitely atropine is much more important, much more effective than cyclopentolate in blocking accommodation in young esotrophic children. The entire hypermetropic refractive error is usually prescribed in spectacle correction of children who are less than 5 years of age. So less than 5 years, I told you, the moment they are in the borderline myopia, immediately subject them to cycloplegic refraction with 1% atropine ointment. They are very, very likely to have hypermetropia. Okay. All right. Next important question. Objective assessment of refraction is termed as gonioscopy. No, we saw in depth about gonioscopy. Ophthalmoscopy is direct and indirect. Okay, direct ophthalmoscopy is using a direct DO, okay, or a direct ophthalmoscope. Indirect is through indirect ophthalmoscope. Okay, they are different. They are not useful for refraction. Keratoscopy to some extent can understand the corneal curvature, but that is not going to be useful for refraction. Okay. It is useful for IOL power calculation, identification of keratoconus, but not for refraction. And retinoscopy is the objective way of assessing refractive error. So it is an examination technique that objectively measures the refractive error of the eye. This is done by looking through an optical instrument called a retinoscope to observe the movement of the reflected light in the patient's pupil. I'll show you the image. See here. So this is how we are positioned, and we'll be changing the lens in front of the patient's eye and we'll be keeping the retinoscope in front of our eye, and we'll be looking for the movement of this light. So with movement, against movement, and neutral. So whenever the light inside the pupil is moving against the direction in which we are moving the light, that means that you need to add minus lenses, that the patient is myopic. With movement, you add plus lenses. The moment you attain this neutrality, that is the exact power that the patient needs. The beauty of this is you can do it irrespective of the patient's response. See, for example, if the patient is illiterate, okay, you can't subject them to the lens changing thing we usually do. Here you don't have to even bother about what the patient says, whether they're saying it correctly. Especially in children, they may be very playful and they're not very keen on reading it right, so they give all sorts of readings. And in objective retinoscopy, you don't have to depend on their response to be accurate, right? So that is the advantage of objective refraction in the form of retinoscopy, right? A little bit of community ophthalmology. Which of the following is the output indicator of NPCB? This is a straightforward question, nothing to explain. Remember, NPCB has certain important strategies. Okay, first is strengthening service delivery, developing human resources for eye care, promoting outreach activities, and developing institutional capacity. Okay, and the most important point here is number of cataract surgeries leading to sight restoration, because NPCB focuses on avoidable blindness, and the most important cause for avoidable blindness in India is cataract. Okay, so that is why a lot of emphasis is laid on that. So 2-3 important programs you need to know, even from SPM point of view. Vision 2020. Okay, this you must know from from SPM itself, and NPCB. Okay, these two. And another point is types of blindness. This is again given by WHO and NPCB. Okay, the economic blindness, social blindness, manifest, legal. Okay, just go through this. It is available in most standard textbooks and also online. These are one-liners which can feature as a question in your NEET PG or INICET. Okay, let's move on to the next question. Best irrigating fluid for cataract surgery is normal saline, BSS plus glutathione, ringer lactate, or dextrose. Remember, BSS plus 500. Okay, it is a very standard preparation which is ideal for intraocular irrigation, and it has glutathione because it is a very good antioxidant. Intraocular irrigating solution you use during intraocular surgical procedures, including those requiring a relatively long intraocular perfusion time. Okay, so procedures like pars plana vitrectomy, phaco, they are all highly dependent on fluid exchange. So you don't want just ringer lactate or normal saline, because they all tend to leave deposits in the phaco probe. Okay, normal saline, what it does is it leads to formation of crystals in the phaco probe that really affects the efficacy of the phaco probe and the sterility. So these are all the reasons why other fluids didn't qualify and BSS plus does. Right. Which of the following does not characterize cataract or does not have a characteristic cataract? Juvenile diabetes, leprosy, myotonic dystrophy, and Wilson's. So I think we've discussed in detail about Wilson's. It does have sunflower cataract. Myotonic dystrophy has Christmas tree cataract. Juvenile diabetes has snowflake cataract. So the answer is leprosy. Oh yeah, so this is about it. This is Christmas tree cataract in myotonic dystrophy. Okay, and this is the sunflower cataract, and this is the snowflake cataract. Sunflower and snowflake. Great. So these named characteristic, like one more is oil droplet cataract. Okay, oil droplet. This is seen in galactosemia, right? So named cataracts are always a fancy type of question that the examiners would want to ask. So just making a mention of them here. Okay. Great. Let's move on to the another. Which of the following drug acts via increasing the trabecular outflow pathway? So this is a very tricky question. See, decreasing the IOP by increasing the outflow and decreasing its production. This is the main funda, right? So here, if you see, first we have to, any question like this, first understand which group they belong to. This is beta antagonist. Brimonidine alpha agonist. Bimatopros prostaglandin analog. So bimatopros is going to go through uveoscleral pathway. So this is not our answer. Now here timolol and brimonidine, their primary action is to act on the ciliary body vessels, vascular action, and decrease the production of aqueous. So it leaves netarsudil out. What is netarsudil? Is Rho kinase inhibitors or ROCK inhibitors. We will see that. So AGM, like I said, is important topic. They've asked it in different ways. So first group are myotics, which are directly acting. Okay, they are going to open up the trabecular meshwork like pilocarpine, but it is not commonly used as a first line treatment here because it can lead to irisis and it can lead to blurred vision due to induced myopia. So these are the two important reasons why that's not common as a AGM, anti-glaucoma medication. Beta blockers, yes, one of the first lines before latanoprost or bimatoprost came into. So timolol, very common. Okay, and now timolol had some systemic side effects. Okay, so to avoid that, we have more beta 1 selective uh, beta antagonists. So that is cartiolol and betaxolol. Okay, however, they still have this blepharoconjunctivitis, stinging, etc. Carbonic anhydrase inhibitors are even going to act on this enzyme we discussed and decrease the aqueous formation. See here, okay, alpha 2 agonist, again aqueous formation. But alpha 1 agonists are dipivifrine, adrenaline. They are not commonly used because they have a lot of things like deposition of adrenochrome, conjunctival hyperemia. Nowadays, alpha 1 agonists are not employed at all, I would say. Next come prostaglandin alpha 2 alpha and analogs. Okay, so all of them are going to act through uveoscleral pathway, and remember commonly used ones now are like travoprost and trafluprost is coming up. Bimato and travo are commonly employed these days. However, they have their own set of adverse effects. Important students, see, they have iris pigmentation, darkening of periocular screen, okay, conjunctival congestion. I'm not even joking, these are significantly complained by patients within a month of their use. However, they settle with time, no doubt. Growth of eyelashes, okay, this is also important. Okay, this is called as trichomegaly. Okay, so last group which are new in the market are netarsudil, which are ROCK inhibitors. Okay, so they are also supposed to have a good effect on the cornea. Okay, corneal endothelium is also said to act better with netarsudil, Rho kinase or ROCK inhibitors. They are called as Rho kinase inhibitors. Okay, so this is about the summary of anti-glaucoma medications that I wanted you to know. Okay. Okay, now let's move on to a little bit of ocular oncology. Which of the following is the most common tumor to be associated with retinoblastoma? Remember, RB gene, we learned it in pathology, left, right, and center, is also implicated in osteosarcoma. Okay, why is this important? I will tell you at the end of this question. Okay, so RB you cannot clear in one of the INICT or NEET without knowing about retinoblastoma, because it is so much important from different perspective, pathology and even ophthalmology. If you talk about ocular oncology, the first tumor that comes to anybody's mind is retinoblastoma, right? So arising from embryonic rest cells, okay, causes 5% of childhood blindness, okay, 90% get diagnosed before 5 years of age, okay, it is because of 13q14 we know in detail, okay. What I want you to focus on is the most common sign, which is leukocoria, okay, appearance of white eye, okay, especially in photographs. Other things which can cause leukocoria is also there, astrocytic hematoma, toxocara, but most common cause of leukocoria that you should be concerned about is retinoblastoma, right? So whenever you have a doubt, okay, you have to first do a B scan. Why is it a B scan? Because remember, CT is again exposure to X-rays, and these are children we are talking about, okay. The more you expose them to X-rays, the increased risk of radiation exposure. I'll tell you again, we'll come back to this, okay. So intraocular calcifications and vitreous seeding are virtually pathognomonic findings. In case you do CT, intraocular calcification, okay, calcium, go for RB. CT scan of orbit and MRI of the orbits and brain detect intraocular calcification, evaluate the optic nerve for tumor infiltration. RB is one condition where you do enucleation, okay, and you take 1 centimeter of optic nerve, because once this part of optic nerve is involved, there is a high chance that this has gone for metastasis, okay. So if the pineal gland is involved, it is called as trilateral retinoblastoma, both the eyes and the pineal gland, okay. Now children with retinoblastoma, they have, if it is unilateral, okay, and confined to the retina, they have good prognosis. That is why you need to pick it up early. Now local therapies are cryotherapy or laser therapy, okay. However, placing a radioactive plaque outside to the globe, it's called as brachytherapy. Why am I talking about this? Has a lot to do with the question we have. When you give brachytherapy in a patient who has a hereditary retinoblastoma, that is, if it is there in the family, RB, okay, gene is there, you give brachytherapy, they have a risk of developing secondary osteosarcoma of orbit. We just saw, right, RB is predisposing to osteosarcoma. So you give them brachytherapy, because of increased exposure to radiation, they can actually develop secondary tumors at the bony orbit. Clear? So this also important. Which of the following is not used as a chemotherapy in RB? Vincristine, etoposide, carboplatin. VEC, you must know. Okay. So what are the indications for enucleation? No salvageable vision, neovascular glaucoma. See, even this can cause neovascular glaucoma. Inability to treat the examined eye, inability to examine the treated eye, okay, and suspicion of extraocular extension. So these are the reasons why you would want to do an enucleation in such children. So again, students, this is just touching upon RB, but retinoblastoma is a topic that you must know in detail from even UG perspective for NEET PG. Okay. Right. Let's move on to conjunctiva now. Pseudogerontoxin. Okay, this is also called, what is gerontoxin? Then we are talking so much about pseudo. Gerontoxin is the other name of Arcus senilis. Because the pseudogerontoxin looks very similar to gerontoxin, it's named as pseudogerontoxin, and it's called as, it's the Latin thing of Cupid's bow. It looks like a bow. Okay. Of course, it is classic of vernal keratoconjunctivitis. Okay, not in choroidal melanoma, not trachoma, not retinoblastoma. It resembles a small segment of arcus senilis or gerontoxon, and hence it's called as pseudogerontoxon. Individuals with limbal, vernal or atopic keratoconjunctivitis. It's often vernal keratoconjunctivitis, not even atopic. It is because it often the only clinical evidence of previous allergic eye disease. So see this image, you see VKC, okay, VKC, two types, palpebral, limbal. In palpebral, you have cobblestone papillae, all those. In limbal, you have the pseudogerontoxon. And Horner-Tranta spots. See this image? These dots you see here are swoops, Horner-Tranta, and it looks like arcus senilis. Can you see? But you don't get arcus senilis in children, right? That's called as arcus juvenilis, but this is not that. Okay? Right. Next question. Which of the following is true about glaucoma? So now we are again touching upon glaucoma. Early and specific feature is isopter contraction, barring of blind spot. Static perimeter, intensity of stimulus is kept constant while it is moved. Visual field defects to be associated with glaucoma only if it is associated with ONH changes. And kinetic perimeter is best for monitoring visual field changes in glaucoma patient. Right. So this is purely got to do with visual field testing. Okay. It is also called as perimetry. Remember, option C is true. Okay. So visual field defects to be associated with glaucoma only if it's associated with ONS changes, because remember, you don't wait for the visual field changes to happen to diagnose glaucoma. Okay. Glaucoma has to be picked up before obvious visual field changes happen, because by the time visual field changes happen, around 60% of your neurons are already damaged. Let's see. Glaucoma is a chronic progressive optic neuropathy most commonly associated with an increase in IOP. It is associated with field defects, raised IOP and optic disc changes. This is the classic triad. Early features of VF changes are isopter contraction and barring of blind spot. We just saw. However, they are not specific for glaucoma. We know that, right? So, these are the early changes of field changes of glaucoma in a particular order. First A is Jerum's scotoma, which is actually in the Jerum's area, which is around 15 to 20 degrees around the point of fixation. Okay. Then B is superior paracentral scotoma. C is sedal scotoma. Can you see? Okay. D is Jerum's arcuate scotoma. Then comes E, which is double arcuate scotoma or ring scotoma here. And then once that is done, you see a Rowan's nasal step. Can you see this? This is called as nasal step. Then tubular field, and finally only temporal island of vision. So the progression of visual fields is actually happening in a particular manner, and it is important for you to know them at least one or two, not one or two, the named ones here, sedal scotoma, Rowan's nasal step. These are all classical of glaucoma. Okay, so you can't miss glaucoma after having seen these visual field defects. So go through the visual field defects of glaucoma once again and know the right order in which they happen. Okay, that makes a lot of meaning when you do perimetry in patients with glaucoma, because remember, you may be asking, when you don't wait for visual fields, then what is the point of knowing all this? Glaucoma progression is often tracked by repeating fields at regular intervals of 3 to 6 months. So when you see that there are newer findings like these that are appearing after every visit, that means the tapering of the, the titration of the medicines have to be done, and increase in the dosage is necessary to bring it to lower teens and maintain the IOP at lower rate to avoid ocular damage. Clear? Next, which of the following is not seen in keratoconus? Wow, we have another all except question. Irregular astigmatism, by now we must know from like the back of our hand that it is a part. Munson sign, scissoring reflex. Herpes striae is not seen here. In fact, herpes striae is seen in congenital glaucoma. Herpes striae. Okay, they are all horizontal folds which are seen in because of excessive stretching of cornea. We saw right in ophthalmos. So that is where you see herpes striae. So it is, we saw progressive, we already know this. It is differentiated into mild, moderate and advanced cases. Now we'll see the clinical features which we have not touched upon in the previous question. We saw about treatment and all that. Moderate to high myopia, and we know it is curvatural myopia, right? They can have irregular astigmatism. Okay, very important. Clinically, what are all the signs? Inferior steepening, central corneal astigmatic steepening. Yeah, these are all topography findings. Okay. Now, presence of one or more corneal signs of keratoconus, that is Vogue striae. Okay, Vogue striae are vertical. Okay, they're not horizontal like herpes striae. So they actually, the answer should be Vogue striae. Instead of that, they've given herpes striae, and that is the odd one out. Clear? And Fleischer's ring. What is Fleischer's ring? So Fleischer's ring is actually deposition of iron at the base of the cone in keratoconus, which is best appreciated using blue filter, cobalt blue filter. Okay. So beyond a point when hydrop starts to set in, you have corneal scarring. Okay. Scissoring or the oil drops, let's say, I'll explain this. So when you do retinoscopy, I told you, right, with movement against the movement, here, because the cornea is irregular in shape, the light will go in X fashion, like this. It is not uniform. Even if you tilt it also, it will not be uniform, it will go in X fashion. That is called a scissoring. Can you see this action? That is scissoring of retinoscopy reflex. Oil droplet sign is the base of the cone. I told you, the part of the cornea is what is conical in nature. So the base of the cone is oil droplet. So there you will see a margin of the cone, or the bottom of the cone, the margin like an oil droplet, because that is refracting different from the rest of the cornea, correct? And Munson's sign is this, because the cornea is very conical, you look down. Okay, that will push the lid, lower lid, further down, and that is called as Munson's sign. It will be like a V. Okay, so these are all named things you must know about keratoconus. Okay, so these are the different patterns, okay, which you see on topography. Just for your information, this is how topography looks. So all these patterns can actually be a part of keratoconus. Okay, last question for the day. Corneal hydration is maintained by which of the following? Stroma, aqueous humor, epithelium, endothelium. And the answer is endothelium. Remember, endothelium is studied using specular microscopy. So endothelium, two things are looked into. One is the count, the other is the size. Many more things are there. I'm just trying to keep it simple for you. So when there is decrease in the number, okay, that leads to compensation of the remaining cells by increasing in size. That is called as polymegathism. Okay, when there is increase in the size to compensate for the function. Beyond a point, it loses its function and allows for fluid to enter, and these pumps in the endothelium, they are reduced in number because of many pathologies. One of them is Fuchs endothelial dystrophy. It's a corneal dystrophy. Okay, one more reason is in cataract surgery. Okay, if you meddle a lot with the endothelium, leads to endothelial cell loss, and that results in PBK, pseudophakic bullous keratopathy. Okay, which is again because cornea getting hydrated because the endothelium is damaged and a lot of fluid has gone into the stroma, and that leads to bullous changes. That's called as pseudophakic bullous keratopathy. Okay, the corneal endothelium is primarily responsible for maintaining the hydration and transparency. Remember, this is the normal endothelial function which has an active pump. Can you see here? It has tight junctions and this active pump which helps in pushing out the fluid if at all that enters past the tight junctions. Whereas in case of a problem like endothelial dysfunction or damage to the cells, there is a lot of edema because the fluid that goes in cannot come out by itself. Okay, there's nothing to prevent it from going in and nothing to push it out. Clear? So this is what I wanted to cover. I hope I've touched upon the different topics of which are commonly asked in our subject of ophthalmology, and most welcome to ask me any doubts if you have in the chat box. Okay, I'll try to reply. So keep studying, keep at it hard. I know the exam is postponed, but one day you'll all come out in flying colors. All the very best.